All right, some more people are showing up, but I'm just going to ask a quick question. If you guys were going to take the NCLEX tomorrow, theoretically, on a scale of 0 to 10, how prepared do you feel, or how confident would you feel that you would pass on a scale of 0 to 10? I'm going to let y'all answer, but we got some more people coming in from Malawi, Tanzania, Canada. That feels like as foreign to me as Nigeria or Malawi does, I'll be honest. I'm in Texas here. So excellent. Waiting for some numbers for how prepared you guys are. Okay, 6, 7, 8, 5. Good. All right. So we got a range of scores, mostly 5 to 8. Some people a little bit lower. So Tiana said that she's 5 with a crying face. And I want to say something about that. A lot of people go in and they take the NCLEX and then they leave and they say, I'm sure I failed. It was so hard. I'm sure I failed. And because NCLEX is an adaptive test, that means however prepared you are, whether I'm taking it and I should theoretically be pretty prepared, or you're taking it or one of your professors, the computerized adaptive testing gives you a question that it believes you have a 50% chance of answering correctly. So that means that you are going to feel like it's a really hard test and you're going to feel like you were guessing when you're passing, right? So hopefully that'll give you a little bit of reassurance that when you're actually sitting there taking the test, if it feels really challenging, that's a good sign because that means you are getting passing level questions. So don't let it trip you up, just keep going. So awesome. All right, so we've got some people coming in. We'll go ahead and get started. So thanks again for joining us today. My name is Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp, and I've got a moderator from our team helping out in the chat. So between the two of us, we will try to answer all your questions and address any concerns today. If there's a little bit of a delay, I'm not ignoring you. It just takes a minute for me to see your comments come through on my end. But yeah, so thanks for joining us. We're going to be talking about how to study for the Next Generation NCLEX, and I love helping students pass the NCLEX. I've been in NCLEX prep for about 10 years now, and I hope that these tips that I've learned along the way are going to be helpful to you guys. So, okay, to get started, we are going to look at what the purpose of the NCLEX is, because that's going to help you understand this second point, or what's on the NCLEX. We're going to look at those top 5 client need areas that are covered on the NCLEX. And then we're going to spend most of our time talking about how to study. And just to give you a little hint, the secret is no secret. It's just to practice, 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 practice. And so we are going to spend some time practicing the biggest section on the NCLEX. So what then is the purpose of the NCLEX? And I want to ask, how many of you guys have heard that the NCLEX is a safety exam? And I think probably most of you who have heard that before, right? That the NCLEX is a safety exam, and that's because it's true. So the goal of the NCLEX is to protect the public. So it might be for you to get your RN, to start making money, paying off those student loans, but at the end of the day, the NCSBN wants to protect the public. And so the NCLEX is designed to make sure that by passing it, they can say you are a safe entry-level nurse. And they define entry-level as a generalist nurse within that first 12 months of practice. And this is general practice, so not somebody who's super specialized in like the NICU or the cardiothoracic ICU. This is something that if I, who only have adult ICU experience, was floated to the NICU, I would know the basics, right? How to recognize acute changes in clinical status, how to protect their skin, keep them clean, things like that. So we're looking at generalist practice, and that's what we're all about at NCLEX, is helping you focus on what's actually on the test. We're not going to go way into the weeds with stuff that's just nice to know, but you're never actually going to see on the exam. So then what topics are on the test? And you guys might not know that there's actually an NCLEX test plan. So there is an official test plan that has a whole list of topics that disclose what is on the test. And so this is based on a survey of actual practicing nurses. And every 3 years, they conduct a survey, and practicing nurses are asked, within your last shift, how often did you do each of these tasks, and how important are each of these tasks, and then how much clinical judgment is required for these. So you can imagine things like hand hygiene, checking 2 patient identifiers, going through your 10 rights of medication administration. Those are going to show up a ton on the test because they are really important. They require a lot of clinical judgment, at least your 10 medication rights does. And they are something that we do all the time. So you're going to see a lot of safety infection control, management of care, where we're prioritizing between tasks because we always have more to do than there is time to do it. And then, of course, you're going to see a lot of emphasis on things like pharm, because could be really harmful to our patients if we don't know how to safely give medications and monitor for their effects. And so we're just centered on what is going to make you a safe practicing nurse. And so the top 5 client need areas actually make up over 70% of the exam. So that's where we want to focus our time, right? It's going to give us the biggest bang for our buck. And so in a 100-item NCLEX, which this is about the average length of an NCLEX, the number 1 is going to be clinical judgment. So 25% of your test score performance is going to come from your ability to demonstrate that you can use clinical judgment or critical thinking in the scenarios in the question or the case that's being presented to you. And so the NCLEX test clinical judgment in the form of those case studies that we all know and love. And I'm going to ask you guys to let me know in the chat if you had the opportunity to actually practice with case studies during school, or if you're kind of new to Next Gen cases. And so if you haven't played with the NCLEX Bootcamp Next Gen cases, students say they look more like the real test than anybody else's. So I really encourage you to check them out. But yes, clinical judgment, that's about a quarter of your test. And then management of care comes next with things like prioritization, delegation, assignment, pharm and parenteral therapies, like we talked about. This can be really harmful if we do it wrong. So we want to make sure we're keeping our patients safe with the medications we're giving them. And then physiologic adaptation, that's your general nursing process with most common disease processes and problems. And then, of course, safety and infection control. And so today we're going to spend time looking at clinical judgment practice, because this is what you really need to nail to pass your NCLEX. But if you know that you struggle with some of these other areas too, do not worry. We've got plenty of practice for you. And in fact, we even have our new NCLEX cheat sheets that are available for free. And if you guys stick around till the end, our moderator is going to leave a comment for you to help show you where you can go to download a couple cheat sheets for free, including some of our popular ones, which are our prioritization cheat sheet and our delegation and assignment cheat sheet, because the new NCLEX is not as simple as ABCs, right? So we're going to help you with everything you need to know to pass. So when they do test clinical judgment, they use this 6-step clinical judgment measurement model. And this is basically just the 6 questions in a case study. And so you might not be familiar with this, but you've probably seen the nursing process before, ADPI, and this is really similar. So we assess or figure out which of these cues is most important. We diagnose or analyze what could it mean. We figure out where do I start and what solutions or actions can I take to address that priority problem. We actually take that action, do the thing, and then evaluate, did it help? And so then how to study? And like I said before, the answer is just practice. And so why and how do we practice for the NCLEX? And this is because practice makes perfect, right? This allows you to actually apply your knowledge from school in the same way you're going to be using it on the test. Right? So if you were a basketball player and you were trying to practice your free throws, you wouldn't go spend hours practicing dribbling up and down the court, right? You would need to practice free throws. You need to practice in the same exact way that you're going to be using the skill. And in this case, the skill is answering questions on the NCLEX. So you want your questions to look just like the NCLEX. So we've made sure of that for you here. And feel just like the NCLEX and ask about the same content. And so that familiarity is going to build your confidence, it's going to reduce your anxiety, so that by the time you actually sit down to take the test, it's going to feel like just another bootcamp practice test, right? And it's going to expose you to the high yield topics that are going to come up over and over and over. And you guys have gone through our case studies, probably saw there all the time we're using words like perfusion. We're pointing out which assessment findings or interventions are going to be related to problems of perfusion or oxygenation or airway. And so you're going to get familiar with these high yield topics and prepared for the test. And remember that every question is a learning opportunity. So whether you get it right or wrong, that rationale is there for you to understand the why. Why did I get it right or wrong? Why would this answer have been incorrect? So we encourage you to take the time to read the rationale for every item that you answer, and then you can even use our tagging system to keep track of the ones that you know you need to review a little bit more. And then it's always a good idea to be structured. So based on when your testing date is, you can follow a study schedule. And we do have 1, 2, and 3 month study schedules for you that give you day by day what questions to practice, what cheat sheets to review, when to take a readiness assessment, and how to incorporate all those pieces into your study. And our moderator is going to leave that in the comments for you so that you guys can go check out our study schedules as well. And then you want to track your performance over time. It's okay if you're, performing a little bit lower than everybody else, as long as you're able to see that you're consistently improving as you go. And that's the normal progression through our question bank. And then, of course, you want to prioritize high yield content, so not spending too much time on stuff that's really overly specific and is only going to help you answer a couple questions. You want to spend your time reviewing stuff that you're going to be tested on a lot. And remember that number one client need area is clinical judgment. So we are going to be focusing on clinical judgment today. And on the NCLEX, that is going to be in the form of the case studies. But just to save everybody some time today and prevent us from having to read through lengthy case studies, we're going to look at 6 items that test those 6 clinical judgment steps the same way that you would see them in a case study. All right, so first, recognizing cues or figuring out what's most important here. And so we've got this sample question to look at. The nurse is caring for a client with severe COPD. Which of the following findings would require immediate follow-up? And when the NCLEX asks you this, what they mean is, which one of these is an unexpected abnormal finding? Because somebody with COPD, even when they're completely stable, they're not going to have a perfectly normal assessment, right? You're going to have several abnormal findings, and you have to exercise your clinical judgment to figure out what can I just document and what do I need to act on. And so let's consider each of these. Lower extremity edema, paradoxical respirations, an increased hemoglobin level, or a pulse ox reading of 88%. And I see a couple of you dropping in 2, as well as some other answers. All right, so let's talk about this. Quick review of COPD. So COPD is either going to be chronic bronchitis or emphysema, and both of these will result in kind of air trapping and limited airflow. So with chronic bronchitis, smoking is going to cause chronic inflammation and mucus production and narrow the airway, so we can't get air in. And with emphysema, it damages the alveoli so that when you breathe out, this collapses in on itself and you can't get air out. And most patients with COPD have an overlap of both of these. So this is our issue with COPDs. We can't get air in and out. A couple of you said 2, 4. All right, so let's talk. For lower extremity edema, why would a patient with COPD develop lower extremity edema? Okay, a couple of you said 1, 2. So do you guys remember what cardiovascular complication might happen from COPD? And there are several that might just be related to smoking, but the big one, right, is if you have too much pressure and stress in your lungs, then that's going to strain your heart and can cause heart failure, right? And so you could see some signs of heart failure. But this is describing lower extremity edema, which is basically you've got swelling in your lower extremities. What would I do about this if I was immediately going to follow up on it? I would just elevate their legs, maybe, right? It's not saying that they have pulmonary edema, that they have crackles in the lungs. It's just saying lower extremity edema. And Keep It a Secret 15 says right-sided heart failure, and you're right. So yes, that would be the right side of the heart that's strained because that's what side pumps to the lungs. So this is not a normal finding, but I don't know that I need to immediately do anything about it. The next, paradoxical respirations. Several of you guys guessed this, and paradoxical respirations is when you normally if you don't have paradoxical respirations, you breathe in and your chest rises and you breathe out and your chest falls. When you see somebody with paradoxical respirations, that means you're seeing the opposite happening. They breathe in and their chest wall kind of sucks in, and then they breathe out and it pushes out. And so that is because they're working really, really hard to breathe. And that is a sign of impending respiratory failure. And so if you guys see paradoxical respirations in any patient, whether they have COPD, whether they have asthma, this is always a warning sign for respiratory failure, and I do not want to ignore it. So I'm thinking that's going to be my answer, but let's check the others just in case. Then an increased hemoglobin level. So do you guys remember why somebody with COPD might have an increased hemoglobin level? And it has something to do with the fact that they've got low blood oxygen. Gina said COPD patients typically have a lower oxygen saturation, and that's true. These patients are so chronically hypoxic that in an attempt to kind of get more oxygen delivered to the tissues, it thinks, oh, I just need more hemoglobin. If I just make more hemoglobin, then I can carry more oxygen to the tissues. And that's why they will have something called polycythemia vera, or they will actually have an increased hemoglobin level, and it's a compensatory mechanism. So on the NCLEX, do not be tricked. They are not going to have anemia, right? They're going to have polycythemia. So this is an expected abnormal finding, but it's also chronic, and it's not something I'm going to do anything about. So we can omit that one. And then a pulse oximetry reading 88. Gina is correct. They typically have a lower oxygen saturation, like 88%. We don't want to go overboard with oxygen on these patients. Instead, we want to titrate for a pulse oximetry to keep it above 88 to 92%. So this is a safe range. It's not something I would do anything about. So you guys are right. Most of you guessed paradoxical respirations, and that is the thing that I would immediately intervene for. And as you can see, only about 57% of our users in the bank, and I think several thousand of them answered this question. So only about 60% of them got it right. And so you guys who got it right are ahead of the curve. And well done. If you didn't, now you know, and you can just review our COPD cheat sheet. Then next, we're going to analyze cues or figure out what could these cues mean for my patient. And so here in this patient, we've got a suspected chronic venous insufficiency. Which of these findings is going to support that diagnosis? And the NCLEX loves to ask about venous versus arterial problems, right? And so we're going to see some findings here that are arterial, some that are venous problems. And when you've got peripheral artery disease, this is when you've got narrowing, usually from smoking, sedentary lifestyle, atherosclerosis, and we can't get blood to the lower extremities. So when you see problems on the leg, they're going to be on the distal most part of the leg because that's where the blood flow is lowest. So when you've got ulcers, they're going to be down here on the toes, the shins, and then you're going to have kind of those 6 Ps of neurovascular insufficiency, the pallor, pain, pulselessness, and so on. Whereas with chronic venous insufficiency, you are going to see these valves are insufficient and they kind of collapse, and so, or they fail to collapse, and so blood is going to pool in the legs. And so that way we're going to see kind of higher up on the leg, you're going to have these issues with the ulcers, and you're going to have a lot of swelling and fluid retention and see signs of fluid retention. So knowing that, absent pedal pulse, is that more arterial insufficiency or venous insufficiency? And I'm going to ask you guys the same thing for each of these, but remember, pulselessness, that is a sign of, okay, Barad says compartment syndrome. Yes, that could be a sign of compartment syndrome, the absent pedal pulse. It's a sign that we're not getting enough blood flow to the lower extremity, whether that's because of compartment syndrome or something else. But in this case, it's not a sign of venous insufficiency, it's a sign of arterial insufficiency. Then the intermittent leg cramping. Well, this also happens with arterial insufficiency because when you're out walking, using up all of that oxygen in the muscle, it can't get enough blood flow back to the muscle in time, and so it starts to cramp and get ischemic. So that is also an arterial finding. Then ulcers on the toes. Remember, when you have ulcers with arterial insufficiency, it's going to be at the most distal part of the foot where we can't get enough blood flow. So that's also an arterial problem. Then a brown discoloration. So we didn't talk about this, but you guys know that all the previous 3 were related to arterial insufficiency. So I think it's got to be this one, right? And let's talk about this. So why would I see brown discoloration in somebody with chronic venous insufficiency? And so this is an interesting complication where basically because that blood is pooling in the lower extremities, Normally, as those blood cells return to the body and die, they would be recycled in our spleen, but instead they die in lice. And what's inside of a red blood cell but iron, right? And so all that iron just gets deposited into the skin, hemosiderin deposits, and it creates this brown discoloration. And I like to think of this as being like it's rusting, right? Like iron sits out, like the blood is pooling and it just rusts. So this is a sign of venous insufficiency. And most of you guessed this correct, so well done. And again, only about half of our users got this right, so you guys are doing excellent today. Then okay, prioritizing hypotheses or figuring out where do I start. And I'm gonna ask you a question. So let's say you are in the neuro ICU and you are getting a patient from the OR who just had a craniotomy. What is the number one complication that you're worried about and that you're thinking about? What would you prioritize? Let's assume, they're coming on the ventilator, so they have their airways intact. We're worried about a complication from craniotomy or any kind of head surgery, head trauma, and that's going to be an increase in ICP. And Joseph got it. Joseph R. got it. Increased ICP. Yes. And so in this next question, we are going to figure out what assessment do I want to prioritize in this plan of care for this client who's at risk for increased ICP. Good. Mai and Selema, you guys got this as well. Well done. So these are all of these options here are part of a normal neuro assessment. I'm going to assess all of these things. But as far as what I prioritize is a different story. So the Babinski reflex, that's where you stroke the foot, right, and watch which direction the toes go. That is an important assessment, but it's also more related to a spinal cord problem, not a problem of increased ICP. So this is useful, but I'm not going to prioritize it. Then the presence of a headache. Well, would you have a headache with increased ICP? Yeah, I think you would, right? But wouldn't you also have a headache because you just had brain surgery? Yes. So if they have a headache, that doesn't really tell you necessarily that they have increased ICP. It just might tell you that they have had brain surgery, right? So this might not be as useful. We'll hang on to it. Then pupil size and reactivity. You guys have probably heard that the pupils are the windows into the brain, and that is true. You will see pupil changes when you have swelling in the brain and it compresses that optic nerve, but this is a late sign. It takes a really long time for pupil changes to develop, and by the time you're going to see a blown or fixed pupil, it might be too late to take them back to the OR and insert a drain. But this final one here is what most of you guessed, and you are correct. The LOC is going to be your earliest and most sensitive indicator of changes in ICP. So that's the first thing you're going to notice when your patient's ICP starts to go up. They're going to be less responsive, lethargic, drowsy. You might have to, give them a little sternal rub to wake them up. And so this is what you want to prioritize: going into the room, saying their name, making sure they can wake up and talk to you normally. So we are prioritizing that level of consciousness assessment. And well done. So this is a need to know, and I think most of you, almost everybody got this one right. But that is a need to know for the NCLEX. So don't miss this one. Level of consciousness is what you want to assess for changes in ICP. Then next, generating solutions, or figure out what can I do about this problem. So here we have a patient who just underwent coronary angiography via the femoral artery. So what condition is this done to treat? And I think you guys should all know this one, but who would come into the hospital and get an emergent coronary angiography? And while I'm waiting for y'all to answer, we'll read on. So we're asked, which interventions do we anticipate in the initial post-procedure care for this client? And this is a select all that apply. And here's an NCLEX tip for select all that apply questions. You want to treat each option as if it's its own true or false. All right, Christina got it. Christina says ACS, that's correct. So if you've got acute coronary syndrome, we need to thread this catheter up. The cardiologist will do this to the site of the blockage and place a stent to open it up and restore blood flow to the heart. Francis says heart attack in all caps. Yes. Very good. Oops, just kidding. Don't look at the answers, guys. So do we want to place them on a fluid restriction? True or false? And so I hope, and it looks like some of you have selected this one. Now remember, when we give when we go up and visualize this, they're going to need to get contrast dye. And there's one organ in the body that hates contrast dye. And I bet Christina knows. She says no to this one. But yeah, it's the kidneys, right? If you give too much contrast and not enough fluids to flush it out, you can develop contrast nephropathy or kidney failure. And so yes, Faustina, false. You're correct. This one is false. We do not want to place them on a fluid restriction. We want to push fluids either orally or through IV or both. Good. Then monitoring the puncture site for swelling. Yes, because not only did we just puncture the femoral artery, which is one of the largest arteries in the body, but they also get aspirin and heparin and a bunch of anticoagulants for this procedure. So they are at high risk for bleeding. So we're going to go in there, look at the groin site and assess it for swelling, right? And so that is something we want to do because we're worried that they might bleed out into their leg or into their abdomen where we can't see it. Then placing them on continuous cardiac monitoring. Yes, I'm going to assume you guys know this because we talked about the fact that it's for a cardiac issue, either coronary ischemia or an acute coronary syndrome. And so there's always the risk that that stent can close or collapse and we would lose blood flow to that part of the heart that we just restored it to. So that is correct. Then assisting them up to the chair to prevent atelectasis. This is number 4, and it looks like about half of you or maybe a quarter of you are guessing this one. And so we do, in general, want to mobilize our patients after some kind of procedure. But in this case, remember, our priority is we're worried about bleeding at this site. And so if they bend at the waist, that's going to put a lot of pressure on this site and can risk life-threatening hemorrhage. So they need to stay totally flat for, depends on your hospital, but on the NCLEX, it's going to be 4 to 6 hours. So that is a long time to stay totally flat. And they're going to need some reassurance for how important it is. They need to keep that leg straight. So no, we're going to wait until they are off of bed rest to implement any kind of ambulation or getting up to the chair. So it's not this one. Then palpating their bilateral pedal pulses every 15 minutes. Yes, so remember, we're worried about bleeding. If we're seeing bleeding from this femoral site, that means the blood is going to go somewhere other than their pedal pulse. So when we palpate, we're going to have a strong pulse on the unaffected side and a weak pulse or absent pulse on the operative side. So this is definitely important. All right, so we're going to give IV fluids, not restrict fluids, keep them totally flat, place them on cardiac monitoring, and we're going to watch for bleeding by checking their pulses and looking at that groin site for bleeding. Very good. Well done. All right. Then we're going to take action or actually implement the action that we know the patient needs. So here we've got diagnostic results for a patient who became unresponsive and has no palpable pulse. They've got gasping respirations. So we look at our diagnostic results here and we've got this EKG tracing. So what is y'all's interpretation of this rhythm? I'm going to let y'all kind of trickle in your answers for that. But we're being asked, which of the following actions should the nurse take? Should we initiate chest compressions, give IV push atropine, obtain a 12-lead electrocardiogram, or deliver rescue breaths? Several of you are answering 1. Shimaja says NCLEX can be really tricky. That's because nursing practice can be really tricky, and I know it. And so we want to give you lots of practice with these kind of tricky scenarios. All right, Marky says PEA. All right, start CPR. So most of you want to start CPR, and I am glad. I would definitely want you as my nurse if you would start chest compressions for this, because there's really only one piece of information in this question that you need to answer it, and it's actually right here. No palpable pulse. So it does not matter what your monitor shows. If your patient doesn't have a pulse, that means this is a pulseless rhythm, whether it's PEA, pulseless electrical activity, or VFib or VTAC. You can have all the electricity you want, but if it's not actually generating a cardiac contraction and a pulse, this patient needs CPR. And it's important to do this quickly because that's going to pump blood and restore blood flow while we're trying to give epinephrine, shock them, or do whatever else to correct the underlying cause, which in this case would be your H's and T's, right? So yes, we are going to initiate chest compressions ASAP because every second we delay it, their brain tissue is dying, right? So very good. I'm glad you guys got this one right. But why would we fall for some of the others? Because you're right, it is tricky. This is a tricky situation to be in. So giving atropine, that would be appropriate for bradycardia with a pulse, right? If this patient was kind of symptomatic, dizzy, had chest pain, and then they're talking to us and we put them on the monitor and we see this, that would mean we would need to treat this as symptomatic bradycardia, and giving atropine or pacing, actually putting them on a pacer, will correct that and get the heart rate up. But this is not that problem. This is pulseless, right? So this is incorrect. Then getting a 12-lead EKG. Again, we already have all the information we need. It doesn't matter what the EKG shows. We know that they don't have a pulse, and that's all we need to know. Assessing first is not always the right thing to do on the NCLEX. That might have worked with the old NCLEX, but you guys have been told, oh, on priority action questions, always assess first. Sometimes you have all the information you already need. And in this case, we do. So this would just delay care. Then delivering rescue breaths. If they had gasping respirations and a pulse, then we would probably give rescue breaths, right? We would maybe, in the case of an opioid overdose, just use the bag valve mask, give some Narcan, but again, this patient doesn't have a pulse, so CPR is our priority. Very good, and 55 or so % of our users got this right, so you guys are just all ahead of the curve. Okay, then evaluating outcomes or figuring out, did it help what I did for them, or in this case, what I taught them? Was my teaching effective? So this patient's undergoing a total laryngectomy, or we're actually surgically removing the voice box, right? And so which of these statements by the client would require follow-up? And so the larynx, remember, is here. It's the voice box, so it is in the throat. It is a throat surgery. And they're going to go in and actually remove the voice box. And so which of these statements would require follow-up? And what that means is which of these has the patient said incorrectly, and we need to either revise teaching or get the healthcare provider to come provide them some more education about, or what. So I will have to practice using a mirror to care for my stoma. Well, yes, that is important. We really want these patients to care for their own stoma before they leave the hospital. This can be a very emotional surgery. They might lose their voice. I mean, they will, right? And they're going to change their body image. And so it's important that they maybe use a mirror, and we kind of coach them through getting comfortable practicing caring for the stoma, just like you guys are getting comfortable answering tricky NCLEX questions. So this is correct. It does not require follow-up. Then when I'm discharged from the hospital, I won't need the feeding tube. Yeah, we're not going to be, taking out their tongue. They shouldn't have any issue with swallowing. This is just their voice box. We're omitting totally different pathway. The air travels in and out of your lungs to generate your voice, not your stomach, your esophagus. So they should be able to chew and swallow just fine. My husband's bought me some scarves to wear over the stoma. And this is also fine, right? As long as it's not like dirty or too tight, then there's no issue with that. And that can be really helpful in helping them adjust to their new body image. Same thing after like a thyroidectomy. And then I see that Marky says larynx is a voice box. It will not return to normal. And yes, that is correct. If the patient says, after this surgery, my voice is hoarse but returned to normal, we want to make sure they understand before they go into this surgery that no, we will be taking their voice box out. They will not have a normal voice. And what this is showing here is a voice prosthesis where basically you can redirect the airflow temporarily and create this kind of digitized sounding voice from the airflow. And so this is part of informed consent, right? That the patient would understand the risks and benefits of the surgery. In this case, that the outcome would be they would basically be cured, hopefully, of whatever laryngeal cancer, but they won't have a normal voice. So this would require follow-up. And you guys are right. And this was a trickier one. 41% got this right. So you guys are doing great. So excellent, everyone. You guys did so well. Great job. And I want to take a second to ask if you have any questions. So please leave your questions in the chat. We'll take a second or two and just kind of answer any questions. But in the meantime, you might go check us out on our socials here. Subscribe here to our YouTube channel if you haven't already. Please join our Facebook study group where we all encourage each other who are studying for the NCLEX or have just passed. And then I will take a second to answer your question. So yes, Gina, this procedure would be needed usually from laryngeal cancer. So if somebody was a smoker and it's very common to develop cancers in the tongue, the esophagus, the throat, the larynx, and so we can surgically remove that. Good. Christina says, how many more of these will we be doing? Christina, we're going to try and do one of these each week. They're usually going to be Tuesday, Wednesday, or Thursday. And the next one you can actually see on our upcoming live channel. You can set for a reminder. But we're going to try and do these every week to make sure you guys get lots of question practice in. And then how can you stay calm during the exam? So I would say the best thing is to be prepared, right? The more practice that you have answering these questions, the more you're going to feel confident, like you know what you're doing. You're going to have less anxiety. On the study schedules on NCLEXbootcamp.com, we have a built-in day, usually on Saturdays or whatever day works for you, to take full-length practice tests, to actually sit down, put yourself in the mindset of the test taker, treat it like it's the real thing, and just practice sitting down and taking every question as seriously as if you're answering it on the real NCLEX. So you just got to get comfortable being uncomfortable. Anthony says, anxiety can get you the first time for sure. So we want to give you all the practice that you need. Gina, our prioritization webinar is very cool, and I encourage you guys to bring it. Marky wants to know, is there a video for test taking strategy? So we actually have a whole NGN strategy course that teaches you how to think like a nurse, how to think through these questions, and so you can come check that out on NCLEXbootcamp.com. All right. Very good. Stella wants to join the study group. Yeah, so here at on Facebook, NCLEX Bootcamp Official, that's our study group. You can just go ahead and apply to join the group and we'll accept you if you answer the questions. So very good. I think I've got most of your questions. Anything I missed, our moderator is going to come in and answer for you, but thank you again, everyone, for joining us. We hope that those of you who answered, you had like a 3 to 5 out of 10 readiness at the beginning, that we've boosted your readiness by at least a couple of points. And to get you the rest of the way there, please come to NCLEXbootcamp.com and check out all of our other resources for you. So thanks again, and y'all happy studying. My name is Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp. We're also going to have Dr. Courtney in the chat moderating. She's our psychiatric expert, and you probably remember her from some of her lectures that she does here for our webinar series. So we are going to be talking today about how to answer Next Gen NCLEX case studies. And this is going to make up the biggest part of the exam. And you guys have probably heard that Bootcamp is really well known for having excellent high quality case studies and video rationales. And so just giving you guys a little bit more insight today into how to think like a nurse as you answer these case studies. So I'm going to ask you guys to quantify on a scale from 0 to 10, how confident are you in answering case studies on the NCLEX, with 0 being not at all confident and 10 being completely confident. And hopefully by the time that you leave today, you will be bumped up at least a couple more points in your preparedness. So I'm going to be trying to answer all your questions between myself and Dr. Courtney here. If you see me looking off to the side, that's what I'm doing, is I'm just tracking with your comments, but there is a little bit of a delay, so hang with me. And Ajay, the venue in Pennsylvania, it's in Lancaster, Pennsylvania, and you can just search Student Nurse Association of Pennsylvania and we'll see you there. So, all right, we are going to be talking about how to answer next-gen case studies. First, we'll look at the next-gen case study format and then spend most of our time practicing together how to think like a nurse. So first, the case study format. So the big difference between the old NCLEX and the new NCLEX is that they now incorporate this clinical judgment piece, and they test your ability to exercise clinical judgment by giving you these case studies. And each of these case studies is going to be 6 questions long, and each of the 6 steps corresponds to 1 question, and it's a different step in how a nurse thinks. And you might not be familiar with this, but you've probably seen the nursing process before, your ADPI, and these really closely parallel each other. So first, you're going to be recognizing cues or assessing what's most important, because as a nurse, we always have lots of cues coming at us at one time and we can't give the same attention to everything, and then analyzing those cues or diagnosing what it could mean. Then kind of our care planning step where we're prioritizing where we start and then generating solutions for what we can do to address that priority problem. Then finally taking action and evaluating if it helped. So you guys know how to do this. This is just kind of different language for the same thing. So in every case, in every NCLEX, a minimum length NCLEX, you have 3 full-length case studies. So that means it makes up about 25% of your score. So that is bigger than any of the client need areas for the standalones. This is the part on the NCLEX that you want to be most comfortable with, and that's what we're here to help with. And then if you require longer than a minimum length exam, so longer than those 85 questions, you're going to get additional clinical judgment standalones. So those are going to be your Bowtie items and trend items. And we also have plenty of those for you guys to practice with. All right, so thinking like a nurse. The first thing when you actually open a case study is you are going to have lots of data tabs here. And let me show you what I mean. So when you open a case study, you are going to be able to click through your patient's chart, just like in real life, right? You guys might have heard that the NCLEX is vague, and that is true for the standalone items, where you have just a diagnosis, what do you do? So you have only enough information to answer the question, whereas in the case studies, this is a lot more reflective of real life practice where we've got tons of stuff to look at. And so my best tip for you guys to make sure you don't kind of get overwhelmed by all the details and lose sight of the big picture is to really try and picture and envision that scenario closely. So in a second, we're going to read through this together, and I want you to kind of keep in mind this picture that's forming in front of you, because that's going to help you prioritize things correctly, and prioritization is a big part of the NCLEX. Then we're going to think, what is the priority problem here? And then each time the case updates, so say we move forward a couple questions, then maybe the patient's admitted to the hospital. It's going to tell us up here that we've got a new nurse's note, for example, and then we read that update. Make sure you revisit that every time and update that mental picture if you need to. All right, so we're going to practice reading this together. So first, for recognizing cues, we're going to be asked in the first question, what's most important? And the NCLEX can ask that a couple of different ways. They like to say what requires immediate follow-up, or which, however many findings are most concerning, because we can't give the same attention to everything. And so we're going to be looking specifically for unexpected abnormals. Some abnormal findings are expected, right? And don't actually require us to do anything. And then if you're stuck, my next tip is to ask this question for how would I follow up? Because you're going to see that some things that maybe look like priority findings, when you actually think through how you would address it, it wouldn't make sense for that given scenario. So we're going to read this together, and remember what we're trying to answer here is we're looking for the top 4 findings that require immediate follow-up. And if you guys already have an idea based on what's here, please start dropping your guesses, what number options you think the top 4 are in the chat. But we're going to read this together, and I'm going to highlight anything that seems especially important, all right? So for this patient, we've got a 57-year-old male. He's come to the emergency department after feeling short of breath and having a cough for the last 2 days. So visualize this, right? 57-year-old guy, so he's like not yet retirement age. He's short of breath. He's coughing. This has been happening for 2 days. He's been sleeping on 2 pillows, so he's probably upright talking to us, waking up coughing several times at night. Then he's been feeling very fatigued and spends most of the day in the bed or the chair. He appears anxious. We review his history and we find he's got a history of hypertension, hyperlipidemia, chronic stable angina, and diabetes. So this is like cardiovascular disease bingo, right? He's got all the risk factors for heart disease here. He expresses a concern that he can't quite afford his medications. So keep this picture in mind as we move on to our more objective data and the assessment and vital signs, is that he's short of breath, he's coughing, he's got all these heart history factor, risk factors, and which 4 findings require immediate follow-up. And I don't see any guesses yet, so you guys want to wait and see the rest of it, I see. Then we perform our assessment. He's oriented, that's good. We listen to his lungs and we hear crackles. We have an S1, S2, and an S3 heart sound. Our bowel sounds are normal, cap refills normal, pulses are, but we've got 1 plus pitting edema in our bilateral lower extremities. So add to this picture of this not yet retirement age guy. He's short of breath, he's coughing, he's anxious. Then when I listen to his chest, I hear crackles and an S3. And when I assess his extremities, I find pitting edema. So am I worried about, like, what is my priority problem here? If you guys were, say, making a care plan, what do you think your number one, like, nursing diagnosis? And you can keep it loose. Do we have an issue with breathing? Do we have an issue with circulation? Do we have an issue with volume status? So kind of start thinking about this as we go. All right. Vanessa says she's worried about cough, respirations. Nina says shortness of breath, crackles, respirations, pulse. Yes, I agree with several of these things, you guys, because we are going to be looking for those priority problems of airway, breathing, and circulation, of which he has several. So then we get our vital signs. We find his temperature is normal, but his pulse is a little high. His respirations are a little high. His blood pressure is high as well. And then his pulse oximetry is low. So you guys know, and I don't have to tell you, that when we're looking for the top findings, we are going to prioritize any unexpected findings of airway, breathing, or circulation. And so I'm going to go ahead and check off the ones that you guys have said. You've said breathing, so respirations, right? He's breathing quickly at 25 times a minute, where your upper limit of normal is 20, probably as a compensatory mechanism because his pulse oximetry is low. And that's why he's reporting to us shortness of breath. And remember, when we had listened to his lung sounds, we heard crackles. And so if he has crackles in his lungs, there's something there in the alveoli that is going to be blocking that exchange of gas. And so that's likely the underlying problem. And you guys got it. You guessed several of these, but this is how things happen on the NCLEX, is the distractors seemed just as likely to some of you. So let's talk about why these ones would not require immediate follow-up. So those of you who chose the cough, maybe you recognize that this is a respiratory issue, and that sounds a lot like a respiratory issue. Again, so are the others, but when I ask myself that question of how would I follow up with this, what would I do about the cough? Would I give him a cough drop, have him gargle something? There's nothing really immediate that I can do to help his cough, so it's not going to be that one. Same thing with the edema. Maybe this is definitely an unexpected finding. We aren't told that he has any history of a condition that would explain edema, like peripheral vascular disease, varicose veins, where it might be expected. But again, what am I going to do about the edema directly? Nothing, right? Nothing urgent. Maybe I'd elevate his legs, assess for the presence of any wounds from venous stasis, but there's nothing immediate that I need to do when I have the presence of crackles, tachypnea, hypoxemia, and dyspnea. Those need intervention right away, probably at least with oxygen, if nothing else, right? Raising the head of the bed if he's not already sitting up. You guys know what to do. The blood pressure. So the blood pressure is abnormal, but we don't know if this is an unexpected abnormal, right? We're told that this patient not only has hypertension, but also that he's been struggling to afford his medications. So he could very well have just skipped his meds this morning, or maybe he's stressed out because he's in the emergency department. So there's really not anything more urgent about the blood pressure than about these respiratory findings. Now, if it said that he had the worst headache of his life and blurred vision and his blood pressure was much higher, maybe then I would need to immediately follow up on that. But it doesn't say that. It just says his blood pressure is 149/93. That can wait. Then inability to afford his medications. What would I do? Would I consult social work? And maybe at some point before discharge I would, but right now while he's short of breath and anxious, he's not going to hear a word that they have to say. History of chronic stable angina. That is going to give us some clues as to what might be causing his symptoms, but there's nothing I'm going to do to address this specifically. So we're going to prioritize these unexpected abnormal respiratory findings of crackles, that's causing a hypoxemia and dyspnea, and then a compensatory tachypnea. And we're right. And you guys will see here that in our question bank, the average score was only 1 out of 4 points, meaning they got one of these correct. So several of you got all of them, and I'm very proud of all of you. So Stella's asking, we choose things we can do something about, right? Yes, exactly. If there's something that there's nothing for us to do, like there's nothing for me to do about his history of chronic stable angina, that's in the past, right? Even if the thing you can do as a nurse is reporting to the healthcare provider, in the example of the splitting headache, what I would need to do is prepare them for a CT, right? So it's not necessarily a nursing action, but yes, don't prioritize following up on something that there's no follow-up required for. Good question. All right, so next, after we decide what's most important, we are going to then move on to our second piece, which is going to be analyzing those cues or figuring out what they could mean. And so I want to take a second and remind you guys that we do have cheat sheets available, and Dr. Courtney is going to leave a link for you to access some of the cheat sheets that we have available for free. But these are going to focus on a lot of these tough topics. And when we're talking about step 2, analyzing cues, that really requires you to have an understanding of the disease process or to know your content. And so we've got some cheat sheets for you guys to check out for free as well, just a handful of little teaser cheat sheets, and she'll leave you the link for those. But when we're thinking about analyzing cues, the NCLEX wants to know that you know what those cues could mean. And they might ask, what conditions is the client experiencing or at risk for, what disease processes could cause those findings, or how you would know if this or that condition was happening. And so the important thing here to consider is the big picture problem, because in our example, we know that shortness of breath could mean a ton of things, right? It could be from pneumonia, it could be from heart failure, it could be from collapsed alveoli like an atelectasis. And so we have to consider the big picture. We already decided in step 1 that we're most worried about his difficulty breathing, right? And probably several of you said there's too much fluid on him, and I agree. So we're going to be thinking about what crackles are caused by in this patient. So the nurse recognizes that crackles throughout the lungs in this client are due to either infective infiltrate, collapsed alveoli, or fluid accumulation that's related to either pneumonia, heart failure, or reduced mobility. So we have to kind of zoom out and think about all of our cues here. And I've got some guesses starting to come in. Vanessa says fluid accumulation and pneumonia. Claudine says fluid accumulation and heart failure. So we have some agreement that we're worried about fluid, and I'm going to give that one to you guys because you're right. We've got an S3 present. We've got pitting edema. We can see and hear that this patient has too much fluid. So that is likely our issue, fluid accumulation. But then from what? We need to think, is this from pneumonia, heart failure, or reduced mobility? And any of these things, I'll say, could cause crackles, but there's only one that's most likely in this client. And so let's look at some of these in order. So pneumonia. So if somebody has respiratory difficulty from pneumonia, what other symptoms might tell us that? Think like vital signs, lab values, assessment findings. Y'all seem kind of torn between pneumonia and heart failure, so I'm glad we're talking about it. So if somebody has pneumonia, which is an infection, it would cause crackles, right? Because I would have pus or infective infiltrate building up in the alveoli. But I would also have findings of infection, like Temwa says temperature. Yes, I might have a fever. Maybe he's got chills. Abibadu says fever as well. Awesome. So right, if we had pneumonia, we would maybe see some signs of infection like muscle aches, weakness, anorexia, other things like that. But heart failure, I think you guys are onto something, and the majority of you are guessing that because, yes, we've got all this heart failure risk factors present. It's worse when he's laying flat, right? That's called orthopnea, why he's having to sit upright. And if we look, we're going to do a quick review of this. Whenever you've got heart failure from inadequate blood supply to the heart muscle, like in coronary artery disease, and maybe too much oxygen demand on the heart, like if you have hypertension and the heart's having to work really hard to pump against that high blood pressure. So those things are going to strain the ventricles, cause them to weaken, and then we've got two problems. Instead of the blood moving forward to the organs, it goes backwards into the lungs and it builds up, and then the alveoli can fill with fluid. And so that's actually what you're hearing when you're listening to crackles. And if you guys have never had a chance to actually listen to this on a patient, you can take a little bit of your hair and kind of roll it between your fingers here, right by your ear, and that's pretty close to what crackles sounds like. It's described to me as like a snap, crackle, pop, or Rice Krispies sounding noise. And I like to think of this like we're trying to blow bubbles through a straw, or we're trying to get oxygen in and carbon dioxide out, but it's going through fluid, like blowing bubbles through a straw. So that's kind of what you're hearing there. So good, fluid accumulation related to heart failure. You guys are right. But let's consider the others. So several of you thought maybe pneumonia. Totally a good guess, really good guess, but we didn't have those signs of infection. He didn't have a fever. We had a completely normal temperature, so less likely. Also, he might have told us that he's coughing up like tan or green, yellow sputum, and we didn't have anything about that. Then our other option, reduced mobility, which would be most likely to cause collapsed alveoli. So that would be crackles due to atelectasis, where somebody who's had prolonged immobility, which he has, he's really not been getting up very much, then that instead of taking deep breaths, you take these shallow breaths and the alveoli start to kind of collapse. And then you'd hear crackles when they take a deep breath and it opens them up. But those tend to clear with coughing, and he's been coughing for 2 days and they haven't cleared. And we just have so many other signs pointing toward fluid overload, which, remember, we got fluid that backs up because it's not moving forward to our organs, especially our kidneys, so we retain it. And we are correct. And again, only 51% of our users answered this right. So you guys who got it right are ahead of the curve. And remember, if you're ever confused about anything in these case studies, you can come down here and watch these video explanations and read our written explanations as well. So, all right, next we need to decide what this client is at highest risk for developing. And when we're thinking about prioritizing your hypotheses, you want to answer the question, where do I start? So what are they most likely experiencing, like we're being asked here? What are they at highest risk for? Or what do I need to do first? And I like to kind of think of it like this. If I can only do one thing for my patient and I have to walk away, what should that one thing be? So let's consider here. This client is at highest risk for developing either respiratory failure, acute kidney injury, sepsis, or pulmonary embolism. And I'd like you guys to start to venture some guesses. Okay, while you guys are guessing, Stella made the great point that S3 is common with heart failure, but not with pneumonia. That's right. Very good. So, all right, what are we at risk for with heart failure? And we already have some early signs of one of these things, right? We already have decided that respiratory failure is something that we're worried about here. And that's because we've already got fluid in the lungs, we hear crackles, we've got hypoxemia and compensation for it. And it looks like lots of you guys are guessing correctly for respiratory failure, but for a second one, you've got kind of a toss-up between pulmonary embolism and acute kidney injury. No one's guessing sepsis, so let's get that out of the way. We already decided we don't have signs of pneumonia, and although any patient in the hospital is at risk for an infection, remember on the NCLEX we're looking for actual issues over potential issues. So although he's at risk for infection, it's a bit of a stretch to say he's at risk for sepsis unless he already has a current infection, and he doesn't. So you guys are right to omit that one. But let's look at these two. So pulmonary embolism. What conditions put you at risk for a pulmonary embolism? Because lots of you guys have guessed this one, which means that we did a good job coming up with a very NCLEX-like question, because on the NCLEX you always feel like you have more than one answer that's correct, right? So pulmonary embolism happens whenever you've got a deep vein thrombosis, and it's going to dislodge and travel up through the veins and obstruct the pulmonary artery. And F got it correct. He said DVT. All right, and so we don't have signs of DVT because what does DVT cause? We would see lower extremity swelling, right? But it would be unilateral. This is a very commonly tested thing. They want you to be confused and think that, oh, I've got lower extremity swelling. It must be a DVT, but that would be if it was one leg and he has a little bit of immobility, but much more likely if he had a recent surgery, or the classic one is a long overnight flight and then they start to have calf cramping, right? So this would be more likely from a DVT, respiratory failure from the heart failure because you've got fluid overloading the lungs. And remember, there's two problems with volume, with fluid movement in your cardiac output for heart failure. We can't get blood forward, so it backs up into the lungs, and what's not getting it is our organs. So we're at risk for end organ failure from that decreased cardiac output. And any organ can be damaged, but your kidneys are the most sensitive to a drop in blood flow because they get 25% of the cardiac output from your heart. So every milliliter of blood pumped forward from your heart, a quarter of that is destined for the kidneys. So we're worried that this fluid is not getting forward to the organs, but is instead backing up into the lungs. And that's putting at risk for respiratory failure and acute kidney injury. All right, so I hope that answers you guys' questions, that we're not really so concerned about PE because we have lower extremity swelling in both legs, not just one. So this is not looking like a DVT. Very good. And so, yep, we've got 1 out of 2 points averaged here. So it looks like everyone's probably getting that respiratory failure and confusing for one of the others. So remember to visit our explanation if you need more review for that. All right, so our next step is going to be generating solutions or deciding what can I do. And they'll ask either, are these interventions indicated or not indicated? Which actions would address that priority problem, or maybe which actions would worsen the priority problem? And again, this really depends on your understanding of the content, because we're going to treat respiratory failure from pneumonia with antibiotics, where we would treat respiratory failure from a PE with anticoagulants. And so it's not always as simple as respiratory failure, raise the head of the bed, right? Although that's true in most cases, we need to know what is warranted based on your understanding of the content in that specific disease process. So, all right, should we anticipate giving blood for a culture, or is that anticipated or not? And remember, we would want blood for a culture if we're worried about infection, right? Culture or sputum, blood or sputum culture, those are going to help tell us about infection, but we don't have any signs of infection. Remember, we don't have like yellow-green sputum, we don't have body aches, we don't have an elevated white blood cell count, we don't have a fever, so there's nothing here. And you guys are right. Evelyn, F, Temwa, you guys are all guessing not anticipated, and you're correct. How about an echocardiogram? I think these no's coming through were for the culture, but for echocardiogram, this is how the NCLEX likes to test your understanding of when certain studies would be indicated. Is they give you a patient scenario like this, and you need to know, do I need to prepare them for an echocardiogram or something else? And you guys are right that we don't need to culture anything. And y'all are saying yes for the echocardiogram, and that's correct, because the echo is going to actually be an ultrasound of their heart. It's going to visualize the heart, the valves, the walls, and it's going to look for decreased cardiac output, valve issues, and anything that could be causing heart failure. So this is anticipated. Then your renal function tests, and you guys remember from the last question that we're worried about acute kidney injury. And renal function test is just a fancy way of saying that we're looking at the BUN and creatinine and all the electrolytes. So what changes would you guys see in your BUN and creatinine if we had kidney failure developing? And I think you guys know that one, but you're right that we need to anticipate looking at the BUN and creatinine to figure out if we've got any kidney failure going on, because that's going to affect what treatments are safe to give or not. Then administering supplemental oxygen. You guys know this, that if we've got a pulse oximetry under 90%, unless they've got COPD and then we have a different range, they need supplemental oxygen. So that's correct as well. And you guys are right. Maria, Temwa, Susan, you're guessing that the creatinine would elevate, and you're correct. We would have a buildup, less creatinine is being cleared if our kidneys have failed. So that's correct. Then a 12-lead electrocardiogram. What's another big cause of heart failure? Something really common that can cause heart failure acutely. Something that would be a severe, extreme form of it called cardiogenic shock. And that can happen sometimes if somebody has an MI, right? Now, he didn't tell us that he has any chest pain, but remember, he's got diabetes. And patients with diabetes don't always have chest pain when they have an MI. So we need to do a 12-lead just to make sure he's not having any ST changes. And then a serum B-type natriuretic peptide. What would you expect the BNP to be if he had heart failure? Would it be high or low? And I'm seeing that Takya guessed 7, Omatayu guessed 7 as well. Fidelity, all you guys who dropped your guesses said guess yes for 7, and you are correct. Because the BNP is released by the ventricles whenever you've got stretch on the heart. So if you have too much fluid in your body from heart failure, from kidney failure, anything that would cause you to have a lot of fluid, and we do think we've got that with him. We've got crackles, we've got pitting edema, we've got an S3, so that will tell us if he's got heart failure. If he doesn't have an elevated BNP, he doesn't have heart failure. So average 5.6. Good job, you guys. Then next, now that we've generated solutions, we want to take action, or what will I do? And they might ask, should you do something, or how do you do something? And here we've got new laboratory results, and we're asked which of these orders do we prioritize? So we're looking for something that's going to address the problem most directly and most quickly. So let's take a look at our new lab results, where we have got a sodium that's a little bit low, a potassium that's in the normal range, and then that BNP is elevated. So it is looking like we've got stretch on the heart from too much fluid. So what do we want to prioritize? And I'm going to watch for you guys to drop in some answers here. Preparing for a chest x-ray, giving enalapril, giving furosemide, or preparing them for an echo. And I've got guesses for 4, for 3. All right, so a couple different guesses here for different options. But I want to point something out. You guys might have heard this kind of test strategy that on the NCLEX, when you prioritize, you always pick to assess first. Have you guys heard that? And that is only true sometimes. Sometimes we already have all the information that we need to act. And so we've got 2 actions here, assessing, right, by getting a chest x-ray, or assessing by getting an echo. But I don't really need, if I'm prioritizing ABCs like we should, I don't need to look at his chest x-ray or his echo to know that he's got too much fluid. And so several of you guys have mostly guessed, yep, Susan says action to remove fluids, right. And that is correct, but let's talk about this enalapril. What drug class is that? And I think you guys know this name, enalapril. So that is, Victoria says give furosemide. Enalapril is an ACE inhibitor, right? And that would lower the blood pressure. So although that is indicated and that would reduce the strain on his heart, the reason that we'd give furosemide first, and you guys guessed it, that this is going to be removing the fluids. Now, furosemide, we might give that and his blood pressure would drop already, right? So if we give the furosemide, we pull off enough fluid, give him some relief, and his blood pressure drops, we might not even need to give the enalapril. So just a little tip for you there. We want to pick the action that's going to most directly and quickly fix the problem. And Vanessa has said that a chest x-ray and echocardiogram won't change the fact that they still have heart failure. And you are absolutely correct. Sometimes we don't need to assess first, and the results of that or that won't change whether or not he needs Lasix now. If we did not yet have his potassium level, maybe I would need to draw the potassium level first, right? Because that would tell me whether or not it's safe to give the furosemide. But that wasn't the option here, so we already know that it's a safe level and we can give it. So well done, 65% got this right. So you guys are doing really well. All right, now we are at our final step, remember to invite your friends. If you guys are enjoying this, invite your friends to join our NCLEX Facebook group. Subscribe to our channel here. We love to have you. We love to come and see you guys every week and kind of work through these NCLEX tough topics. So when we're prioritizing, we're going to be looking at our prioritization pyramid where we eliminate stable and chronic issues and then prioritize our ABCs. And that's what we did in that prior question is we prioritized the action that was going to relieve his breathing problem by pulling the fluid off. All right, so evaluating our outcomes, we might need to answer, was our intervention effective, including teaching? Was our teaching effective? Or maybe what signs would indicate a complication or improvement? So you're following up and evaluating how what your intervention was affected the patient. So here, it's now 2 days later, this patient's improved, they got their furosemide and enalapril, they're going home for discharge. And they're being discharged on those meds, the enalapril, metoprolol, and furosemide. We've given the discharge instructions, and which statement of theirs indicates that the teaching was effective? Select all that apply. And here's another tip for the NCLEX. When you're answering select all that apply questions, treat each option as if it's its own true or false. So I want you guys to answer true or false as we work through these together. So true or false, it's best if I take my furosemide first thing in the morning when I wake up. Yep, you guys want to pick that, and that's true because furosemide, we've already established, is a diuretic, and that is going to make you pee a lot. And a little trick here, furosemide, the trade name is Lasix, and the mnemonic is that it lasts 6 hours. And so if you take your diuretic at 9 p.m., your patient is not going to get to sleep until like after 2 in the morning, and they're going to be really unhappy with you. And they're not going to get better because sleep is really important. So yes, we want to take diuretics in the morning, and that is on our diuretics cheat sheet that Dr. Courtney kindly worked on. And so you guys can come check that out if you're members of the Bootcamp website. Then next, I should avoid eating prepackaged foods and over seasoning my food with salt. And yes, you guys are all selecting number 2, and that is correct. A lot of patients, when they're told to limit their sodium intake, because sodium follows water and we don't want fluid retention, they think, oh, I'll just take the salt shaker off the table. But most of the sodium that we eat in our diet comes from packaged foods. So that is an important thing to make sure they know, is to read the labels on packaged foods to look for something with too much sodium. Then how about 3? Should they contact their healthcare provider if they gain more than 3 to 5 pounds in a week? True or false? And yeah, that is true. LaShawn, Fidelity, Takya, you guys are correct. We definitely want to notify the provider. The reason that we're weighing regularly is because we're watching for fluid retention. If somebody has 5-pound weight gain in a week, that's not fat, that's fluid. And this person is at risk for a heart failure exacerbation. Now, to detect that, should we weigh weekly? Or how often? Is this true or false that they should weigh weekly to make sure they're not retaining too much fluid? And I really hope you guys remember that we should not be weighing weekly. We should be weighing daily, every day with the same time, same scale, same clothes. So this is not correct. I didn't mean to check it. Sorry. This is not correct. We would need to correct them and say, no, you need to weigh yourself every day. The week comes in when you've got 3 to 5 pounds weight gain in a week. Then next, certain over-the-counter medications like antacids can contain high amounts of sodium. And remember, guys, medication interactions is big on the NCLEX, and a lot of antacids contain sodium, calcium, like calcium carbonate is Tums, and so that can be a hidden source of sodium. We never want to ignore over-the-counter medications because they can be just as dangerous as some of the prescription ones. So this is correct as well. All right, you guys. So that is it, and I hope you guys got something out of this today. Several of you say that you've learned a lot. Let me know, you guys feel more prepared for the NCLEX after learning all of this, and I hope so. But you guys can check us out on bootcamp.com/NCLEX. Follow us on all of our socials, and are there any questions that I can answer for you? I'm going to answer. Omar is here. He says, just to clarify, we would still administer diuretics even if the sodium levels are abnormal or low. Will it not worsen the electrolyte imbalance? Omar, that's a really good question. And The answer, as with anything, is it depends. But I'm going to phone the audience here. You guys, why would somebody with heart failure have a low sodium level? All right, Silas, I'm glad you came too. Susan's a little bit better prepared. You guys are welcome. So somebody with heart failure would have a low sodium level because it's dilutional, right? They're retaining too much fluid, and so that dilutes the sodium in the blood. And so in this case, we need to pull fluid off. And remember, furosemide is a potassium wasting diuretic, meaning that it spills potassium into the urine, and potassium acts like a salt as well, just like sodium does. And so in this case, it would lower their potassium much more dramatically than it would their sodium. So we're going to pull off potassium, and water is going to follow it, and that's going to raise the sodium level. So very good question, although I believe thiazide diuretics, those work more on sodium excretion. So in that case, you would not give it. But I don't think that's actually something really important on the NCLEX related to thiazide diuretics, so you'll just have to go check out our diuretics cheat sheet for the answer. All right. Chanel says, is this review good for PN as well? So if you're studying for the NCLEX PN instead of the NCLEX-RN, do know that our product is specifically based on the NCLEX-RN test plan, but we've heard from a ton of our users who are studying for the PN exam that they found this just as helpful. And in theory, if you're prepared to sit for the RN exam and exercise that level of clinical judgment, you should be able to do pretty well, and that's going to translate to helping you on the PN as well. All right, Omar, you're welcome. Okay, so I don't see any more specific questions. If you have any questions left, you guys can drop them into the chat, and myself or Dr. Courtney will try to get some answers to you. But thank you again for joining. We're so happy to have you here, and tune in next week.
For those of you who don't know me, my name is Courtney. I'm one of the content creators here at NCLEX Bootcamp. I have been a registered nurse since 2010, which is hard to believe, and a psychiatric nurse practitioner since 2017. So quite a while. Most of my career has been spent in mental health, but before I went into mental health, I worked in med-surg and public health for a number of years as well. So a little bit of experience all over. And we are also joined today by Dr. Amber Adams, who is down there in the chat. So she's moderating today's event, so feel free to pop in and say hi to her. She is going to be dropping some helpful links throughout the presentation, answering any questions you might have. And as you know, today is kind of a live review session, so we're going to be answering some practice questions together. So I might ask you to weigh in on some of the answers, so feel free to leave your answer down there in the chat, just to make it a little bit more interactive, a little bit more fun, so you can kind of think about these questions as we go through them. All right, so should we get started? Are you guys ready? All right, so we're going to cover a few things today. So like I said, today is kind of a live review session for our some NCLEX questions, and we're going to be focusing on single best questions today. And so why, you might ask, are we focusing on single best? It's because these are the most common item type you're going to see on the NCLEX, and they can cover a really wide range of topics. So you might get pharm, mental health, prioritization, delegation, maternity, OB, all of the above, right? So I have handpicked a couple practice questions for us to go through today, and so we're going to talk a little strategy about how to approach those and get a little practice in. So before we dive into those practice questions, we're going to talk a little bit about how these questions are scored. It's really easy. And then we're going to talk a little strategy about how to approach those questions. And then we're going to dive right in and do some practice questions together. And these questions are going to look very similar to what you might see on the actual NCLEX. So let's take a look. So let's first off cover really quick how these items are scored. Like I said, it's really simple. These are the easiest ones to score. So you can see that with single best items, we're going to have 4 answer options, and only one of those is going to be correct, right? So if we choose the correct answer option, you're going to get 1 point. Now, if you get the answer incorrect, you're going to get 0 points. So we call it the 0-1 scoring rule, because you're not going to lose a point, you're just not going to get a point. Okay, so it's either right or it's wrong. There's no partial credit for these questions. All right. Excuse me. Okay, so let's talk a little bit of strategy before we dive in, a little test taking strategy. So people ask me, what is the best advice I can give to someone who's going to take the NCLEX? And I will tell you, my number one piece of advice that I give to everybody that I say is so important is to make sure that you read the header and the stem really carefully. And I know this sounds simple, but you would be surprised how easily this can trip people up, because the NCLEX might ask you something like, which of the following actions by the nurse is correct? Okay, so in that means we're looking for one correct answer, and three of those options are going to be incorrect, right? But then we might also get a stem that says, which of the following actions should the nurse take first? Well, that means that all of our answer options are going to be correct, but only one of them is going to be our highest priority that we should do first. And then we might get an even different stem that asks us which of the following actions by a staff member would cause the nurse to intervene, which means it's kind of asking us almost a negatively phrased question saying which of these actions is incorrect. So you can see that if we don't read that header and stem really carefully, we could accidentally answer that question wrong, even if we know the content, which is definitely not what we want to do. So always read very carefully before you answer the questions. And then when I'm going through questions, I like to read the header and the stem really carefully. And then I like to ask myself, okay, what do I already know about this topic? So for example, say that I got a question, a pharmacology question, and it was asking me about fluoxetine. Okay, what do we know about fluoxetine? You guys can help me out. What do you know about fluoxetine? Let me change my chat here so I can see you. All right, so we know that fluoxetine is what kind of medication? It's an SSRI, right? A selective serotonin reuptake inhibitor, which is a mouthful. And so we know that these are used for depression and anxiety. Can anyone tell me what are some common side effects of SSRIs? Anybody know? I know GI upset, right? They can cause like nausea, diarrhea. Headaches are common. Sexual side effects are really common with this class. All right. What do we know about how long these take to work? They can take several weeks to start working, right? And then what's the big thing we worry about with this medication class? Oh yeah, you guys got it. Serotonin syndrome. And I always remember the symptoms of this in kind of a fun way. I always think of sweating, shaking, and strange behavior. So like sweating or fever, shaking or muscle rigidity, and strange behavior, so like changes in mental status, right? Okay, so already we can see we know quite a bit about fluoxetine. So that kind of helps me. I do my brain dump, and that can be really quick, just to kind of a quick run through. And so if I got an answer option that said, oh, the client needs to avoid aged cheeses and wine or tyramine-containing foods, I would say, oh, well, that is true, but it's true for MAOIs, right? Not SSRIs. And so by doing this brain dump, it just kind of helps me to put down everything I know so that I'm not accidentally distracted by like a distractor option that might be true of like a different class of medication. So it kind of helps me keep things straight in my head. Okay, so once I do that, then I start ruling out answer options, okay? So, are you guys ready to do some real life practice? All right, let's go. Okay, so our first question is going to be a prioritization type question. So when we think of prioritization, we're thinking which of these conditions is most life-threatening, right? That's going to be our highest priority. So in this question, we have an emergency room nurse who is receiving change of shift report on the following clients, and we're being asked which client should the nurse see first. So when we're being asked which client we should see first, we're going to be looking for who, right? The client who is at most imminent risk for a life-threatening concern. Okay. So to remind ourselves of how we're going to prioritize these clients, let's take a look at our handy prioritization cheat sheet. And you can find this on NCLEX Bootcamp on our live site as well. It's just a really helpful tool to kind of figure out who we need to see first. So I always like to start over here on the left and work my way over. So first I'm going to eliminate any stable and chronic issues. So the example I like to use for this, and we often see this as a distractor, is maybe a client with COPD who's having dyspnea on exertion. Well, would we expect a client with COPD to have dyspnea on exertion? Yes, we would expect that to happen. It's not good, right? Like clearly this is going to be a health condition that is going to lead to poor health outcomes in the long term. But dyspnea on exertion is expected in the process of COPD. And so if we had a client who was short of breath when they were up walking around, they had COPD, I wouldn't expect that to become a life-threatening concern within the next couple minutes, right? So that's why it's a lower priority. Okay, and then from there we can go over to our green area here. So that's going to be our routine tasks, expected findings, and psychosocial needs. So we often see psychosocial needs pop up in here. So this is going to be things like financial stressors, some kind of emotional distress, like the client's upset about something. And so what we need to remember is we're not saying that these aren't important, because they are. They're really important, right? But they're just not going to cause imminent life-threatening things to happen within the next few minutes, right? So if a client can't afford their medications, we have time to address that, right? It's not going to be fatal within the next couple of minutes. So that's why it's going to be a lower priority, okay? And then from there, we move into our yellow zone, which is going to be our neurological disability, circulation, and breathing, okay? And then our two biggies, which are going to be our airway and safety. And this makes sense if we think about it, right? Because if we have a client with an airway obstruction, how long do we have to intervene before this becomes life-threatening? Minutes, right? Not very long at all. So I have a lot less time to fix an airway issue than I do a financial stressor, right? So that makes sense. And then any safety issues, so anything that's causing an imminent life-threatening risk to the client. So say they have suicidal ideation with a plan and access, and they plan to act on it right away, right? That's an imminent safety concern, okay? So with that in mind, let's go back to our question. And now that we've kind of got our prioritization pyramid in our head, let's take a look at our answer options and see if we can figure this out. Okay, so our first option is a 7-year-old who fell out of a tree and is cradling a discolored and swollen arm. What do you guys think? What do we think might be happening here? I'm thinking probably a sprain, strain, a fracture of that arm. So we definitely need to follow up, right? But is this going to be a life-threatening issue if we don't address them in the next 3 minutes? Probably not, right? But let's take a look at our other options to see if we can figure out if there's anything that's going to be a higher priority. We have a 3-year-old who's been vomiting for 12 hours and has a temperature of 103.6. What do you guys think? That's definitely concerning. I'm more concerned about this 3-year-old than I am about this 7-year-old, so I'm going to rule that one out because I'm concerned about they're vomiting, they have a temperature. What are you guys worried about? I'm worried about dehydration, which could easily become a circulatory issue or a circulation issue. Okay, so right now number 2 is my highest concern, but let's go down to number 3 and see what we have here. So here we have an 18-month-old who's vomiting and was found with an open bottle of drain cleaner. What do you think? What are you worried about? It sounds like they've ingested this drain cleaner, right? They have an open bottle of drain cleaner and they're vomiting. So I think it's safe to assume that they have ingested drain cleaner. And what do we know about drain cleaner? It's really corrosive, right? So we're going to have a lot of tissue damage. And so if they swallowed this into their esophagus, what's right next to their esophagus? Their airway, right? So now we have a corrosive substance that's causing tissue damage and swelling right next to their airway. So what are we thinking might happen? I'm pretty concerned right now about an airway obstruction. Okay, so if they have swelling and edema around this airway issue and it's closing off their airway, how long do we have to intervene? Couple minutes, right, at the most. So I am more concerned now about number 3 than I am number 2 because remember, airway issues are going to come ahead of circulation issues, okay? So 3 is right now topping my list, but let's take a look at number 4. We have a 5-year-old with epilepsy who experienced a seizure 30 minutes ago that lasted 3 minutes. What do you guys think? I think if we look, we could say seizure is probably a neurological issue, right? Which is still not going to top airway. Also, what would be the criteria for status epilepticus? Does anybody know? We'd have to have a seizure that was lasting over 5 minutes, right? And this client had a seizure 30 minutes ago. So there's nothing happening right now that we're being told of. So I think we could say they're fine, right? There's nothing going on right now. Nothing to make us think that there's an imminent risk going on, right? Yeah, so I see a lot of you are thinking number 3 is going to be our highest priority, right? Because we are worried about airway issues with number 3. And I also agree. So should we see if we're right? Yes, we are. And you can see, if you look at how many people in our bank got this correct, it was about 57.4. And so if you got that right, you're doing better than most. So good job. All right, so let's go on to question number 2. So this is a pharmacology question. Does anybody love pharmacology? I know some people say they struggle with this. I like pharmacology, but that could just be me. Okay, so let's see. We have a client with hypertension who's taking lisinopril, and we're being asked which of the client findings is most concerning. So again, this is another prioritization type STEM. So we're saying all of these are going to be concerning, right? But which is the most concerning? So if we're asking which is the most concerning, what are we looking for? The one that has the potential to be most life-threatening, right? Okay, so let's do a little brain dump, and you guys can help me with this. So what do we know about lisinopril? What kind of med is this? This is a ACE inhibitor, right? Angiotensin converting enzyme inhibitor. All right, what do we know about ACE inhibitors? Does anybody know what are just some common side effects in general to antihypertensive medications? Well, we know that they're used to lower blood pressure, right? If it's too high. What happens if we lower blood pressure too much? A lot of clients end up with what we call orthostatic hypotension, right? So blood pressure gets low when they stand up. It can make them dizzy. So we have to tell them to stand up slowly and change position slowly. Oop, I see someone says coughing. Yep, that's a common side effect. Is that usually life-threatening? Or is that just an annoying side effect? Yeah, it's typically an annoying side effect, not typically life-threatening, right? Okay, what do we know is a big concern with this medication class? What's a life-threatening concern that can happen? Oh, I see it. Tosh got it. Angioedema. Good job. Okay, angioedema we worry about, right? Because that is swelling in the face, in the neck, and then what do we worry about if we have swelling going on in this area? Airway obstructions, right? So if we have swelling of the lips and the tongue and in this area, we worry that it could obstruct the airway, right? Which we know, if we go back and look, is going to be our highest priority, right? So let's take a look at our answer options. We already know quite a bit about ACE inhibitors already, so let's see if we can use this to answer our question. So option number 1 is itchy lips and tongue. All right, what might that be a sign of? Yeah, that might be a sign of angioedema, right? Because if their tongue is itchy and their lips are itchy, that might be because they're swelling, right? So that would be pretty concerning, right? Because like we said, we're worried about airway because swelling of the face could lead to an airway obstruction. Okay, so right away, I'm thinking that's probably most concerning because we know airway issues are a big deal. But let's take a look. We always want to read all of our answer options because we want to make sure we're not missing anything. Okay, a persistent dry cough is number 2. Well, we already said that that is a common side effect. And while it's concerning because it can be an issue for clients not wanting to take this medication, it's not typically life-threatening, right? Okay, so I'm going to say that's not my most pressing concern at the moment. How about a blood pressure of 142/92? Is that normal? No, it's not normal, right? But is it a hypertensive crisis? No. It's high. It's higher than I would expect to see for somebody who is being medicated for hypertension. So that might be a sign that the lisinopril isn't working so well for them. Maybe they need a bigger dose, or maybe they need a different medication. But is this blood pressure life-threatening? No, right? So not my most pressing concern. And how about feeling lightheaded when standing quickly? Is that a pressing concern? Well, we already said orthostatic hypotension is common. And so feeling lightheaded when they stand quickly is probably a result of that blood pressure going low, right? And that can happen with antihypertensive medications. And so we need to educate them, right, to change positions slowly, to stand up slowly, not come bouncing up out of their chair really quickly, because that will increase their risk for falls, but definitely isn't going to top a potential airway issue, right? So I'm still liking number 1 as our answer for most concerning. What do you guys think? I see a lot of number 1s. Yeah, okay. Let's take a look and see if we're right. And yes, we are correct. Itchy lips and tongue, right? Because we said we were worried about angioedema, which can be an airway obstruction. And we know that airway obstructions are always going to be a really high priority concern, right? All right. You guys are doing great. Good job. Yeah. Yes, Janice says you don't need to freak out. Just educate. Yes. Good advice. Okay. Let's take a look to number 3. So this is a therapeutic communication question. So how do you guys feel about therapeutic communication? You feeling pretty confident? This is a topic that is really likely to come up on the NCLEX, because therapeutic communication isn't just for those of us working in mental health, right? It is applied throughout every field of nursing that we work in. We need to be good communicators. We need to be good therapeutic communicators. So let's take a look at this question. So we have a client who recently experienced a significant loss, and the client states, "I'm doing fine, everything is okay." However, the nurse notices the client is frowning when they're speaking. Okay, so there's a lot going on in this heading. So what do we notice is kind of our problem here? We have something we call incongruent communication, right? So our verbal and nonverbal cues are not matching up, right? So the client is saying everything's fine, I'm good, but their face is showing something else, right? They're frowning when they're saying this. So we're being asked which of the following would be an appropriate response for the nurse to make. So we're trying to get to the bottom of what's happening, right? We need to solve this incongruent communication, right? We need to reconcile these incongruencies we're seeing between verbal and nonverbal cues. Okay, so before we do that, let's take a second to remind ourselves what we know about therapeutic communication. Now, therapeutic communication can be broken down into kind of 3 big areas. So we have our active listening, our open-ended questions, and our non-judgmental communication. So our active listening is going to be things that we say that just kind of show the client, like, I hear you, I understand, I'm listening, right? So we might kind of reflect things back to them. So if they said something like, "Oh, I've been up all night," we might say like, "Oh, you didn't sleep well last night. Okay, I hear you, I understand," right? And that is a good way to show the client that they have our attention and that we're following along. And then we have our open-ended questions, because we all know we typically don't want to ask closed-ended questions. So we want to ask open-ended questions to prompt the client to give us more information. So for example, if I were to ask you, "Are you studying for your NCLEX?" What are you going to tell me? You're going to say, yes, I am. But that's not going to give me much information. So I might ask you, how are you studying for your NCLEX? And that might prompt you to say, "Well, I'm using Bootcamp and I'm reviewing my class notes and I'm doing these things," right? That's going to give me more information. And then the last thing we want to be mindful is that we don't want to be coming across as being judgmental, because nobody likes to feel judged, right? And so if the client feels like you're judging them, they're not going to want to share with you. So if I, for example, asking why questions can feel judgmental. So just in our previous example, I said, "How are you studying for your NCLEX?" And you'd say, "Oh, I'm doing this and that and whatever." But if I were to ask you, "Why are you studying for your NCLEX like that?" That feels judgy, right? You'd be like, "Ooh, I don't know. Am I doing something wrong? I feel like she thinks I'm doing something wrong," right? And so we don't want to come across as being judgmental. So we don't want to say things like, "Why are you doing that?" But we do want to say things like, "Yes, I understand," or we make neutral observations like "You seem like you might be feeling uncomfortable," or it seems like this might be happening, or "I've noticed this," right? We want to make neutral observations. Okay, So let's go back to our question and take a look and see if we can figure out which is correct. I'm seeing a lot of 1s and a lot of 4s. All right, so let's take a look at our first one. I can see that you're feeling upset. Tell me more about what's bothering you. Okay, I like this. Tell me more about what's bothering you is a nice open-ended question, right? So we're just saying like, tell me more. But there's one thing about this question I don't like. Does anybody know? And this is a tough question. This is a more advanced one. Does anybody know? Okay, the one thing I don't like about this is we're telling them kind of how they're feeling. We're saying, I see you're feeling upset. We're kind of putting words in their mouth, right? We don't want to do that. We don't want to say like, I see you're angry. I see you're feeling upset. I see, we're kind of telling them how they're feeling, which we don't know that, right? We don't want to make that assumption that they're upset. We just want to get to the bottom of this incongruent communication. So I think there might be a better way to ask this. So let's take a look at our other options. Our number 2 says, okay, I understand. If you want to talk more about how you're feeling, I'm here for you. What do you guys think? It's nice that we're saying that, I'm here for you. That's nice, right? But does that help us get to the bottom of what's going on? We're not asking any questions at all, are we? We're just saying like, okay, that's good. I'm here for you. But that doesn't help us solve our problem of this incongruent communication. Okay. Number 3. I'm glad to hear everything is okay. Is there anything specific you'd like to discuss today? What do we know? What do we see about this one that's not so great? We're kind of just blowing right by those nonverbal cues, aren't we? We're just like, okay, you said everything's fine. Anything else you want to talk about? And this is also what? This is a close-ended question, right? So if we ask that, what's their response likely going to be? If I said, is there anything else you want to talk about? They're going to be like, no, there's nothing more I want to talk about. So that's not going to get us any information. So let's see number 4. I see a lot of you pick this option. Let's take a look. You mentioned everything is fine, but your facial expression seems to show otherwise. I'd like to hear more about that. What do we like about that? I like that we're just kind of observing what we're seeing. I'm like, you're saying that it's fine, but your face doesn't seem to match. We're not saying that you look angry or you look upset or you look frustrated. We're just saying like, hey, I'm observing that these 2 things don't match. And then we follow it up with an open-ended question. And what you'll tend to notice with therapeutic communication is it follows a pattern, right? So typically we make an observation, we ask an open-ended question. We're like, I noticed this. Tell me more about that. Or I'm seeing this. I'd like to know more, right? So it kind of follows a specific pattern of making an observation, following it up with an open-ended question, right? So I am liking number 4. Yes, 4 over 1. Yep, you guys, you got it. All right, let's see. Are we right? We are. Good job. Okay. Should we keep going? We've got 2 more questions left to get through. You guys are doing great. Okay, so number 4, we have a mental health question. All right. How are you guys feeling about mental health? I like it. Obviously, I'm a psychiatric nurse, so it's kind of in my wheelhouse. All right. Let's see. The nurse is observing a staff member who's caring for a client who has schizophrenia and is experiencing auditory hallucinations. Which of the following statements by the staff member to the client would require the nurse to intervene? Okay, so again, a lot going on in that header and stem, right? So we've really got to read carefully to figure out what we're looking for. So in this case, we're looking for the statement that would cause the nurse to intervene, which means we're looking for a statement that would be inappropriate, right? Okay, so 3 of these are going to be correct and 1 is going to be inappropriate, and that's the one we're looking for. So before we do that, let's take a second to remind ourselves what we know about communicating with clients who are experiencing psychosis, because there's a few things that are going to be a little bit different, right? So I think it's easier to start off with the things that we don't want to do. So the biggest things that we don't want to do is we don't want to refer to hallucinations as if they are real. So we don't want to say like, what are the aliens saying to you? Where are the spies at? Why is that person trying to kill you? Like, we don't want to also convey to the client that we think that their hallucinations are also real, because it's going to reinforce that psychotic content for the client and make it feel even more real for them. But on the same hand, we also don't want to negate the client's experience. So we don't want to say things like, nobody's trying to get you. That's not what's happening. Nobody's trying to poison you. Because we have to remember that what the client is experiencing feels very, very real to them. So if we come in there and say, that's not what's happening, that's not real, nobody's trying to hurt you, they're going to feel dismissed. They're going to feel really suspicious of us. They're not going to trust us, and it might even make them really kind of agitated. So you might be asking, okay, well, if I can't go along with it and I can't tell them that's not what's happening, what do I say? So what we do is we make neutral observations. So we offer our own perception of what's happening. So we could say things like, I don't hear any angry voices, or I see Dr. Smith at the nurse's station, but I don't see any evil aliens. I see Dr. Smith. And then we also want to acknowledge how the client's feeling. So we could say things like, I don't hear any angry voices, but that sounds really upsetting. That must be really frightening. That sounds really scary, because it is, right? So we want to acknowledge how that's making the client feel, okay? And then we follow that up by engaging them in things to distract them away from those hallucinations. So we might engage them in distraction, like playing a card game, doing a simple art project, because what we don't want to do is leave them sit alone with those delusions or hallucinations, because it's going to allow them to just get more and more wrapped up in that content. So we want to engage them in some reality-based activity that's simple and concrete. Now, if the client has some insight into what's going on, has some insight into the fact that they might be experiencing a hallucination, we can engage them in reality testing. So we can say things like, let's look around. Does anybody else seem to be hearing what you're hearing? Does anybody else seem to be fearing for their life? Do they seem to be seeing what you're seeing, right? So kind of just prompting that observation. We're not telling them that it does or doesn't exist. We're just saying like, hey, let's look around, right? We can also do things like competing auditory stimuli. So for auditory hallucinations, we might do things like turn on some music, engage them in conversation, turn on the TV, because it's really hard to attend to both internal stimuli and external stimuli at the same time. So it can help distract them from those hallucinations. If they're also experiencing auditory hallucinations and they have some insight, we can also help them tell the voices to go away. That has been a proven technique to help clients feel more in control of their symptoms. So with that in mind, let's go back to our question and see if we can answer this and figure out which of these would be inappropriate. So our first one is, why don't we go listen to some music together? Would that be appropriate for a client who is experiencing auditory hallucinations? Would that be appropriate? Yeah, absolutely, right? Because that's going to help distract them away from those auditory hallucinations. All right. What about let's go play a card game with the rest of the group? Is that appropriate? Yeah. That's also a good form of distraction, right? We don't want to leave them sit alone, like listening to these auditory hallucinations. So we want to get them engaged in a reality-based activity. Okay, and then number 3, I will help you and together we can tell the voices to go away. What do you think? Yeah, that could help them feel more in control of those hallucinations. And we don't have any reason to believe up here that they do or do not have insight, right? So if they did have insight, we could certainly have them do that. That might be helpful in decreasing those auditory hallucinations. And then number 4, what you're hearing is not real. You are experiencing a hallucination. What do you think? I think this often trips students up because we're like, oh, we're reinforcing reality. That's a good thing, right? But remember, it's a little different with clients with schizophrenia or psychosis, right? Because we don't want to directly negate that experience, right? So this we know, would that be appropriate? No, right? Because we don't want to directly negate that hallucination. Now, even if we didn't know that number 3 was appropriate, because that is a little bit more advanced, we definitely would know that this is inappropriate, right? So that would help us choose our answer. Okay, should we see if we're right? And yes. Okay, we've got one last question to do, and this is going to be a delegation question. So I know students often say like delegation and prioritization are tougher concepts to grasp. So I put a delegation question in here so that we can talk through this one. Okay, so we have a charge nurse who is supervising a registered nurse in the care of a client on a mechanical ventilator. Okay, and then we have the charge nurse should intervene if the RN asks the unlicensed assistive personnel, or UAP, to do which of the following tasks that we have described to us. Okay, so again, a lot going on up here, so we need to read this carefully. So we're looking for an action that would be inappropriate to delegate to a UAP. And depending on what state you're in, this might be like a CNA or a nurse's aide, right? An unlicensed assistive personnel. Okay, so 3 of these are going to be appropriate to delegate, and 1 of these is going to be inappropriate. So we're looking for the inappropriate one. So before we look, let's take a look at our 5 rights of delegation to help us remind ourselves kind of what we're looking for. So when we're looking for appropriate delegation, we need to look to make sure that we're delegating to the right person. So is, in this case, the UAP competent to do this task? Do they have the skill and the appropriate knowledge to do what we're asking them to do? Okay. Then we need to ask, is it the right task? And so is it in the scope of practice for the UAP to do what we're asking them to do? And is it a routine task with an expected outcome? Because remember, even though we're delegating that task, us as the RN are still going to be responsible for the outcome, right? So we need to be sure it's an expected outcome that we can evaluate. Is it the right circumstance? So is this client stable? So for this one, I always like to use the example of like client transfers, right? So we might often ask a CNA or a UAP to transfer a client from the bed to a chair, right? That would be totally within the scope of their practice. But what if this client that we're asking them to do it for has just come back from a total knee replacement and they've never done a transfer before? Well, in that case, we wouldn't know that that client is stable or not because we haven't assessed them yet. And so in that case, it would not be the right circumstance to delegate, even though it's within the UAP scope of practice to do a client transfer. Does that make sense? Okay, so we need to make sure that that client is stable. We've already assessed them and determined that it would be an okay task to delegate. And then do we have the right direction and communication? So basically, does this UAP understand what we're asking them to do? Do they have any questions? And do we have the right supervision and evaluation? So basically, can we evaluate this task that they've done, right? So we need to be able to follow up because, right, we're ultimately responsible for this task that we've delegated. So we need to be able to evaluate the outcomes of this task. Okay, so let's go back and see if we can figure out which of these tasks, remember, we're looking for which one is inappropriate. So would it be appropriate or inappropriate to turn the client from, or to delegate this to the UAP to turn the client from left to right side every 2 hours? Is that appropriate? Yeah. To do, to move the client, reposition the client, turn them from right to left side so that they don't have skin breakdown would be within the scope of practice for a UAP. We can evaluate the outcome of that, right? Because we can see that their skin is maintaining integrity. So yes, I think that would be appropriate to delegate. So I'm going to say that would be appropriate. We don't need to intervene. Okay. How about number 2? Notify the RN when the client requires inline suctioning. Would that be appropriate to delegate? So I think to figure this out, we need to ask ourselves a couple of questions. So how would the UAP know when the client requires suctioning? They would have to assess that client, right? They would probably have to listen to some lung sounds, maybe look at O2 saturation. Okay, is it within the scope of a UAP to assess the client? No, right? It's not within their scope of practice to assess the client. That is the nurse, right? So can we ask them to let us know when they require inline suctioning? Well, no, because they would have to assess the client to be able to know when that needed to be done, and that's not within the scope of their practice. So I'm going to flag this one here. I think that would be inappropriate to delegate, but let's take a look at our other options and see if we can make sure that that's the one we want to choose. So number 3 is perform passive range of motion exercises on the extremities. Is that okay? Is that within their scope of practice? Yeah, passive range of motion exercises, right? We can evaluate the outcome of that in terms of the client still having good range of motion. I would expect the UAP would have the skill and the knowledge to be able to do that. We're not asking them to assess anything, so I feel like that's appropriate, right? All right, and then we have our last option, to measure the client's respiratory rate and pulse oximetry reading. Is that appropriate? So I think where students get hung up is between number 2 and number 4, right? And what's the difference between these two? What's the difference between 2 and 4? Well, in 4, we're asking the UAP to measure respiratory rate and pulse oximetry reading. They're collecting data. We're not asking them to assess that data. We're just asking them to collect the data, give those numbers to us. Is that within the scope of practice of a UAP? Yes, right? But in number 2, we're asking them to interpret this data, right? We're asking them to interpret what that means, which is not within the scope of their practice. So what are you guys thinking? I like number 2, right? That would not be appropriate to delegate because we can't ask the UAP to assess the client, right? Okay, so let's see if we are correct. And yes, we are correct. All right. Well, you guys have done fantastic. Great job. I am going to leave you here with some links of where you can find us. So we obviously you can find us on NCLEXBootcamp.com. We're also on, bootcamp.com/NCLEX, which you'll see here. We're also on Instagram and TikTok and YouTube, which we're on today. We have a Facebook study group, which you can see here. So if you go over to our NCLEX Bootcamp study group and you click that invite button, there's just a couple of quick questions you can fill out and be invited to our Facebook study group. And there's a lot of people over there studying for the NCLEX as well. We know it can be a really stressful time, so a lot of people really like that peer support as well. I do think Amber might be dropping some links for you in the chat if you are interested in signing up for bootcamp. We have a lot of really great study resources. We have study schedules. We have a very large Q bank. We have really great case studies with those video walkthroughs. And so a lot of students have said they felt it's been really, really helpful in studying for their NCLEX. So for all of you who are taking your NCLEX soon, I wish you all the very best of luck. I'm sure you'll be happy to have it done because, like I said, I know it can be a stressful time, a stressful season for you. So I wish you all the best of luck, and we will see you next week for another webinar that will be coming up. So everybody take care, and I will see you all soon. All right, bye.
Okay, so we have a lot of people getting ready to take it very, very soon. A couple people going in for their second attempt. So best of luck to you. I have no doubt this information is going to help. So let's go ahead and get started. So I'm Dr. Amber. I'm one of the nurse educators here at bootcamp.com. And we do have a moderator that you see in the chat. That's Miss Miriam. She's also a nurse educator here. She'll be answering any questions that you have and also sharing some information throughout this presentation. So once again, today we're going to talk all about prioritization, which I know can be a very challenging subject and very intimidating for most people. So let's go ahead and get started. So we're going to talk about some general principles of prioritization, and we're also going to talk a lot about how we should be approaching these prioritization items strategically, the types of things we should be thinking about when we see a prioritization question pop up so that we can feel confident and kind of know how to navigate them versus just simply being overwhelmed with the vast amount of information you sometimes get in these items. So before I get started, I want to remind everybody to follow us on our socials. And if you have Facebook, we do have a very active, wonderful study group on there. Please join and invite your friends. I also want to remind you guys that we have been working very hard at bootcamp.com on some amazing cheat sheets. If you haven't heard about them, they've been making quite the splash. We've got a lot of really great feedback from students that have taken the NCLEX. So please check out our cheat sheets, and we do have one devoted specifically to prioritization that's going to cover some additional information that we really don't have time to cover today with our practice questions. So please check that out. Okay, so why are we talking about prioritization? Well, one of the most important reasons is I guarantee you will see prioritization items on NCLEX. So the NCSBN that creates the NCLEX, they're very transparent about what's on the exam. And so when we look over here in this right-hand corner at the NCLEX test plan, we can see that management of care items count for almost 20% of the exam. So that's quite a large number of what you're going to see on the exam. And these management of care items include prioritization, delegation, and assignment making, which I know can all be pretty challenging topics, but today, once again, hopefully we'll break it down so it feels a whole lot easier by the end of this webinar. So one of the reasons that you will see these items so frequently on the NCLEX, it is one of the best ways to assess critical thinking. So we've all heard everyone say NCLEX is a safety exam, and it absolutely is. And one of the best ways they can assess if you're a safe nurse is determining if you are able to figure out what patient do I need to go see first, or what task do I need to perform first. So it's a wonderful way to assess critical thinking. Now, the reason that prioritization can kind of be challenging is because it does require us to kind of take a step back and look at the overall clinical picture of the client. And we also have to be able to kind of imagine or predict the progression of their disease process. And that can be really challenging when you're a nursing student or a new graduate nurse and you haven't had a lot of clinical experience. So I know these can be a little difficult, but once again, we're going to make them easier. And then I want to remind everybody that prioritization questions can be formatted many different ways. So what I did today is I made sure that I brought 3 practice questions that we can go through together that are all formatted a little bit differently, so you can get a variety of experience in how you might see these items asked. And then also, I just want to remind everybody that prioritization doesn't stop after NCLEX. It is a primary nursing skill that you need to continue to work on practicing and developing so that you can be a safe nurse. So before we jump into the practice questions, I wanted to show y'all one really helpful resource that we're going to use throughout the webinar. So this is our NCLEX Bootcamp Prioritization Pyramid that we worked really hard on to try to give you guys a resource or a tool so that when you are sitting there trying to figure out a prioritization item, you can look at this pyramid and it kind of helps you have a strategic approach to help guide you as you navigate these questions. So we've all heard probably people say, oh, prioritization, just focus on ABCs, that kind of thing. And although that information is helpful, that really doesn't look at the overall picture and it's not very comprehensive. So that's where this prioritization pyramid came in. So let's briefly talk about how do we use it, and then we will practice with it on a couple of questions. So the first thing we're going to do whenever we see a prioritization item is we're going to start with step 1 over here on the left, and we're going to eliminate any stable or chronic issues. So let me give you an example of that. A stable issue would be a client that, for example, has a fracture. Maybe they have a fractured wrist and they have some mild pain and swelling at that site. Is that stable? Do we think that that's expected and normal for this client? Yeah, there's nothing to indicate that that client's not stable. Now, if it said that you have a client with a wrist fracture that has no pulses distal to the injury, or they have decreased sensation or tingling, that would all be concerning findings that our client might be unstable and experiencing a perfusion issue. But in this case, the client's stable. So they would not typically be a high priority, and we can eliminate them as a high priority before we look at anything else. Another thing that we can typically eliminate right at the beginning is chronic issues. And an example of a chronic issue would be, for example, a client with advanced COPD. Can someone tell me what do we expect the normal pulse oximetry range to be for a client with advanced COPD? What do you guys think? Do we expect it to be normal, above 94%, like it is in most clients? Probably not. So it's typically going to be about 88 to 92%. So if we're looking at a prioritization item and it says that we have a client with COPD with a pulse oximetry of 90%, we can expect that. It's a chronic issue and that's normal probably for that client. So once again, these guys are typically not our highest priority. So we can eliminate them, and then we move on to step 2, which is actually looking at that pyramid. So the bottom in bright red to get your attention are the issues that require immediate intervention typically. And those are going to be airway and safety issues. So any type of acute airway or safety issue is usually our highest priority that needs immediate intervention. And then it is followed by breathing, circulation, and disability. Disability is just another way to say neurological So altered mental status, stroke, that type of thing. So we can do our A, B, C, Ds, and once again, safety and airway are both very high priorities. And then our lowest priorities are at the top of the pyramid. And that's going to be our routine tasks, our expected findings, and then psychosocial needs. And what I mean by psychosocial needs is just anxiety or frustration. Although those things are, not ideal, they typically are not going to kill us. And that really, guys, is the fundamental principle to follow when we're looking at prioritization, is we have to ask ourselves, if we don't perform this task, or if we don't see this client, who's going to die first? Like, what life-threatening condition do we see? Because that's always going to be our highest priority. Okay, so I know that was a lot of information. So let's actually look at a couple of a couple of items and look at our prioritization pyramid as we go along. So this first item is formatted in probably the most traditional, most common way you will see a prioritization item formatted. And that's where we are having to identify the sickest or the most acute patient that we need to see first. So we always want to read our stem very closely. So it says the nurse should first assess the client who is obtunded on hospice care and is becoming restless, a client who had a cholecystectomy 2 hours ago and is reporting nausea, a client that has a peptic ulcer with a rigid abdomen reporting sharp abdominal pain, and our last client who had abdominal surgery 2 days prior and reports left lower extremity pain and swelling. So let's take a closer look at these options and look at our pyramid and see if we can figure this out. So first option is obtunded. Do we remember what that means? Obtunded is kind of lethargic. They're on hospice care and they are becoming restless. So this is where I'm going to go ahead and give y'all a really helpful test-taking tip for NCLEX. And that is, be very careful to not just latch on to a single word or finding and just run with it. And that is, a lot of times we worry whenever we see that a client's got a change in their mental status, because that can indicate a lot of life-threatening issues, such as stroke or hypoxia. But for this client, we have to look at the context, okay? And that's with any item, especially prioritization. We always have to be very careful to look at the full picture. This client is on hospice care. So do you guys think if we have a client that's on hospice care, which means they have a terminal illness, and they're lethargic and there's a change in their mental status, do we think that is expected for a client that is on hospice care at the terminal illness? Especially as they get closer to the dying process. Do we expect a change in mental status and some lethargy or obtunded? So I'm already seeing that you guys have some wonderful guesses on the right answer. So I love the engagement. It makes it a lot more fun for me. But remember, there's a lot of learning in the wrong answers too. So we'll see if y'all are right. So I'm seeing a lot of people say that that's expected. That's correct. So once again, when we look over here at our pyramid, that's an expected finding. So that's not a high priority. So let's look at option 2. We have a client with a cholecystectomy 2 hours ago reporting nausea. So remember, cholecystectomy is a gallbladder removal. And we just had this surgery about 2 hours ago and they're having some nausea. So do we think this is an expected finding? So let's talk about this. Anytime we have a client going to a surgery, typically they get anesthesia. And we know that one of the most common side effects of anesthesia is nausea. And then also we have a client that had a gallbladder issue, obviously, to warrant the surgery. And so just gallbladder issues alone can cause some nausea and vomiting. So for this client, that's also a pretty expected finding. So we'll put that also up there at the top. So you guys are loving option 3, okay? And I see a couple people I already identified the diagnosis, so I'm very impressed. So we have this client with a peptic ulcer. They have a rigid abdomen and sharp abdominal pain. So do we think this is an expected finding for a client with a peptic ulcer? What do we think? So typically with a peptic ulcer, you can have some abdominal pain, But I'll tell you what's really concerning for me is this right here, rigid abdomen. So this is another helpful NCLEX tip. If you ever see the word rigid abdomen or board-like abdomen, that's a big old red flag that we have a life-threatening condition called peritonitis, which you guys have already identified, so kudos to you guys. So peritonitis, remember, is inflammation of that peritoneal cavity in the abdomen, and if left untreated, it absolutely can cause life-threatening complications. A lot of times we see shock, so we see tachycardia, we'll see hypotension, and it is certainly a life-threatening issue related to perfusion or circulation. So when we look over here at our pyramid, it's a circulatory issue. So far, I agree with you guys. I love 3, but let's take a look at 4 just to be safe. So option 4, abdominal surgery, abdominal surgery 2 days prior, left lower extremity pain and swelling. So anytime we have a client that had a recent surgery, typically they're not as mobile as they normally are. So you have some immobility. So anytime we have a client that's immobile, what are they at risk for? What do we think? Sitting in that bed, not really moving around. What is a really big risk factor? They're at risk for, I can't talk today, guys. DVT. Y'all got it. So with DVT, you will experience that unilateral pain and swelling. Now, this is where it gets kind of tricky because that is also a circulatory issue. So you might say, well, they're both circulatory issues, so which one is the higher priority? Well, we once again have to look at the context. So with the DVT, it is still just localized to that lower extremity, okay? We are not seeing any indication that it is a systemic problem at all. Whereas with option 3, with peritonitis, they are at risk for shock. So they're at risk for systemic circulatory issues, which is going to be a lot more life-threatening quicker. But let me tell you about when option 4 could potentially be correct. Let's say we have the same situation where we have a client with lower extremity pain and swelling who then suddenly reports a feeling of impending doom with difficulty breathing, with chest pain. What do we think's going on there? If we have a DVT and suddenly we have a feeling of impending doom, difficulty breathing, chest pain. PE, very good. So we're at risk for a pulmonary embolism. So if that was the case, that's either a circulatory or a breathing issue. And so that would be a higher priority than option 3. But that's going to lead us to another really, really important testing point, is that we don't ever add information. Now, one of my favorite pastimes when I was a nursing student is going down a rabbit hole when I would read answer choices. And I know some of y'all might struggle with that as well. But remember, the NCLEX is not trying to trick you, neither are we, so always take it for face value. If it just says left lower extremity pain and swelling, let's just believe them. Let's not start thinking about how it can turn into a PE and that's technically a breathing issue. Don't do that to yourself. It's a good way to set yourself up for failure. So I think we got it correct, and we did. So kudos to all of you guys. Y'all are doing awesome so far. So let's look at our second practice item. And this is another really common way that you're going to see prioritization items formatted, where we're still trying to find the highest priority, but instead of looking at the client, we're going to look at the client need or the task. So let's take a look. The nurse has been made aware of the following client situations. Which of the following client needs should receive the highest priority? So it's basically asking us, which task should we perform first? So let's look at our options. Administer an antibiotic to a client with cellulitis that was due 1 hour ago. Assess the client who reports redness and pain at an appendectomy incision site. Assign assistive personnel to stay with the client who is reporting suicidal ideations with the plan. And provide discharge education to a frustrated client who has been requesting paperwork for 2 hours. So let's take a little bit closer look, because all of these things we need to do, right? So administering an antibiotic to a client with cellulitis that was due 1 hour ago. So that right there is a routine task that does not pose any type of life-threatening risk to our client if we delay it at all. Now, if we delay that antibiotic for, days, certainly they'd be at risk for some issues such as sepsis, that type of thing. But it's just 1 hour. This patient is most likely not going to have any type of life-threatening complication if we don't administer it right now. So far, that's not looking like the best task. Option 2, assess the client who reports redness and pain at their appendectomy incision site. So whenever we have a surgical incision with redness and pain, what does that potentially indicate? It can indicate really a couple things. Sometimes just the trauma of surgery will cause some redness and pain, but it also can indicate infection. And so this is not necessarily an expected finding, but it is stable, okay? Right now, all it's saying is that there's some redness and pain. And we want to assess it, but it's not looking like the most important thing. And then you guys love option 3, and I agree with y'all. So assign assistive personnel to stay with the client reporting suicidal ideations with a plan. So we all know it's already concerning when your client is reporting suicidal ideations, but when they report they have a plan, they've typically thought about this, and there's a much higher likelihood that they'll make an attempt on their life. So that is a huge safety issue. So I think you guys are right, but let's take a quick peek at option 4. So provide discharge education to a frustrated client who's been requesting discharge paperwork for 2 hours. So I would also be frustrated if I was them and I'd been asking for paperwork for 2 hours, but ultimately that is a psychosocial need up here, which is a low priority. Now, certainly we want to use therapeutic communication, we want to address that need, but it's not posing any type of life-threatening risk. So I love option 3, and so do you guys. And so we got it correct. So y'all are doing amazing, by the way. I'm super, super impressed. Let's look at one final way that prioritization questions are formatted. And you don't see this type of formatting as often, but there's a chance you can see these. So I wanted to go ahead and throw it in so you're not shocked if you see something like this on the exam. So it says the nurse is caring for admitted clients involved in a mass casualty incident. The nurse must discharge a client to make a bed available for more injured clients. It would be most appropriate for the nurse to recommend discharging which client. So if we are planning on sending somebody home, we need to find the client that is least sick, or basically the lowest priority. So we're kind of working backwards. So our options are a contusion to the chest wall with a heart rate of 110, soot around the nose and mouth and a respiratory rate of 30, a headache and bruising behind the ear following a head injury, and superficial non-bleeding abrasions to the face and upper extremities. So let's take a closer look. So I see already a lot of people are making some guesses, but pay close attention, even if you think you know the right answer with this one. I chose this question for a reason. There is a lot of super high yield conditions we're about to talk about that you want to be able to recognize whenever you go to take the exam. So the first one, you have a contusion or bruising to the chest wall with a heart rate of 110. So we know that heart rate's a little bit elevated, so they are a little tachycardic and there's bruising. So what do you guys think? If y'all are working in the emergency room and you have a client that comes in with bruising to the chest wall and they're a little bit tachycardic, what are you worried about? Any specific condition come to mind? What do we think? And once again, like I said earlier, there is a slight delay in me being able to read y'all's comments. So I'm worried about cardiac tamponade. Okay, so if y'all remember that, there's that pericardial sac around the heart and it can fill up with fluid. And that heart can't pump as efficiently and you start seeing decreased cardiac output. So you're going to start seeing changes in the blood pressure. You're going to start seeing tachycardia. So the point to all that is, do we think that if a client has bruising of the chest wall and tachycardia, they are stable to go home? No. So that's going to be probably like a circulatory issue. And Irene, also you said pneumothorax, and that's, it could also be pneumothorax, anytime you have chest trauma. And so even still, that's a breathing issue. So either way, I don't want to send them home. And then option 2, this one I want you to pay close attention to these keywords. Soot around the nose and mouth, and respiratory rate of 30, which we know is a little elevated, so they're a little tachypnic. But anytime you see soot around the nose or mouth, or someone is coughing up sputum and there is soot in there, that means that they have breathed in smoke. So we are concerned about an inhalation injury. Now this is very life-threatening. Okay, a lot of times in the ER, which is where I worked for most of my nursing career, if somebody has an inhalation injury and they have any type of symptoms such as this increased respiratory rate, we go ahead and intubate them. The reason this is so dangerous is smoke is an irritant to the airway. And so as the airway gets irritated, it gets more and more inflamed. And before you know it, that patient can't breathe, but we also can't really stick an endotracheal tube down there because of all the swelling. So anytime you see soot around the nose or mouth or in the sputum, that is an indicator of a life-threatening condition and very high priority. So once again, it's airway or breathing. We are not sending them home. And then a headache and bruising behind the ear following a head injury. So any bruising behind the ear, okay, that has a name, battle sign, okay? Does anybody remember what injury that is usually associated with? If we see battle sign or bruising behind the ear, is there a specific injury we need to be worried about? Another thing you could see on the exam. It's going to be a basilar skull fracture, and that's also a life-threatening condition that can cause changes in intracranial pressure, that type of thing. So it could be a circulatory or a neurologic issue. Either way, they're all pretty high priorities on this pyramid. We don't want to send them home. And then I know y'all loved 4. And so we have superficial non-bleeding, keyword non-bleeding, abrasions to the face and upper extremity. So that is a stable client, and that person, I would feel safe sending them home. So we got it correct again. Okay, so once again, we certainly want you to approach these prioritization items very strategically, because once again, it usually typically involves many different disease processes, many different tasks. So you're having to use a lot of your comprehensive knowledge in order to have a really good overall picture of the different options. So please continue to practice, use our prioritization pyramid, check out our cheat sheet. And I'm gonna give everybody a second to ask any questions they may have. And while y'all are putting some questions in there, if you have any, I want to remind you guys to follow us on our socials. I know Miss Miriam has probably already shared those links. And I also wanted to just briefly show y'all our website. So if you go to bootcamp.com/NCLEX, you will see right away you can start studying for free, and we have some amazing resources. We have some really well-developed case studies, our cheat sheets, practice questions, and we've had a ton of really positive student feedback that it very, very closely mirrors the NCLEX. So by all means, please take a look and see what resources are available on that website. So let's see if we have any questions. Any questions, guys? Well, I just want to thank you all so much for joining us today. Once again, I know prioritization can be a challenging topic, and so I hope this helped you guys. Jennifer, well, thank you for joining us. I'm glad you're enjoying it. Okay, any questions? Okay, guys. Well, I hope you guys have a wonderful rest of your day, and please join us next week for our scheduled webinar then. Bye. Well, I know many of y'all are preparing to take NCLEX very soon, so my hope is that this webinar helps you a lot, because you're going to hear me say this a couple of times. You are guaranteed to see delegation on the NCLEX exam, so this should certainly help you. Also, if you have any friends or peers that you think would benefit from this, share the link so they can join us too. And this also is recorded, so you can watch it at a later date. So let's go ahead and get started. So before I do, I want to remind you guys, we have a very active Facebook study group. So please certainly send the link, invite your friends so you can stay up to date on what webinars we have next. We typically do a weekly webinar on many different topics. So today, throughout this presentation, we're just going to talk about the general principles of delegation and assignment making. We're going to talk about what the nurse's role is in delegation and also discuss a couple of resources that we should be thinking about anytime that we are faced with delegation questions. I forgot to introduce my moderator. Miss Miriam is in the chat, and she is also a wonderful nurse educator that's going to be answering any questions you guys have throughout this presentation. And once again, there is a little bit of a delay, so she's not ignoring you if it takes her a second to answer you. Okay, so back to the presentation. So the reason we think it is so important to talk to you guys about delegation, assignment making, and prioritization is because when we look at the NCLEX test plan, we can see that management of care is 18% of the exam. So it is the largest percent of the exam, even more so than safety and infection control. So that means when you go to sit to take the NCLEX, it's a guarantee that you will see those types of items. You will see delegation, you will see prioritization. So once again, guaranteed on NCLEX, and I want to remind everybody that when we're talking about delegation, that's not simply asking somebody to just perform a task for you. It's a very complex nursing skill that you really need to know, not only for the NCLEX, but for practice. Because as you all know, when you go to the hospital and you see those nurses, it is one of the most commonly used nursing skills. But if we do it incorrectly, it can get us into a lot of trouble. So we want to make sure that we really know what we're doing so that we can delegate safely. So I want to go ahead and let y'all know 2 helpful tips that's going to guide you throughout this presentation and whenever you're practicing delegation. The first one is we don't ever want to delegate tape tasks. Those are things that the registered nurse is responsible for. It includes patient teaching, assessment of your patient, developing the care plan, and evaluating the patient's care and their response to interventions. So those things we do not want to delegate. And also, I know you already know this, but I want to remind you guys, we never want to delegate tasks on unstable clients, okay? So we want to make sure we are only delegating for stable clients. So there are a couple of resources that can help guide us whenever we're navigating delegation questions that we really want to be familiar with. The first one is the provider scopes of practice, and the second one is the 5 rights of delegation. So let's look at those really briefly before we jump into some practice questions, which I know is what you guys came for. So the scopes of practice is just understanding what is it that our peers that are working on the unit with us can do. What is in their legal scope of practice that's safe for them to perform. So let's start with the UAP. The UAP has the smallest scope of practice, and I will tell you, most NCLEX questions on delegation are delegating to that UAP, okay? So the UAP can only ever perform care on stable clients. They should never complete any type of tape tasks. They should not perform any part of that nursing assessment. That is outside their scope of practice. And they are typically responsible for performing routine and non-invasive tasks. So when I say that, I'm talking about vital signs, hygiene like oral care, pericare, and once again, it's only for clients that are stable. And then there is the LPN or the LVN. That is the same role, but it's just different names depending on where you live. So LPNs, you won't see these questions as often as the UAP, but they can be a little trickier because their scope is a little larger than the UAP. However, the LVN can only care for stable clients, just like that UAP. LPNs can perform parts of the nursing process, but it's only after the RN performs them first. So they are able to help with reinforcing teaching after the RN has already provided it, and they're able to help monitor assessment findings after the RN has performed the assessment. So I know it can get a little tricky, but remember, when it comes to the nursing process, the registered nurse always has to perform that task first. And they can also administer medications, but it really depends on where you live, so you don't see those questions as often, but they are able to typically administer oral medications, that kind of thing. And then there is the RN, and we have the largest scope of practice. We are able to care for stable or unstable clients, and we are responsible for all steps of the nursing process. So the assessment, the planning, the evaluation, and once again, we should always be performing it the first time. And we also can do any tasks that are invasive and non-routine as well as routine tasks. And an example of invasive tasks that the RN might perform include hemodynamic monitoring and then also titrating like cardiac drips in the critical care unit. So hopefully that gives you just a brief summary of the general scopes of practice. Now, don't get too confused. I know I was an LVN, and I know many of y'all go to the clinical setting and see nurses, and you don't always see people following their scope of practice. But remember, this is what is accurate and appropriate when you sit down to take NCLEX, not what you necessarily see in the hospital or the clinical setting, unfortunately. Okay, so before we jump into questions, I want to show y'all one more thing. The 5 rights of delegation. So basically, this is just 5 questions that we should ask ourselves before we delegate a task. So the first one is the delegatee or the person that I'm asking to perform the task competent? Do we think that they have the appropriate knowledge and training to safely perform the task? And then we have to ask, is that task routine and within their scope of practice that we just discussed? And then we always need to make sure that that client is stable. Now, one thing I want to remind everybody about is we typically use delegation the most when we're very busy. However, that RN is still responsible for supervising. So the RN can't delegate a task and then leave the unit. That's not safe. The RN needs to be readily available to assist and to follow up on that task. And we also need to make sure that the delegatee has very clear instructions on when to perform the task, how to perform the task, and any information that they need to report back to you. And then lastly, as the registered nurse, we should always be going back after a task is performed to make sure the patient tolerated it well and that everything went as planned. So once again, these 5 questions kind of can give you a framework. So when you're thinking about if a task is appropriate, these are the kind of things you need to be thinking about to help guide you. Okay, so without further ado, let's go through a couple of practice questions and apply all that stuff that we just talked about. So the first question says, the registered nurse is supervising UAP. And once again, this is really the most common way I've seen NCLEX questions on delegation formatted, where it's the UAP we are delegating to. So which task would be most appropriate for the nurse to assign to a UAP? And our options are perform incontinence care for a newly admitted client who has a cervical spine injury, assist a client who had an above-the-knee amputation 2 days ago into the prone position, reposition a client with increased intracranial pressure who has decreased level of consciousness, and the last option, demonstrate use of continuous passive motion for a client who underwent a knee replacement. So let's look at each option a little more closely. So performing incontinence care for a newly admitted client with a cervical spine injury. So what do we think? Yes or no? Should we delegate this task to a UAP, an unlicensed assistive personnel? I know a lot of y'all are guessing option 2 already. We'll see. I always say that there's just as much knowledge to be gained from incorrect. So let's see if y'all are right. So option 1, I do not think it is appropriate to delegate this task. I agree with you guys, and let me tell you why. If we just see the words incontinence care, that seems like a routine task. And that's why it's very important that we don't just latch on to certain words. We have to look at the whole context. It's very important anytime you're sitting down and practicing questions or taking the NCLEX. Look at the whole content. So this is newly admitted client. So any client that is newly admitted is considered unstable because it is assumed that that registered nurse has not yet been able to perform a thorough assessment on that client. So that's a helpful NCLEX tip. Anytime you see newly admitted client or a client that just returned from a procedure, that is considered an unstable client. And remember, we don't ever delegate on unstable clients. But also, there's another learning opportunity here for us in this option. Anytime you have a client that has a spine injury and you need to perform incontinence care, that is not really a routine task. There is a special technique we use. I'm sure many of y'all are familiar with it, the log roll technique. So if we don't turn that patient very carefully with help, we can make that spinal injury worse. So that's really a non-routine task. And once again, our client is unstable. So I agree with you guys. I don't like that idea. So you guys love option 2. So let's see if y'all are correct. So assist a client who had an above the knee amputation 2 days ago into the prone position. So AKA 2 days ago. And I'm sorry, my handwriting is not the neatest. So we can assume that a client that had a knee amputation 2 days ago is probably pretty stable. And so we're just being asked to reposition them into the prone position. So do we like this idea? Yes or no? Are we going to delegate repositioning this client? So I agree with you guys that this would probably be appropriate to delegate, but we haven't looked at our other options. So this client, once again, had surgery 2 days ago, so chances are they're pretty stable, and all we're doing is repositioning them, which is a routine task. Now, bonus question. Why would we even reposition a client after an above the knee amputation into the prone position? Does anybody remember that? It's a little bit more challenging. Winnie, you said past 12 hours post-op are considered stable. Yeah, that's a good rule. Typically after that first 12 to 24 hours or so, that client is considered stable. So we want to prevent contractures. So placing a client that just had a knee amputation a couple days ago into the prone position, we're going to typically do that a couple of times throughout the day to prevent contractures. So great job, Leah. I'm super impressed. That was a bonus question for you. So once again, I like this, but let's look at our other options. So option 3, reposition a client with increased intracranial pressure who has decreased level of consciousness or decreased LOC. Do we want to delegate this? So I feel like most of y'all are going to tell me no, and I'm going to agree because we have a client who seems pretty unstable. Okay, decreased level of consciousness is typically not a good thing with any client. That is an indication your client is unstable. But we're also concerned because this client already has increased intracranial pressure and we are repositioning them. So what happens if I have a client with increased intracranial pressure and I position them incorrectly? Maybe I lower the head of the bed or I even place them in a supine position. What's going to happen? Anytime you have a client with increased ICP and you place them in a supine position or lower the head of the bed, what happens? And once again, there is a chat delay, so I'm sorry. Takes a little while for me to see your answers. It's going to increase that ICP more. So I can actually make that client a lot worse. So that is certainly, like I said, an unstable client. So we are not going to delegate that. So let's look at option 4. Demonstrate use of a CPM device or continuous passive motion device for a client who underwent a knee replacement. So that seems pretty simple. So do we want to delegate that? Yes or no? So I'm not going to delegate that, even though it sounds simple, because the words demonstrate use are just another way to say educate. Okay, so very good, Winnie. Teaching, yes. So we cannot have the UAP performing steps of the nursing process. They cannot do client teaching because remember, that is a tape task, which UAPs cannot do. So that teaching, okay. So we got that correct. So awesome job, guys. And I know that was a little bit of a simpler one to get you warmed up. So now I want to go ahead and do a little bit more challenging one, a select all that apply, which I know is everyone's favorite. But we're just going to take it line by line, like a true or false. So the nurse is caring for 5 clients on a telemetry unit, okay? Which of the following client needs can the nurse delegate to a UAP? So once again, we're talking UAP. So the first one, determining the pain level for a client that just received IV morphine, just received. So what do we think? Yes or no? Do we want to delegate this to a UAP? Yes or no? Determining the pain level for a client that just received IV morphine. So I do not like the idea of delegating this. Just like Linda, Winnie, I agree with all of you guys. Or false. Sorry, Dee Dee. Here I said we were going to treat it like a true false. False. So determining the pain level for a client that just received a pain medication is evaluating their care and kind of doing an assessment. So that is, once again, a TAPE task that we are not going to delegate to a UAP. Option 2, assessing a client's ability to swallow food prior to feeding them lunch. So this one is a very, it's easy in my opinion, only because the word is assessing. Right away it tells you that's a TAPE task, that's assessment. We're not going to delegate that. But also, if we're checking if a client can swallow food before feeding them, that is certainly something that we don't want to delegate, because if that client does have dysphagia or difficulty swallowing, we can cause them to aspirate and have a lot of complications. So no, I agree with you guys. Option 3, assisting a client admitted with pancreatitis to ambulate to the restroom. So remember, pancreatitis is just inflammation of the pancreas. You typically have some nausea, vomiting, you can have dehydration. Manu, you said, what's TAPE? So TAPE, you might not have been here for the previous part, so I just want to remind everybody, TAPE is those steps of the nursing process we're not going to delegate. So that is going to be teaching, assessment, planning, and evaluation. Great question. So I see a lot of yeses for option 3, and I agree with you. There is nothing in that option that indicates that that client is unstable. So it's just a routine task to help somebody ambulate to the restroom, so I love it. Option 4, assisting a client admitted with a myocardial infarction to perform oral hygiene. So a client with MI to perform oral hygiene. Do we like that? What do you think? And this is where I'm going to give you another helpful NCLEX tip. Don't overread, okay? Don't read into the question. I used to do that as a student. It's very easy to do, but don't do it. Because you could say, oh, myocardial infarction, that's a serious diagnosis. Maybe they're unstable. No, we're not going to go down that rabbit hole. We are going to just look at what they tell us. So I agree with you guys. That is a routine task, oral hygiene, on a client that is stable based on the information we have. Option 5, performing pericare on a client with an indwelling urinary catheter. Yes or no, or true or false? Do we want to delegate this? Yes, I agree that that is perfectly fine. Pericare is a routine task, and I know the client has an indwelling urinary catheter, but there is nothing to indicate they are unstable. So I think that is safe. But let me give you an example of when that would be inappropriate to delegate. Maybe it says perform pericare on a client with an indwelling urinary catheter with blood at the urinary meatus, or maybe they have bladder distension. Those are all indications that our client is unstable, and we would not want to delegate that. So option 6, recording the intake and output of a client with a history of CHF. Do we want to delegate collecting intake and output of a client with CHF? What do you guys think? So I think that is also a good option, just like you guys, because once again, intake and output is a routine task, and based on the information we have, this client appears stable. So let me give you another example of when this would be inappropriate. Maybe we have recording the intake and output of a client with a history of CHF with pink frothy sputum, or with crackles, or edema that's 4+. All those are indicators that the client might be in fluid volume overload or have pulmonary edema and would not be considered stable. But once again, we're not reading into things, so I agree with you. And then last one, this one kind of tricks people up a little bit. Performing vital signs on a client that just returned from the cardiac cath unit. So the cath lab. What do we think? Do we want to delegate this? Because a lot of times people see vital signs, and that's one of the most common tasks that's delegated. So they see that word, vital signs, and they just want to say yes. But y'all are on the right track. Lindy, Manu, Winnie, great job. No, because once again, as we said on the previous question, just returned or newly admitted or newly arrived, all of those tell us that that patient is unstable, and we are never delegating on an unstable client. So options 3, 4, 5, and 6, and we got them correct. I'm super impressed with you guys. Y'all are doing an amazing job. So let's do one more question, but let's change it up a little bit. So the last 2 items were delegation, so let's try assignment making. It is not as common, but there is a chance you still may see it, and I want you guys to feel confident when you do see an item like this potentially pop up on NCLEX. So instead of delegating, it is making safe assignments for a client. So a charge nurse is making client assignments for a critical care step-down unit. Which client would be most appropriate to assign to a new grad RN? And I know some of you might be thinking, well, we just talked about scope of practice, and the RN can care for any patient. And you are right. But remember, we are at that magical NCLEX hospital where staffing is perfect and we can be very selective. And so we want to give that new grad a very stable patient with a simple care plan, okay? Even though they can care for any of these. So option 1, a client admitted for diabetic ketoacidosis on an insulin drip, a client who is scheduled for discharge today with a new colostomy, a client scheduled for a pacemaker insertion procedure during the shift, and a client admitted for postoperative infection who's receiving IV antibiotics. And I know a lot of you guys are making some great guesses right now, so let's talk about each option in a little more detail and tease out some more learning. Option 1, the client admitted for DKA that is on an insulin drip, which means IV insulin. So why would I not want to give that to a new grad? Because I didn't see anybody guess option 1. It's because that client with diabetic ketoacidosis typically has a very complex care plan, especially if they are still in an early enough or acute enough phase to require IV insulin. It's typically going to be very frequent glucose checks, hourly or more frequent, and they are getting IV insulin, which is one of the most high-risk drugs we can give, okay? If we accidentally bolus insulin, there's a good chance that we can that patient can code. So that is a complex care plan that I would really ideally like to assign to a nurse that has a lot of experience administering IV insulin and caring for clients with DKA. So option 2, a client scheduled for discharge today with a new colostomy. Okay, so discharge today sounds pretty simple, but I didn't see a lot of people guess that. So why do we not like that option? Well, when a client has a new colostomy, that is going to require a lot of client education. They need education on site care to prevent infection, excoriation, but also a lot of psychosocial and discussion of lifestyle modifications and that type of thing. So ideally, you want to give that to a nurse that has a lot of experience with colostomies, wound care, that type of thing. So I agree with you guys. Option 3, a client who is scheduled for a pacemaker insertion procedure during the shift. And I didn't see a lot of people guessing option 3 either. Why? Why would y'all not want to assign that to a new grad nurse? Client going for a pacemaker. Well, when a client returns back from their pacemaker insertion, we have to very, very closely monitor their cardiac rhythm. We have to make sure everything's working properly, make sure that they have adequate perfusion, and a lot of things can go wrong there. So you really want a nurse that has a lot of experience with cardiac rhythm interpretation or ECG interpretation. So ideally, you'd probably want a more experienced nurse if you can. And y'all are correct. Y'all also said that there's a lot of teaching associated with the surgery, and that's true too. A lot of times patients will have a lot of questions before and after surgeries. And then the last one, y'all all love this, and I agree with you guys. The client admitted for a postoperative infection who's receiving IV antibiotics. Ideally, that is a very simple care plan and will typically just require monitoring vitals, administering antibiotics, that type of thing. So I agree with you guys. But let me give you an example of when maybe that wouldn't be the best client. Maybe it says a client admitted for a postoperative infection, receiving IV antibiotics, who now has tachycardia, hypotension, elevated lactate levels. What would that indicate? Somebody that has an infection who now is hemodynamically unstable. They're tachycardic, hypotensive, having an elevated lactate. Can anybody tell me, bonus question, what you would be worried about if that was your client? What do we think? So I'm going to be worried about sepsis. So in that case, I am not going to want to give that to a new nurse. Okay, and look at y'all, Stephanie. Awesome, very good job. Shock, Mary, yeah, septic shock, same principle. Very good, guys. So we got that correct as well. So once again, and if y'all have any questions, once again, there's a little bit of a delay, so feel free to type in your question, and I'm just going to briefly recap what we talked about. So I want you guys to keep practicing delegation items because they are guaranteed on the NCLEX. Remember, NCLEX is a safety exam, and delegation is one of the biggest safety issues that nurses have to deal with. So keep practicing delegation, get comfortable with it, look at your 5 rights of delegation, make sure you feel comfortable with the scopes of practice of the UAP, the LVN, and the RN. And then remember, we never delegate our TAPE tasks, our nursing process tasks, such as teaching, assessment, planning, and evaluation. The registered nurse needs to do those, especially initially. And then remember, we are not delegating tasks for unstable clients. They must be stable for us to delegate tasks on them. Okay. I also want to remind you guys that at bootcamp.com, we have some wonderful cheat sheets. We've been hearing some great feedback from students on these, where we've pretty much consolidated all the important things you need to know about delegation into this cheat sheet. And there is additional information that we did not discuss today, such as this delegation flow chart that will really help you. So please go to bootcamp.com and check that out. So here's our website, and also remember to follow us on socials if you have them, and share us with your friends and your peers. So let's see what kind of questions we have. Lakita, where can we find more delegation questions? Okay, so bootcamp.com/NCLEX. We certainly have a bunch of delegation items there, as well as additional assignment making questions. Okay. Well, I thank you guys so much for joining us. I hope you'll join us next week for our next webinar, and I hope you guys have a wonderful rest of your day.
All right. Well, we will go ahead and get started. So I'm Miriam, and I am one of the content creators here at NCLEX Bootcamp. And we have Amber. She's in the chat. She's going to be getting to all your questions, putting some helpful links in for you guys. So keep a lookout in the chat for her. There usually is a lot of people that join, so just have patience as we try to get to everyone's questions, but we promise we will get to them. So before we get started, if you guys haven't joined, I just want to show you our Facebook page. We have a NCLEX Bootcamp Facebook page that you guys can join, and feel free to invite your friends to join as well. We post questions in there. Students help each other through different questions, and we'd love to have you on that platform as well. All right. So we are going to cover dosage calculation, obviously, and there are two different methods we're going to use. So dimensional analysis and ratio proportion. Who here is more of a dimensional analysis person, or are you more of a ratio proportion person? What do you prefer? I am really more of a dimensional analysis person. Ratio proportion, once I figured out that there's some specific steps to follow and understood that, it really helped. So we'll definitely cover that as well. So in practice and clinical and school, you might be given like a picture of a medication label or just written orders, and you could be asked to work backwards. You could see, is this the right medication to draw up? These different things happen in practice every day, right? So it happens all the time. So we want to be able to move quickly to convert units and move back and forth to determine if the client's receiving the correct medication, the correct dose.
So these approaches are going to help us solve our dosage calculations. So these two methods, we have dimensional analysis, like I said. So this gives us more of a standard approach. You plug all your numbers in, you make sure your units cancel out, and you solve. And then our ratio proportion method is going to use fractions to compare that relationship to solve for X. Okay. So let's talk first about some steps for dimensional analysis. We'll talk about steps for ratio proportion, and then we're going to get to some actual problems to practice together. So here are just some simple steps for dimensional analysis. So first, what you want to do is always compare what you have versus what is desired. So what you have is going to be that med label. And then what's desired is going to be what you're trying to figure out, what you're trying to solve for. So maybe it's tablets, maybe it's milligrams, milliliters. Maybe you just have to reconstitute some medication and determine how much liquid medication to drop. And then you're going to set up your middle of the equation and make sure that your units will cancel. You'll multiply across, we'll divide. And then of course, our last step is always going to be checking, making sure we're rounding properly and verifying that that work that we've done makes sense. So when we get to our ratio proportion method, this is where we have some specific rules to follow that we'll get to. So our steps are sort of similar here. We're going to identify our known and our unknown. So again, that med label, what do we have? What are we trying to find out? You're going to set it up as a proportion. So that's a fraction. And then you're going to cross multiply and solve. Now you will work between steps 2 and 3. You'll go back and forth between those steps several times until you get to your desired units. So afterward, of course, we're going to verify. Same thing as our dimensional analysis. We want to make sure that we've done the math correctly. We can plug our numbers in to make sure it all makes sense. Now, these are the rules that we want to follow. So we want to make sure when we set up our proportion that the units and the numerators match. So if we have milliliters at the top, we need milliliters on both sides of the fraction. We have units matching in the denominator as well. And if they're not matching, something seems off, we're going to convert. So you have to make sure that you follow those rules. Okay, so let's take a look at this. Now, we are going to get to harder problems, I promise. This is just a quick little setup. I wanted to give you guys a problem where you probably don't even have to think hard through it. You could probably solve it without setting it up, but just to show the basic steps for dimensional analysis and then for ratio proportion. So we have here 1 milligram per 1 ml. We have an order for 2 milligrams to give daily, and we need to figure out how many mLs we're going to administer per day. So for dimensional analysis, we are going to put what we have on the left and then what we're trying to solve for on the right of the problem. So on the right, I'm trying to solve for my milliliters that I'm going to give per day. And on the left side, I'm going to put something that I already know, which is what I have here, this 1 milligram per 1 ml. So I'm going to put my 1 ml and over 1 milligram. Now, what I like to do when I'm doing these problems is to kind of check it off as I go so I don't accidentally re-enter information. For a problem like this, there's not a whole lot of facts. You might not have that problem, but if you have a lot of conversions happening and things like that, it's easier to check them off as you go just to save yourself any errors. So I'll plug in the middle now. So I have 2 milligrams daily. Now, I need to get my milliliters to cancel off, right? Or and keep my milligrams. So that's what I'm trying. Sorry, I just said that wrong. Reverse, ignore that I said that. We need to get to our milliliters per day. So we need our milligrams to cancel out. So we're going to put 2 milligrams on top, and that's per day. And the reason why we do that is because when we multiply, our milligrams are going to, when multiply and divide, our milligrams are going to cancel out. So you see that we'd be left with milliliters per day. So we multiply here, just our 1 times our 2, we get 2, and of course our 1 times our 1. So we see that we'd be giving 2 milliliters per day. Now let's look at the same problem using our ratio proportion method, and you guys just need to pick whatever method is going to work best for you and you stick to that. But we want to go over both of these since these are common methods and make sure that everybody is getting helpful tips for these dimensional analysis problems. So for this to set up with ratio proportion, as we read this, we can say that 1 milligram equals 1 ml, right? Because that's our volume. We know that that's the amount in 1 ml. So that's our relationship, 1 milligram over 1 ml. And then what we're trying to find out here is we are trying to figure out how many milliliters, so X milliliters that we're going to be administering. So when we set this up, we know that 2 milligrams, our relationship is equal to X mLs, right? Does that make sense? We want to be able to make sure that we're figuring out how many mLs we're going to give to get 2 milligrams. So remember those rules. We have to make sure our numerators and our denominators match. So we have milligrams on the top, we have milliliters on the bottom, so now we can cross multiply and solve for x. So when we cross multiply here, we get our 1x equals 2, and of course we have to divide by 1 to get x alone. So we see that we're going to be giving x equals 2 mLs. So we got the same problem here. We can of course verify our work, plug our numbers back in to be sure. All right, so let's get to a problem that is more likely to be what you will see on the NCLEX or on your dosage exams. So these dosage calculations are considered standalone fill-in-the-blank questions, and the questions that I've selected are right from our question bank that we have on NCLEX Bootcamp. So we will solve each one with dimensional analysis and ratio proportion just to break down the steps. So reading this question, the nurse is caring for a client taking acetaminophen 2,600 milligrams per day in 4 divided doses. The nurse reviews the medication. How many tablets per dose does the nurse expect to administer? And we're going to record our answer using a whole number. So after reading this, we can see we have our rounding rule, which is we're going to a whole number. And we can also look to the right of the answer blank to see what we're trying to solve for, which here is tablets. All right, so let's apply everything we've learned in our next step here. All right, so what do we have? What do we know in this problem? We have this medication label, right? And we're given information within the problem. So we have this tablet of acetaminophen in our hand, or the label, and we see that we have our medication concentration is 325 milligrams per tab. We see that our ordered dose here is 2,600 milligrams per day, and that we are giving this in 4 divided doses. So now when we look at this equation, the next step we'll see is what we're trying to solve for. So let's look at our next step. So here we see, what are we trying to do? What are we trying to figure out? And we are trying to solve for our tablets. So we want to know how many tabs per dose we are going to give, right? So now we have some things that are given. We have all this information and we can start plugging it in. So we're going to set up our middle. So when we set up our middle, what do we set up on the left? Do you guys remember? On the left, we put something that's known, right? And on the right side, we're going to put what we're trying to get to. So on the right side, we'll see we are trying to get our tabs per dose. And on our left side, we can take any of our given information here, so like our 2,600 milligrams per day. And then we'll plug in the middle next. So let's get to our middle. All right. So I'm going to check these off because I have already plugged them in and don't want to re-plug them in. So next I can put my 4 doses per day. So where would I put day? Would I put day on the top here or day on the bottom? Remember that we need days to cancel out because we are not finding per day over here. So what do you all think? Are we putting days on the top or the bottom? We're going to put per day up top and 4 doses down below. And that's because we have day down here and that will cancel off. So here, if we were to solve, we would be left with milligrams per dose, which is not quite what we're looking for, right? We're trying to get to this tabs per dose. So I'm going to check that off that I've plugged it in and go to my last piece here, which is our 325 milligrams per tab. And I will plug that in. So here I need my milligrams to be on the top or the bottom. Do we need our milligrams to cancel? We see that we need tablets per dose. So I will put my 325 milligrams on the bottom and my tab on top. So by doing this, my milligrams cancel and you see that we're left with tabs per dose, which is exactly what we're trying to find here. All right, so now that we've set up our middle, we can go ahead and multiply across. So here we have 2,600 times 1 times 1. We have easy math to start. That's nice. 2,600. And then down here we do our 1 times our 4 times our 325. And what did you guys get? We get 1,300. So we have 2,600 divided by 1,300. So now we can do our division step. So what do you get? 2,600 divided by 13. And we're going to be left with 2 tabs per dose. right? So the last step that we have to do is always verify, right? We have to make sure that our math made sense and that everything we're doing, we're giving the correct dose. So I like to think of it as you're not getting some crazy number like 2.3, right? Or you're not giving your client 15 tablets. So I think of it like that. We plug the numbers back in. We also want to make sure that the number we got, if you were to plug it back in, that it all equals out. And 2 tabs per dose is our whole number. We said we were to round to the whole number. We have no rounding that's necessary here. We have that whole number. So we are good with our 2, and we see that we're correct. All right, so we're going to do this same problem, but we're going to use it with ratio proportion before we move on to another problem. So we've already worked this problem. We know all our knowns and our unknowns. So we're going to plan out our steps. When I plan out the steps for ratio proportion, it just helps me see it all. So hopefully that helps you guys too. So you're going to take we know we have our milligrams per day, right? So we can take our milligrams per day, and we can take that and figure out our milligrams per dose, since we know there's 4 divided doses. And then we can take it and get to milligrams, to how many milligrams per, oops, I think I miswrote. One moment, let's go back. Okay, so we get to our, maybe I didn't, milligrams per dose. And then we can get to our tabs per dose that we're going to give. Okay, so once we know that, we can set up our proportion, right? And make sure that our units match. So we need to set the proportion, and we know that 2,600 milligrams is in 4 doses, right? That's our relationship. So we're going to write that. And then we want to figure out how many milligrams, so that's X milligrams, is equal to each 1 dose. So remember that we always have to make sure our units match. So here we see we got milligrams on the top, we have dose on the bottom, so we are good. We can go next to our cross multiplication here. Okay, so when you cross multiply, you're going to get your 4x equals 2,600. And of course we have to divide by 4, right? Because we need to get x alone. So x equals, what did you guys get? Did we get 650 milligrams? And so we see that that's going to tell us our milligrams per dose, right? But we still have to do another proportion. Remember how I said with those rules, those steps, you go back and forth between setting up proportions and solving for it until you get to your desired unit. So next, we're going to take this 650 milligrams to figure out how many tabs per dose. So we're going to set up one more proportion. So when we do that, we take our 650 milligrams of tablets, and we need to know how many tablets to give, right? So we need that relationship. 650 milligrams, we want to know how many tablets that is, so X tabs. And then what we know is our 325 milligrams are in each 1 tab. So now we can just verify again that our units all match, and they do. And so we can do our cross multiplication. So when we cross multiply here, we get 650 equals our 325x. And of course, we have to divide by our 325 to get x alone. And we see here that we get the same, x equals 2 tabs, which makes sense, right? So we just do our verification here the same that we would with our dimensional analysis. We're checking, make sure the number plugs in, and checking to make sure we have round properly. We see that that's correct. All right, so our next step we're going to do, our next problem is going to be a little bit more challenging, but you guys are ready for it. So this one is going to have a weight conversion in it. So let's read it together. The pediatric clinic nurse is reviewing the medication for a 2-year-old client presenting with acute otitis media. The nurse has an order to administer amoxicillin 90 milligrams per kilogram per day, divided into 2 doses. The client weighs 24 pounds. How many milliliters per dose should the nurse administer? And we're going to record using one decimal place. And what we're trying to solve for right there we see is our milliliters that we're trying to give. So we can ask ourselves here, what do we have? We are holding this powdered suspension in our hands, this amoxicillin, and we see that there's 400 milligrams per 5 mLs on this label. And then we have some knowns that we are given. So we know that our ordered dose is this 90 milligrams per kilogram per day. And we know that we're giving it in 2 doses. And then our dosing weight is 24 pounds. And of course, we're going to have to convert that to kilograms. Okay. So next, let's talk about what we need. And remember, we find that to the right of the answer blank there, and that's going to be how many milliliters we're going to give per dose. So now that we know that, we can start with our given weight and we can do this conversion. So conversions always used to through me. I had to really think about it. But when I set it up with dimensional analysis, it just helps because you can see everything cross off. So I'm going to start with my given weight. And we're going to eventually get to how many milliliters we're going to give per dose, right? So we're going to write our 24 pounds. And what's our conversion here? We're going to put that over 1. But we're going to think about what the conversion is for when we add that for our next step and do the conversion. So how many pounds are equal to how many kilograms? What we're trying to find is our milliliters per dose. So now we'll set up the middle and do that conversion. All right, so what did we figure out? Does anybody have any clue what our conversion is here? I'm going to check off the things I've already plugged in. Any idea how many kilograms are in 1 pound? So we're going to put 1 kilogram on top over 2.2 pounds. So this way our pounds will cancel off, right? So we know that there's 2.2 pounds per kilogram. So next we're going to go to our next step here where we can pick any of the other items to plug in, and we will, great. Now I see you guys, I know the chat's a little delayed. So I see all y'all with your 2.2, perfect. So we will put in our 90 milligrams per kilogram per day. So we need our kilograms to cancel. So we'll put 90 milligrams on top per kilogram per day. So this is going to allow me to cancel off my kilograms. And if I was to solve now, I would just be left with milligrams per day, and we're trying to get to milliliters per dose. So we still have more things to plug in. So I'll take this next one, 2 doses per day. And where will I put my days? On the top or the bottom? If we're trying to get them to cancel. Right now we have days on the bottom here. So we'll put them on the top here, right? So 1 day, 2 doses. And we see that our days will cancel. And here we'd be left with milligrams per dose. And so we have 1 more to plug in here so that we can get to our milliliters per dose. Whoops. There we go. Okay, so 400 milligrams. Where are we going to put that? On the top or the bottom? Put it on the bottom, right? Because this will cancel. So our 5 mLs. So just checking to make sure all our units cancel here, and they do, and we'd be left with milliliters per dose. So now that we've set up our middle, we are going to get to our next step, and that is going to be to multiply. So when we multiply across here, this is going to be bigger math for us. 24 times 1 times 90 times 1 times 5. So we get 10,800 there. And then we'll multiply across the bottom as well. So 1 times 2.2 times 1 times 2 times 400. So we should get 1760 or 1,760. So now we can do our division. So when you divide this 10,800 by 1,760, what do we get? We get 6.1363. And of course, we need to round, right? And it said that we were going to round to 1 decimal place. So when you do that, how do we do that? We're going to look to the right of the decimal. And if it's 5 or above, when we look over here, we would round up. But it is a 3. So it's less than 5. So we get to drop all this. So we're going to give 6.1 mLs. So does everybody agree with that? We get our 6.1. You can plug the numbers in. We know we got to make sure that this makes sense. You can look back at your ordered concentration and see that label, that it made sense with that. And so we see that 6.1 is correct. All right, so let's now tackle this problem using our ratio proportion method. So we have to plan out our steps first to solve for our desired units. So we're going to take our pounds and then we're going to convert that over to kilograms. And once we do that, then we can figure out how many milligrams per day. And then we can go from there to figure out our milligrams per dose. And then our last part will be to solve to get milliliters per dose. So now that we know these steps, we can follow along, check them off, and make sure that we're plugging everything in. Now, we do have to convert this weight, right? Because we would not have the same unit of measurement. So we need to get our pounds over to kilograms again. So we are going to put our 24 pounds over X kilogram because that's the relationship that we're trying to solve for, what we're trying to figure out. And then we'll put our conversion factor over. So we can put our 2.2 pounds over 1 kilogram because that's our conversion. So when we do that, of course, we need to verify, right? Our units match, and they do. We have pounds on the top, we have kilograms on the bottom, and then our next step will be to cross multiply and solve. So here we cross multiply, you're going to get your 24 and your 2.2x, and of course we have to divide by that 2.2 to get x alone and solve for x. So what do we get here? X equals 10.9 kilograms. Okay, so now that we know that weight, we can go and do the rest of our proportions. Remember, we're working through those steps, those 2 and 3 steps over and over until we get to that desired unit, which is our milliliters per dose. So we have our 10.9 kilograms. And now we can plug in our information. So we need to know how many milligrams we're going to be given based on this weight that we figured out. So we want to find out the relationship between kilograms and milligrams. So we're going to put X milligrams because that's our known, or our unknown, sorry. So X milligrams over our 10.9 kilograms because that's the relationship we want to figure out. And then we're going to compare it to our known, which is our 90 milligrams over 1 kilogram. Of course, we need to verify our units match, right? We have the same units on the top and the same units on the bottom. So we can go ahead and cross multiply. All right, so as we cross multiply, we get our 1x, and then we have to do our 90 times our 10. So we get 981. So x equals 981 after you divide by that 1. Okay, so we know that we are going to give 981 milligrams per day. So we've gone from pounds to kilograms. We figured out our milligrams per day. And next we can reset up our proportion with this number to find out our milligrams per dose. Okay, so when you look at this, what is the 981 milligrams telling us? It's telling us that that's the dose in 1 day, right? But we want to figure out how much is in 2 divided doses. So we are going to set up our 900. Sorry, my screen went a little crazy. 981 milligrams. And that's over 2 doses, right? That's our related facts. Okay, and then what do we need to find out? We want to figure out how many milligrams or X milligrams are going to be per 1 dose. So we verify, of course, that our units match, and then we can cross multiply. So we do our 981 equals 2x, and of course we have to divide by 2 so we can get x alone. And what do we get here? X equals, you should get 490.5 milligrams. Now, keep in mind, we don't want to round yet, right? We don't want to do anything with that 5 yet. We're going to save all our rounding until the end. So we have 490.5 milligrams, and that's how much we're giving per dose. So we have one more proportion to set up. So hang in there. We're almost there. We're going to get to our milliliters per dose. Okay, so we know our 490.5 milligrams. So we're going to take that 490.5 milligrams, and we want to figure out how many milliliters that is, right? So we're going to put that over X mLs. And we have our known over here that we have 400 milligrams per per 5 mLs. Okay, so when we plug this in, we say our units match, right? Are you tired of hearing me say that? We just got to always make sure. So our units match, we have milligrams on top and milliliters on the bottom, and now we can cross multiply. So when we cross multiply here, again with our big math, we're going to get 490.5 times our 5 equals 400x. So what's our 490.5 times 5? We should get 2,452.5 equals 400x. And of course here we have to divide by our 400 so that we can get x alone. So what do we get here? Did we get that 6.1 again, or really the 6.131, right? And so the same thing here, we're going to do our rounding to verify. So, and we know that this makes sense, right? So you can think we had that dose was 490.5 milligrams. We knew that there were 400 milligrams in 5 mLs. So of course it's going to be slightly over that 5 mLs, right? So our 6.1, and of course you can go back and plug your numbers into your X's and make sure, working backwards, that it all makes sense. So we see that we're correct. I hope that this was helpful for you all. You can find us on our other socials. Of course, you already found us here on YouTube, but this will also be streamed over on our Facebook page. Please remember to sign up there or join the group, and invite your friends to join as well. We love to have all you students there getting helpful information and helping you all pass your NCLEX. You can also find us on Instagram and TikTok as well. And Amber's going to be putting helpful links in the chat for you all if she hasn't already. We have a study calendar and new cheat sheets that are free to you all, so use them to help you. And then if you guys have any other questions, feel free to put them in the chat and we will get to them. You're welcome. I'm glad it was helpful. Dosage calc is not easy, so give yourself some patience and just keep practicing the problems. There's a lot more dosage calc practice over on NCLEX Bootcamp for you guys to practice with and use these methods. All right, well, we will see you guys next week. We're having one on answering Bowtie questions, so I hope that you will join us and just keep a lookout for when that will be scheduled. Well, while we're waiting for everyone to join, let me get this up here. I'll introduce myself. So I'm Miriam. I'm one of the NCLEX content creators here at Bootcamp, and my focus is on the OB content. And I work with a bunch of other amazing nurses to help get you all the content you see on Bootcamp. And Krista is in the chat, so she'll be moderating and responding to comments. So feel free to throw any questions that you have in there. She'll be putting links to resources and other helpful links, so be on the lookout for her in the comments as well. All right, so if you guys haven't, if you go over to our NCLEX Bootcamp page on Facebook, you will see a link to join the group. It just answers some questions, and you can share that group with your friends, and we would love to have you all there. All right, so let's get started on this Bowtie webinar. So we are going to be talking about what a Bowtie question is. We're going to talk about how it's scored. Everyone, of course, wants to know what are the chances they're going to see one of these on their exam, on their NCLEX exam. So we'll talk about that, and then we're going to practice one together. And hopefully I'll give you guys some tips to get through that. So before we go into, everything this webinar, I want to touch base with you guys on what a Bowtie question is and what it's really looking at. So it really assesses the clinical judgment. And I know a lot of this might seem like foreign language, but it'll make more sense as we go through the webinar. So there are 6 steps of the clinical judgment measurement model, and that's what is being tested on these Bowtie questions. So we are going to be looking at how we recognize cues, analyze cues, prioritize hypotheses, generate solutions, taking action, and then evaluating outcomes. And we're going to break each of these steps down as we go through our Bowtie question. Okay, so what is a Bowtie question? Great question here. So parts of the Bowtie, you're going to be given your instructions, and those are pretty standard. It's telling you to complete the diagram, and it gives you all the information you need. Then you're going to have scenario and data tabs. Now, the scenario is going to be like what's happening with the client. You might have data tabs that could be vital signs or head to toe assessment. It could be nurse's note, progress notes. Anything is fair game there. So you're going to look through all your data tabs when you get these questions. Then you have these headers that you see here. So you are given actions to take, potential conditions that they're experiencing, and then parameters to monitor. So each of these answer options on the side are going to have 4 to 5 choices, and then you'll have 4 in the center here for what their potential condition is. And then of course our answer spaces up here at the top. You'll drag your responses in there, and it's going to make what looks like a bow tie. All right, so will you see this on your NCLEX? So the question here, or the answer here, is that they show up after you've completed 85 questions on the NCLEX, or it could show up before as a pre-test item. So you might see it, but if it's before 85 questions, it's a pre-test item. And then scoring. The good news with these bow tie questions is that they're partial credit, right? That's really helpful. So you're not going to get, it's not all or nothing. So you're going to get 1 point for each correct, and you can get a total of 5 points. All right, let's talk through some strategies, because that's what's really important here to help you as you're taking on these questions and know how to approach it. So first, you're going to read the scenario, review any of the data tabs. So up here, you can see this one has a health history and vital signs. So you're going to review those in their entirety. As you read through those, I want you to ask yourself if each finding is normal and expected, or if it's abnormal and concerning. And as we go through the example today, I'm going to be asking you all to tell me if you think it's normal and expected, or if it's concerning. Then you're going to consider each of these columns separately. So you're going to take it on one by one and think of them either as a multiple choice question or a select N question. So in the center here, when we're picking our potential condition, we're going to pick that first. We have to know what the client's experiencing in order to know what actions to take and what parameters to monitor. So this is going to be a single best. You have 4 options, ignore everything else, and pick what is most likely occurring for this client. And then you're going to look at your left and your right columns and determine actions to take and parameters to monitor. And this is looked at as a select N, which just means you're selecting 2. N is standing for the number that the NCLEX wants you to pick. And here they want you to pick 2 from each. So you'll pick 2 actions and then 2 parameters to monitor. All right, so let's dive into one together. So our instructions are to complete the diagram by dragging from the choices below to specify what condition the client is most likely experiencing, 2 actions the nurse should take to address the condition, and 2 parameters the nurse should monitor to assess the client's progress. Okay, so let's look at our data tabs first. So we see that we're caring for a 34-week pregnant client, and the nurse reviews the health history and vital signs from 0900. So in our health history, we see a client who's 34 weeks pregnant. She's a G3P2 and is being seen in the obstetrician's office for a routine prenatal appointment. She reports experiencing mild lower abdominal cramping and small amounts of bright pink vaginal spotting yesterday evening. She also notes recent occasional dyspnea, and the client reports a mild headache for the last 2 days and not feeling the baby move very much today. Okay, now let's take a look at our vital signs. So in our vital signs, we see that we have a temperature of 98.2, our pulse is 80, respiratory rate's 20, we have blood pressure of 122/81, our pulse ox is 97%, and the pain is 2 out of 10 for a headache. All right, so we need to recognize our cues. That's going to be our first step. So this is where we're looking at what matters most here. So looking at this information, what things were concerning for you guys? What things did you see? What did we think about her being 34 weeks pregnant? Is that term or is that preterm? There's a little delay, so I'll give you all a second. So we have that she's 34 weeks pregnant. And yeah, so some people are saying baby not moving. I see that that's a concern. Okay. So we know bright pink vaginal spotting, preterm. Great. Okay, so our 34 weeks pregnant, we know she's preterm. So we don't really want to have a baby yet. We see that she is experiencing mild lower abdominal cramping and small amounts of bright pink vaginal spotting. What do you guys think of that, about that? Mild lower cramping, what could that be? Awesome. Everyone's agreeing that the preterm is a concern. So when we see that we're having cramping, that can indicate signs of labor. And this bright pink vaginal spotting, what do we know about that in labor? So we could have this as the cervix at faces, you have what's called bloody show, and it can cause this bright pink spotting to happen. Now, bleeding in pregnancy is always concerning and could mean many different things. But when we have this cramping, we have bright pink spotting, this is concerning for, I see preterm labor. Great. So we're concerned about that. Definitely need to look at that further. What do we think about this dyspnea? Are you all concerned at all about the dyspnea that she's having or this headache? When you guys see a headache in pregnancy, what do you automatically think of? What's something we might think of? Do you think about preeclampsia? So with preeclampsia, that's that hypertensive disorder that happens in pregnancy, right? And what happens is we have this elevated pressure and it's going to cause a headache. But her blood pressure is looking okay, right? It's 122/81. So I'm not too concerned about that headache. If her blood pressure was elevated, then we'd be worried, with the proteinuria, all of that. But since she has just a 2 out of 10 headache, her blood pressure is okay. I'm not super concerned about that. Now, she hasn't felt the baby move very much today, and I saw somebody had put that in the chat for a concern. But maybe maybe the baby's been in a deep fetal sleep state, maybe something we need to look at, definitely. But I'm not super concerned about that because maybe she just hasn't noticed the feeling yet, felt the baby move as much. What about in her vital signs? Do we see anything? So she had some dyspnea, so difficulty breathing. But what do we know as that we get further in pregnancy? What happens? That baby grows, takes up space, and our lungs can't expand, right? So we see that she has a slightly elevated respiratory rate, but it's just at 20, so not super, super concerning. And because we know that that baby is just in the way of breathing, it's kind of expected towards the end of pregnancy. We see her temperature looks good, pulse is good. So now we're going to keep all that in mind. We also see that she's 97%. So that makes me feel better about her dyspnea as well, right? Okay, so I see stable vital signs. For the most part, yes, we have stable vital signs. So let's take a look at our next step in this judgment model, which is the analyzing cues. So what could these findings mean? And so many of you already said preterm labor, right? But let's take a look at all of our other options as well. So we have placenta previa here. What do you all know about placenta previa? What are some symptoms of placenta previa? If you remember, placenta previa is when that placenta implants low over that cervical opening, as you can see in the bottom right picture. So it implants low over that cervical opening versus up high here at the fundus of the uterus, or the anterior side. So placenta previa, what does it cause? What are some symptoms? We're going to have vaginal bleeding, right? Yeah. Okay, so what is characteristic? Yes, so I see... I can't read. My eyes are blind today. The font is small, but somebody said we have painless bright bleeding, right? That is absolutely correct with placenta previa. But she's experiencing some pain, right? She's having these contraction pains or uterine cramping, as she said. So I don't think that it's previa because of that. If she was having painless vaginal bleeding, or if it was bright red where we have that bright pink color instead, then I might be concerned that it's previas. And previas are also usually diagnosed earlier in pregnancy, so it probably would already be known. Our next option here is a pulmonary embolism. So what do we think about a pulmonary embolism? What is it? It's a clot, right? And what happens is that it's going to block here, an embolus in that pulmonary artery, going to block blood flow. Does anyone think that it could be a PE? What's making you think it, or what makes you think it's not? We kind of already talked through some of this. We have that slightly elevated respiratory rate, right? But again, that's expected at the end of pregnancy. And our pulse ox was normal. So as you see here in pregnancy, as that gravid uterus grows, that fetus grows, that uterus grows, it's going to push up on that diaphragm. And so what happens is when we take a deep breath, that diaphragm cannot move fully down to allow those lungs to expand. So I'm thinking PE is not likely. It looks like you all are still agreeing with that. So our last option here is an intrauterine fetal demise, or an IUFD. So an IUFD occurs when we have a fetal loss that happens after 20 weeks gestation. So she is after 20 weeks gestation. Do any of our findings indicate an IUFD? So she hasn't felt the baby move much today, right? So we definitely need to assess that, but it could just be a deep fetal sleep state. So remember, for this, we're looking for what is most likely occurring, most likely happening. And with our given information, I think what's most likely occurring is going to be that preterm labor, right? Because our vital signs are not showing us a PE. The bleeding is a little bit painful. It's not painless to indicate previa. And just because she has some decreased fetal movement does not mean that we have an intrauterine fetal demise. All right, so what's going to be our final decision here? What are we thinking? It's going to be, our preterm labor. Perfect. All right, so now that we have our preterm labor, we're going to go on to our next step here and figure out what are we going to do about that. All right, so this client's showing signs of preterm labor, and because of that, what are we most likely preterm labor based on all of our findings that are given are known. So now we need to determine what 2 actions that we need to take in order to help this client in preterm labor, okay? So generating solutions. This is where we decide what we need to perform or prepare to perform. So our nursing process comes into play here, right? Our ADPI, we're going to assess, diagnose. Now we're going to do this planning and implementation. You guys are already jumping ahead. I see cervical dilation. Y'all are on it. Okay. So remember that the NCLEX is a safety exam. So we need to find actions that we're going to take to keep the client safe in this situation, right? And this is a select end. So again, we're selecting 2 options. So we want interventions that are going to slow or stop the preterm labor, and things that will assess for labor, right? So that helps if you can determine ahead of time, what's my overall goal? And then you can look at each one separately. Okay, so QBL, quantify blood loss. What do we think about this? When would we quantify blood loss? Yep, perfect. So yeah, when the placenta detaches, we would, anytime there's a lot of bleeding, anytime there's bleeding, we're watching how much is happening. So this would happen in an abruption. It would happen in a hemorrhage. We'd be watching that, right? But is getting the quantified blood loss, she's only had a little bit of spotting, right? So it's not super concerning. And if we quantify the blood loss, that's not going to help us with these goals of slowing or stopping labor. It's not going to assess for labor, right? So while we might do all of these things, we want to pick the best 2, right? Which always makes it tricky, because if yes, all of these could be possible options that we would do. All right, so let's look at our next one, assess for uterine contractions. Do we want to do that? I've seen lots of people say this. Yep, Ashley's on it, assess for uterine contractions. Okay, so assessing for uterine contractions, we can put that client on an external monitor, those TOCO it's called, to assess the contraction pattern and frequency, right? Because we want to know, is she contracting? Are these cramping feelings that she's having, are they uterine contractions? So I definitely think this would be a helpful intervention for us to do. Okay, our next one is prepare to administer nifedipine. What do y'all know about nifedipine? What is nifedipine? More importantly, what is nifedipine in the OB world when you're in preterm labor? So nifedipine is a blood pressure med, right? We give it as an antihypertensive. But if you are in labor, it's what's called a tocolytic. So a tocolytic. And tocolytics are going to slow or stop uterine contractions, right? So that is going to help us stop or delay this preterm labor. Awesome. Yep. Tocolytic. You all got it. Okay. So I have 2 options here, but of course we need to always look at our other ones just to make sure. Prepare the client for an abdominal ultrasound. All right, so I saw some people were thinking that. Now, again, not that it's wrong to do, right? It can tell us how the baby's doing, especially if we were worried about an intrauterine fetal demise. It can assess where the placenta is, but that's not going to help us slow or stop this labor or assess for labor, right? So although it won't hurt anything, it's not going to be what we complete here. All right, our last option, prepare the client for a ventilation perfusion scan. Okay, when do we do this? What does this assess for? Obviously, it says, right, we're assessing for ventilation and perfusion in the lungs, those two parts of oxygenation, where air has to get in, that's ventilation, and then oxygen has to get to those red blood cells, and that's perfusion. But, and there's different diseases that we do this for. So let's look at this image here just to help explain this VQ, or this ventilation perfusion matching. So the first image on the left shows that we have a problem with ventilation. So anything that prevents the air from filling those alveoli, reaching the capillaries, such as fluid. So that could be like pneumonia. And then the image on the right is going to be, this is where we have a perfusion issue. So like a PE, it's going to block blood flow from reaching those capillaries. And what happens is then the lungs won't get oxygenated, right? So the client has no breathing and ventilation issues, but the blood flow is stopped, and that's preventing oxygenation to the blood. So a ventilation perfusion scan would help diagnose different things like the pneumonia. It'll look at that, and it'll look for a PE. But remember, we were not concerned that it was a PE. And again, this isn't going to slow or stop labor, right? And it's not going to assess for labor. Okay, so take action. What did we decide? What are we doing here? We're going to do prepare to administer an ephedipine, our tocolytic, and we're going to assess for uterine contractions, right? All right. So next we have to evaluate our outcomes. So we need to reassess and see if our interventions helped. So this is going to be a direct measurement of what we did for this client, or for the condition. So again, this is another select N. We're going to pick two options here. So two parameters that we monitor. We might do all of these for a client, right? They might not be wrong, but we want to know what two actions are going to help us know if our interventions and our actions worked. So we need to know, did we slow or stop the labor, right? Did it get slowed or stopped? And we need to know if the fetus and mom are tolerating labor, right? So those are things that we want to look at. So let's go one by one down here. I see some of y'all already put in some great options, great answer choices. Hemoglobin. What's this going to tell us? Our hemoglobin is going to tell us our blood volume, right? Going to see if we've lost too much blood. It's going to let us know if we're low on those red blood cells. Great for clients with heavy bleeding, like postpartum hemorrhage. We would definitely want to monitor this if it was previa, right? Yeah, if we were quantifying blood loss. Good job, Jennifer. But right now, the hemoglobin is not going to tell us if we've been effective in slowing or stopping labor, or tell us how the fetus and mom are tolerating labor. So I don't think that's going to be in our option. How about respirations? So same thing here, right? Our respirations are not going to tell us if we've slowed or stopped labor. Definitely something we monitor on everyone. It's not going to tell us if they're tolerating the labor well. Looking at cervical dilation. So I already see some people have put that in as an option. And here in this image, if you see, so you understand the cervical dilation and effacement, I want you guys to think of the cervix like a donut. So the hole in the center of the donut, your little hole, donut hole, as that gets bigger and wider, that's your dilation. And then if you squish the donut down as it gets flatter, that's effacement. So we definitely want to monitor this, right? Because we need to see if this client is progressing in labor or if we've slowed or stopped it. So as she's progressing in labor, she's going to get further dilated to that 10 centimeters. So I definitely think that we will be monitoring our cervical dilation here, right? We want to see, is she progressing in labor or did we stop it? Okay, fetal heart tones. So getting that fetal heart rate, what do we think about that? We can place this on the mom. We put this little monitor on the fetal back, an ultrasound monitor, and that's going to detect the fetal heart rate. And it's going to tell us, the toco up here is going to tell us the contraction pattern, and then we'll have our fetal heart rate to compare. And what is that going to tell us? It's going to assess how the fetus is doing, how it's tolerating the labor, right? Yeah, I see everyone agreeing that yes, we want to do this. So we want to get our cervical dilation and check our fetal heart tones. But let's check our last one just to be sure here. It's going to be our oxygen saturation. So oxygen saturation, we're going to monitor on everybody, right? Definitely important to know, but it's not going to tell us if we've stopped this preterm labor, if she's progressing, and it's not going to tell us how she's tolerating that labor, how the baby's tolerating labor, right? All right, so let's check now all of our answers. We see that we're correct here. So we have a client in preterm labor. We'll give her nifedipine, a tocolytic. We're going to assess those uterine contractions. We'll check fetal heart tones and cervical dilation to see if our interventions have worked. So now you all are ready for these bow tie questions. I hope you all picked up some new strategies here to help you when you approach these questions, and you're going to do great. So remember just to take each part as a single question and answer it from there. And you all can find us. Krista will be putting these links in if she hasn't already. A course at bootcamp.com/NCLEX to get more questions, more bow tie questions, our cheat sheets, and some video walkthroughs of our case studies. And then you can also follow us on Instagram, TikTok, YouTube, of course, and our Facebook group. I hope that was helpful. Please let me know if you all have any questions. Chris is dropping all the links for you. You're welcome. All right. Well, if there's no other questions, I look forward to seeing you guys the next time, and keep a lookout. We'll be having a webinar coming up next week, so you can join in for that as well.
Very cool. All right. Well, for those of you who are new here and don't know me, my name is Courtney. I'm one of the content creators here at NCLEX Bootcamp. And today is going to be kind of a fun live demo. So if you're thinking about using Bootcamp to study for your NCLEX, you're in the right spot, because today I'm going to take you over onto our live site and show you all of the great resources that NCLEX Bootcamp has to get you feeling really comfortable and confident and ready to be successful on your NCLEX. So it is 1 o'clock, so we will get started. I want to first introduce you to Dr. Emily. She is moderating in the chat, so you'll see her messages popping up. She is there to answer any questions you might have. So if you have questions throughout the webinar, or if you just want to pop in and say hi, make sure that you leave her a note. She's going to be dropping some links throughout the presentation as well. That are going to be really helpful for you. So be sure to pop in there and say hi to her. So like I said, my name is Courtney. I'm one of the content creators here at NCLEX Bootcamp. I have been a nurse for 15 years and a nurse practitioner for 7. So I definitely know how stressful it can be getting ready to take your boards. So without further delay, let's hop in, and I'm going to show you all of the great resources that NCLEX Bootcamp has to offer. So before we get over to the live site, I want to tell you a little bit about who Bootcamp is. So we have here a group of nurse educators that come from every nursing specialty you can think of. We have maternal, OB, we have nurses from the ER, nurses from critical care, mental health, pediatrics, and so we've combined all of our expertise together to bring you a study resource that really looks and feels like the NCLEX, and a study resource that will really help you prepare and be successful when you sit to take this exam. So the biggest question I get from nursing students, so you just graduated nursing school and you're like, whew, that's all done with, and you're very relieved, but then you start thinking like, oh my gosh, now I have to take the NCLEX, and where do I even start? Because trying to compile all those years of nursing education and kind of restudy for all that seems like a really daunting task, right? we have come up with some study schedules for you to help you figure out where you should start, what you should do, how you should pace yourself, because we know that can feel really, really overwhelming, especially when you're feeling stressed out and studying for the NCLEX. So the first thing I want to show you is I'm going to take you over to our live site. And so this is what NCLEX Bootcamp looks like. And so you will see in the left side panel here, you will have everything that you need. So if you scroll down, you are going to see our study schedules right here. So if we click on that, you will see that we have 1 month, 2 month, and 3 month study schedules. So depending on when you're taking the NCLEX, you can pick whichever one is going to work best for you. So say you're going to take your NCLEX in the new year, maybe sometime in January. So you will find a really great fit with our 1 month study schedule. And so if you click on that, all right, you can see what this looks like. So it gives you a week by week breakdown, day by day, and you can see that it's going to tell you when to do what. So you're going to start off by taking a readiness exam. Oops, I'm sorry. You're going to start off by with our first Next Generation approach course, and then you're going to start with a readiness exam. You're going to review some cheat sheets and start right off with our case studies. So I'm going to walk you through each one of these components so that you can see what they look like. But this is a really, really great resource because it breaks it down into really manageable chunks. And by the time you get to the end of it, you can walk into the NCLEX feeling very confident that you have covered everything that you need to know, that you didn't miss anything, and it's not going to feel completely overwhelming when you're trying to study, because you'll go in, say, on Wednesday, and you're going to do, I'm going to do case studies 3 through 6, 60 adult questions, 20 farm questions, and you're done for the day, right? That seems pretty manageable. So students really enjoy that. All right. And then, of course, you're going to see it says to take our Next Generation course, which is, if I go back here, you'll see right here above our study guides is our Next Generation course. So this was made by Dr. Emily, who I said is in our chat today moderating. And she has done a really fantastic job covering everything you need to know about the Next Generation NCLEX, because I think some students still feel a little anxious about the Next Generation NCLEX because it is still somewhat new. So she covers the basics and all about case studies, because we know the Next Generation NCLEX has case studies, right? So she's going to walk you through how to approach the case study, and then take you through a full-length case study and talk about how to approach that in a way that feels manageable and in a way that is going to allow you to be successful. All right, so if we're following our study schedule, the first thing you'll notice is that it tells you when to take certain questions. And these are going to be our standalone questions that come from our comprehensive test bank. So if we click on this, okay, you can get to our standalone questions from a couple different places. So you can come to here on the left side panel where it says standalone questions, and you can click on those. And say on your study guide, it says that you're supposed to do 20 adult health questions today. So you would just go to adult health, click on create a test, and select that you want to do 20 questions. And that will take you right to where you need to be. Same goes for child health, critical care, fundamentals, all of that. The other place you can go is right over here where it says create a test. And I like this tab personally because you can really customize. So there's a lot of different things you can toggle on and off. And you can pick from the subjects that you want to do or want to pull from in our question banks. And you can either use unused questions, or you can use all the questions, which might be questions you've seen before, or you can pull from your tagged questions. And I'll show you what that means in just a bit. So let's look at a couple questions, and I've bookmarked some for you today so we can answer at least one of them together. So I'm going to hit Start Test. And I want to show you a couple things. Let's do this one. So let's answer this one together. So I'm going to ask you to help me out here in the chat. So in this question, we have a nurse who's assessing a client diagnosed with major depressive disorder, and their dose of fluoxetine was increased yesterday. And now we're being asked which assessment finding is most concerning. So this is kind of a prioritization question, right? We could say that all of these are concerning, but we're looking for one that is most concerning. And let me just get the chat over here so I can see you all. There we go. So We're being asked which one is most concerning, which in my mind, I typically think which one is most likely to be life-threatening, right? So I'm going to have you help me out. So first of all, I think we need to ask ourselves, what do we know about fluoxetine? Does anybody know what kind of medication this is? I see a couple of you guessing answers. So this is a selective serotonin reuptake inhibitor, right? An SSRI. And we use these to treat depression and anxiety disorders. So what do we know about SSRIs? What do we know about common side effects of SSRIs? Let's start there. Yep. So SSRIs, we know that GI upset is really common, like nausea, diarrhea. We know that headaches could be common. We know sexual side effects are common with this class. And how long do SSRIs take to start working? Do you know? They take a couple weeks, right? So they're not just an overnight fix. They take a couple weeks to start working. And then what's the big thing we worry about? I see a couple of you are mentioning it already. The big thing we worry about with antidepressant medications like SSRIs. We worry about serotonin syndrome. Yep, you got it. Okay, so when I think of serotonin syndrome, I think of sweating, shaking, and strange behavior, right? My 3 S's. So I think with all of that we've kind of know about this class of medications, I think we can answer this question. So we talked about nausea is a common side effect, headache's a common side effect. We said that they can take several weeks to start working. So if this dose was just increased yesterday, reports of low mood wouldn't be unexpected, right? Because it hasn't had time to kick in. What do we worry about with beads of sweat on the forehead? We're worried about serotonin syndrome, right? Sweating, shaking, and strange behavior. So I would say this is most concerning, right? Because serotonin syndrome can potentially be fatal. And I see a lot of you are getting it right. Now, I see a couple of you selected number 3. Now, I would be more concerned about this if the client was saying they were suicidal, and then that would be a safety concern, and then I would be most concerned about that, right? But because they're just saying that they have a low mood, that's not unexpected, right? Because fluoxetine can take a couple weeks to start working. All right, so good job. So, okay, so when you select the answer that you want, you're going to go ahead and hit submit, and you're going to get some information that pops up. So I'm going to walk you through what all of this means because it can look like a lot in the beginning. So the first thing is this panel right here at the bottom of our question. And so it's going to tell us if we got the question right or wrong. So in this case, we got full credit. And then we're going to see this percent right here, which is going to tell us how many of the people who have taken this question in our bank have got it correct. And so in this case, 52.5% of our users got this question correct. So that's going to give you kind of an idea of how difficult this question is. We're going to see the scoring rule. So this is a 0-1 scoring rule because this is a multiple choice select one option or question. And then we're going to see our time spent. So this is a helpful little tracker for when we're taking practice questions, because we know that we have about 5 hours to take the NCLEX, and we can get a possibility of 150 questions. So if we do the math, that's about 2 minutes per question, right? So as we're going through our questions, we want to make sure that we're hitting at or below that 2-minute mark, so that if we were to get all of the questions on the NCLEX, we could finish that exam in time. Okay, so if we go over now to the right side of our screen, you will see what is our explanation. And so we have a lot of images embedded throughout our explanations for those who are visual learners. So in this case, you can see we're looking at serotonin syndrome and the symptoms that come along with this. So the fever, the sweating, confusion, agitation, muscle rigidity, tremors, increased blood pressure and heart rate. And then if we scroll further down, you can see we have the explanation as to why the correct answer is correct. And so in this case, we're talking about how SSRIs, like fluoxetine, block the reuptake of serotonin, and that could potentially lead to serotonin syndrome. So we need to be on the lookout for that. Okay. And then if we keep scrolling down, you will see that we have rationales for why our incorrect options are incorrect. And these are also really important to read because we have written these questions specifically not only so that you can learn from the correct answer, but also so that you can learn from the incorrect answers. So you will see here we're talking about continued reports of low mood and how SSRIs take several weeks to start working. And then we talk a little bit about the common side effects of SSRIs like headache, nausea, that type of thing. Now, if we keep scrolling, you will get to a section called our key takeaway. And this is also a really helpful section because it talks about what is the key concept you need to know about what you're being asked. And so in this case, we're talking about SSRIs and serotonin syndrome. and all the things you need to understand about serotonin syndrome and what that looks like. Now, why this is really helpful is because ultimately we can't predict what questions you're going to get on the NCLEX specifically, but we can predict themes. And we know that serotonin syndrome is a big safety concern when it comes to SSRIs. So we can say it's likely that you might get a question on serotonin syndrome. So if you understand kind of this key takeaway or these main concepts about serotonin syndrome, you'll be able to answer any question that they throw at you about serotonin syndrome because you kind of understand this big concept. Okay, so make sure that you always read these when you go through the question. And then if we go down even further, we have our Ask Bootcamp AI. So if you have any questions about this, you can put that here and our AI will give you back an answer, which is really helpful. And then if you still have a question, you can come down here and contact our team. And so this will link to the question that you're asking about, and you can send a message to our team and they will get back to you, which is also a really great resource. We love to hear from students, so don't be afraid to use this feature as well. Okay, and then the last thing I want to show you on our questions here is our tagging system. So you remember when I told you about when you go to make a test, you can pull from your tagged questions, and that is these down here. So we have either red means you're still learning it, yellow means you're reviewing it, and green means you've mastered it. So if we answered this question correct, it's going to auto tag it as mastered, as in we know this content, we're good to go, right? Now, say I just guessed on this and I wasn't really sure of my answer, and I still got it right. I could go down here and tag this as reviewing, which means I could come back to this question later. I could make a quiz just out of my questions I'm still reviewing. Now, if I got this question wrong, it's going to auto tag it as red, meaning I'm still learning this information. And so if I wanted to go back later on and make a test out of all the questions I've gotten wrong previously, I could do that as well. So it's just a really helpful way of sorting the questions and like sorting out the content that you know you're really solid on, you're good to go, and then kind of sorting that from the content where you still feel like needs a little bit more attention. All right, so that is our test bank. We have about 1,500 questions in there, so lots of learning to be had. And if we go on, we can see that we have case studies as well. So on your study schedule, you saw that there was case studies that you are assigned to answer day by day. So you can get some practice with those as well, because we know that the Next Generation NCLEX now has case studies. So fortunately, we have a lot of case studies for you to practice from. And I want to show you what these look like. So if we go back, you can get to our case studies again from two places. You can either come here and you can see we have a lot of case studies for you to practice with. These cover all kinds of topics like adult health, mental health, maternal, child, critical care, all kinds of things. So you'll get plenty of practice. So if we take a look at what those look like, you will see these look very similar to what you're going to see on the actual NCLEX. So we have our client data tabs and the questions here on the right-hand side. So all of our case studies have 6 items associated with them, which is what you'll see on the actual NCLEX. So in this case, this is a highlight type question. And so we would just go through here and after we read our data tab, here we're being asked to select the 3 findings that are most concerning. So I'm just going to select, let's see, we'll select 3 of them. And then we're going to submit that. Okay. And so in this case, look at that, I got all 3 right. Okay, so it's going to give us the same dashboard we saw on our standalone questions. So I got 3 out of 3 credit, and I'm gonna see that I spent about 1 minute on that question. So again, we're still aiming for about that 2 minutes or less. Now, the thing I really wanna show you is that if we scroll down, we have case study walkthrough videos that go with every question of every case study. So for 50 case studies, 6 questions apiece, if we multiply that out, that's how many videos we have walking you through why the correct answer is correct and why the incorrect options are incorrect. And students really, really like these. They find them very helpful. So this is kind of like having like your favorite preceptor, your favorite instructor standing there with you, looking at this patient saying, this is why I'm concerned, and this is what I'm seeing, this is why I'm concerned, and this is how I got to this answer. And so students find this is really, really helpful in helping them learn to think like a nurse and helping them think in a way that will really help them be successful with these case studies. So here we have Dr. Emily talking about this question, and you can see all of these videos, they're going to be short. They're less than 5 minutes. So they're short, they're concise, they're to the point, they tell you what you need to know. So in 3 minutes, she walks you through this whole question. She's going to tell you what she's seen, why she found the concerning options concerning, and why the other ones she found as distractors. And then again, we have our written rationale for those who like to learn by reading. So it's going to tell you why the correct options were correct, why the incorrect options were incorrect. We're going to again have that key takeaway and the same Bootcamp AI. You can ask us questions. And so this is going to be the same thing for all 6 items of every case study. So students really have been enjoying that. We've got really positive feedback on those. Okay. And then the last thing I want to show you is our readiness exam. So you probably noticed in our study schedule, it was telling you when you should take your readiness exams. And usually you'll take 1 in the very beginning, 2 readiness exams, 2 and 3 in the middle, and then the last one before you take your NCLEX. And so these readiness exams, they're not just kind of a random compiling of a bunch of our questions. They're actually specifically written to match the NCSBN test plan. And so what I mean by that is that when you look at our readiness exams, they're going to simulate the types of questions you will see on the NCLEX. And by that, I mean 18% will be management of care, 14% will be physiological adaptation, 12% will be reduction of risk potential, and so on. So it's going to kind of match this pie graph. So let's take a look at what those look like. And again, you can get to those. They're right here under our standalone questions here on our left-hand panel. And you can see we have 4 readiness exams. So if we want to see what these look like, we can go over here and start the exam. All right, and so we have a couple things we can select before we get into our exam. So it's going to tell us how long we have. It's going to tell us if we want to add the NCLEX restrictions. So that's going to disable that kind of cross out and highlight feature to simulate the real Pearson testing experience. And then if you have any time accommodations, you can go ahead and select that here to get extra time. Okay, so then we're going to start our exam. And this is going to look really similar to our practice questions, right? Because our practice questions look very similar to the NCLEX. So from here, we would just start reading through, selecting our answers, and going through. And you'll see when I'm clicking next, though, we're not getting that rationale pop-up because, of course, you wouldn't get that in the actual NCLEX. So we would go through here and answer all of our questions. I'm just going to answer a few so we can kind of get a sense of what this looks like. And I'm just kind of randomly picking, so I'm thinking I might not do very well. Okay, but we would go through to 100, but since you don't want to sit around and watch me click through 100 questions, I'm going to end our exam. And this is just telling me that I have some questions that are unanswered and if I'm sure I want to submit. I want to say yes because I want to show you what you're going to get at the end of this. Okay, so say I went through all 100 questions and then I would get this kind of report card, if you will, at the end. And this is going to tell me, it's going to give me a lot of information actually. And it's going to tell me, first off, what my chances are of passing the NCLEX. So I'm going to get low, borderline, high, or very high. And in this case, I didn't do so well with my random clicking, and so I have a low chance of passing the NCLEX. But if I had gone through all 100 questions, of course, we would get a little bit more accurate of a prediction. So it's going to give us that, and then on the right side over here, it's going to give us our score. It's going to give us the average score of everybody who's taken this test. It's going to break down by points. It's going to tell us how much time we spent per question and a total time. And then under that, we're going to get a nice note from Dr. Emily telling us how we did and what we can do to improve our score. And then if we go down even further, it's going to break down this exam by subject. So pharmacology, management of care, fundamentals. And this is really helpful because it's going to show us what areas we did really, really well in and what areas might need a little bit more attention. So it will really help you focus your studying as you're moving through your NCLEX preparation journey. And then further down, it's going to give us a more detailed breakdown of the time we spent. So maybe adult health questions were more challenging for us, and we're going to see we spent a little bit more time on those questions. So again, just helping us focus our studying. And then it's going to give us a full breakdown of each question and which ones we got right and wrong. All right. So the last thing then that I want to show you is also our performance dashboard. So as you're working your way through the standalone questions, the case studies, the readiness exams, this performance dashboard is going to become more and more populated for you. And the purpose of this is it tells us, it's another indicator of how ready you are to take the NCLEX and be successful on it. So we say that we want you to meet 2 targets, and if you do, 99% of the students who have met these targets will pass their NCLEX. And so those seem like pretty good odds, right? So what these are is our overall score of our questions. So this is how well I'm doing on all the questions that I've answered. So here you can see, as I've gone through some of our bank, it's at 51%. So we want to see you above 61%. But also we want to see that you've answered a little less than 1,800 questions out of our test bank. The reason we do that is say I come in here and I'm a mental health nurse, right? So if I came in here and I answered all the mental health questions and I did really good on them, say I was scoring at like 90% and I was like, yes, I'm doing great. Okay, but we know that I am probably going to see questions other than mental health on the NCLEX, right? So we want to be able to say that you've seen a broad enough variety of questions and you're still scoring over 61%. And then we can say that you're very likely to pass the NCLEX. And then again, if we scroll down, we're going to see that broken down by topic. So again, say I was doing great in mental health. I was scoring really, really high, but maybe maternal newborn, I wasn't scoring so well. And we're going to be able to see that here, and that's going to better help me focus my studying in which areas are going to need more attention. All right. And then I know I said the last thing already, but the last thing I want to show you, of course, is our cheat sheets. So these are a somewhat newish addition over the past couple months, and these, I must say, we are all very, very proud of because our cheat sheets are going to be a great resource for your studying, especially in areas where maybe you feel like you're struggling a little bit more because they give you all the information you need to know for the NCLEX and nothing you don't. So it's really synthesized down complex topics into really digestible, easy to understand information that are very applicable to the NCLEX. So let's take a look at what some of these look like. So you can separate these out. We have adult, child health fundamentals, management of care, mental health, pharmacology. So you can divide them out by topic. So let's take a look at, let's do COPD, right? That's a common condition we see on the NCLEX. So you can see that these are synthesized out into a really easy, a very readable way of studying for the NCLEX. So if we keep scrolling down, you can see it's going to cover all the high yield topics of the things we need to know. And then you'll see that they have these little star points. And these are call outs. So things that are really important to know for the NCLEX that you're likely to see come up. And then if you look at the bottom of each page, you're going to see what's called our NCLEX star points. And so these are kind of similar to our key takeaways from our practice questions. And so these are going to tell you these really high yield points that are really likely to come up on the NCLEX. And then at the very end of our cheat sheets, you can see that you're going to get the chance to test your knowledge. So you can go ahead and answer these questions just to help this information sink in, make sure you remember it, and make sure that you're understanding the content. So again, these cheat sheets, you can find them here, right underneath our readiness exams, and new ones are being uploaded every week. So this list is only getting longer with the amount of topics that you have to choose from. So again, a really, really helpful study resource as you're preparing for the NCLEX. All right, so additional resources. So today we are live here on YouTube, but if you are also a Facebook user, you can go over to our Facebook study group. If you're already a member, you can hit that invite button and invite any cohort members or friends that you have who are also studying for the NCLEX, so they can utilize our resources as well. We do live weekly webinars. So last week, I believe it was Dr. Amber Adams who gave a lovely presentation that is archived on our YouTube page. And then next week, I believe we have Dr. Emily coming up with her Ask Me Anything webinar, so you can get all of your burning NCLEX questions answered. And she The date and time for that will be posted in our Facebook page and on our Instagram as well, which you can find here. So you can follow us on bootcamp.com, or you can find us, on bootcamp.com/NCLEX. We're on Instagram, TikTok, YouTube, Facebook, all of those. And we love to hear from students. So make sure that you pop in and tell us hi and follow us. Of course, you can start studying on NCLEX Bootcamp for free. If you decide that you do want to upgrade to an all-access pass, you can find that here. And Emily's going to be dropping those links for you in the chat. And you can pick from a 1 month, 3 month, or 6 month access depending on when you're taking your NCLEX. Okay, so that I think wraps us up, and there we go. I will hang out for a few minutes if any of you have any questions, and Emily is going to be in the chat answering any questions that you might have as well. And thank you so much for joining us today. I hope that you found this helpful, and I want to wish all the best of luck to those of you who are taking your NCLEX soon. I'm sure that you will do great. And if you have any questions, make sure that you post them in the chat for us. All right. Well, thank you so much, everybody. It was great to hear from you, and I will see you in the next webinar. All right, take care.
Hello, everyone. Just going to give a chance for everyone to kind of show up. Hello. Hi, Greg, RG. Yes. Hey, everybody. Good. Okay. So we're going to take just a couple minutes to let people kind of filter in. I see some of you have already started leaving some questions, and that's excellent. We are going to ask you just kind of as you file in, if you have any burning questions about the NCLEX, about NCLEX Bootcamp, or anything else like nursing school, NCLEX related, we are going to try to help you out as best we can. I've been in test prep for 10 years, in NCLEX prep specifically, and so I feel like I can try and answer any questions that come to you guys. So just kind of start leaving those in the comments. I see several of you have asked questions about what do I do when reviewing rationales, prioritizing, figuring out best action versus initial action. Very good. A couple repeat attempts. So we're just going to take a couple minutes, but want you guys, if there's something specifically that you are really hoping to have answered today, like what do you want to learn after you come away from today's YouTube Live? If you just want to leave that comment, and yeah, we'll go ahead and take just a second, collect some of your burning questions, and then we'll get started. Hi to you, Cheryl. Hello, Saba Abid. Dawn, Krubo, Miriam, hi everybody. Where are you guys joining us from? Cheryl, you're a repeat test taker. I would not worry too much about being a repeat test taker. Bootcamp has helped lots of repeat test takers pass, even if it's their third, fourth. I think somebody said here they're on their fourth attempt, and it is not unheard of. In fact, we hear all the time from our students that they pass after unsuccessfully tackling the NCLEX with other products. So we try to really be that game changer for you. So, all right, we got people from Dubai, Kenya, Maryland, Portland, Oregon. I want to visit there this summer, Krugo, before the summer's over. So, all right. Okay. I think we've got a good number of people here, so we'll go ahead and get started. So again, my name is Emily. I'm one of the co-creators here at NCLEX Bootcamp, and we have another of our creators moderating in the chat. So she's just going to kind of collect several of your comments to give us some things to talk about. So leave those there. And again, I've worked in NCLEX prep for about 10 years now. So I've been asked to answer every manner of question about the NCLEX. And yeah, we'll try and get to as many questions of yours that we can by the end of this today, and just kind of leave those questions in the chat as they pop up, and our moderator is going to pick a couple to highlight and bring out for my attention. So okay, first to get started. So this is a big burning question that we hear a lot from students is, how do I prepare for the NCLEX? Or more specifically, how do I get started? Because you guys have probably heard from your peers like, well, you need a content review and you need a question bank and you should write down all the rationales and you should do do this and that. And so you guys have probably heard a lot of conflicting information about how to prepare for the NCLEX. And so we want to kind of help demystify some of that for you, with the biggest emphasis being on this point number 1, that practice makes perfect. So this is kind of exemplified sometimes, like if you want to perfect your free throw in basketball, you don't go practice like dribbling the ball, or you don't practice running up and down the court. You need to practice doing the free throw. And so you want to make sure that your practice, when you're practicing to pass the NCLEX, what you need to do to pass the NCLEX is to know how to answer these critical thinking and clinical judgment questions really, really well. And you need to be really comfortable in your ability doing that, or at least have enough practice that you're comfortable being uncomfortable. And so that means you need to practice with questions that look as similar to the NCLEX as possible. And you guys have probably heard, if you heard about bootcamp from your peers or anybody else, that our questions, we try to make sure that they look more like the real test than any other question bank out there. And that's what we hear from students. And so that's what you want to do, is you want to get in that same mindset that you're going to be in the test, of knowing how to practice these complex questions that are at or above the passing level, or that difficulty level of passing or above on the NCLEX. And so we've got lots of questions for you to do that, but it's not that simple, right? Many of these question banks have 1,000, 1,500 plus items, and it's not as simple as just jumping in and start to generate random tests. Although if you have a good base of content, that might not also be a bad idea. But in order to help you get started, because just telling you to go practice items is not really going to help you know your first step to takes, we have the NCLEX Bootcamp study guide and a study schedule available on our website. So let me show you what we've got here for that. This is our homepage, where you can kind of access all of the resources that NCLEX Bootcamp has for you, including our case studies, standalone questions, readiness exams, cheat sheets, and a strategy course. Either from our homepage in our resources tab, or here within the product under resources, we've got this study guide and study schedule available to you. And so this study guide is going to offer really kind of answering all of these questions about the NCLEX. What is it? When should I take it? Details on registration, if you should self-study or use a course. And so you're going to find that this answers a lot of your questions about your content review and your NCLEX prep in general. So that's a good place to get started. Also, within our resources page, we've got a study schedule. So this is literally, depending on whether you have 1, 2 months, 3 months to study, you can download these study schedules here. And this is going to walk you day by day through your study schedule, and has built-in days for review time and for taking your readiness assessments. So, of course, you would start by reading the study guide, and then we have some videos from our strategy course that talk about testing basics. This is going to answer some of the questions you guys had about what do I do with the rationales, what do I focus on, etc., how to approach cases. And then the first thing that we suggest that you guys do is take our readiness assessment. So in the NCLEX Bootcamp homepage, whenever you've taken one of our readiness exams, you can see here I have a low chance of passing. No, I'm just kidding. I just kind of clicked through these. But once you complete a readiness exam, you can actually go in here and review. You're told whether you have a low, borderline, high, or very high chance of passing. But when you're just getting started and you're taking your first readiness exam, the important thing is that you want to make sure you are focusing on your weak areas. And for me, that's maternal newborn health. No surprise there. I've worked with adults my whole life, so that's absolutely my weakest area. And so that will kind of let you see, oh, well, within these areas, that's my area that I really need to focus on the most. And then that will let you kind of create tests from just those specific subject areas. So that's my second tip for you, is in addition to just practicing, you've heard that practice makes perfect. Well, it's really true that perfect practice makes perfect. And so that means focusing your practice on the areas that you need the most help in. And that's going to be different for everybody. So, yep, you're going to focus your practice areas on those subject areas that you have the most room for improvement. So, okay, as far as how to prepare, questions about how to prepare, I'm going to look for what questions that you guys have asked for us. And I saw someone said, what do I focus on when I'm reading the rationales? And that's a really good question. And I'm actually going to pull up a question here for you to kind of talk about that. Because yeah, you don't just want to answer questions mindlessly, right? Each question is made for you to learn something from not just the correct answer. So whether you get it right or wrong, you want to be able to let me make this a little bit bigger for you guys. So yeah, whether you get it right or wrong, there's a teaching point built into each one of these options. So let's say if I am, here we go. So I'm gonna pick a question that I think you guys might be able to answer no matter what point. Okay, prioritization question. We know we love prioritization questions. Okay. So we've got telephone messages from clients. It would be a priority for the nurse to follow up with a client who either has this new single irregularly shaped mole, painful blisters on the trunk after starting phenytoin. We've got questions about a Mohs surgery procedure, or we've got an itchy rash after contacting poison ivy. And so this is kind of the practice. This is what you're practicing when you're engaging with our question bank is you are trying to practice being uncomfortable with the answer, thinking through what you already know, and trying to generate a solution and pick the best action. And so here, if I'm going to prioritize a client, does anybody want to venture a guess? I don't see anybody wants to guess yet. So what's a priority? So when we're looking for priority, we're looking for life-threatening issues of airway, breathing, circulation, things that pose an imminent risk to the client, things that are unexpected abnormals. All right, I've got some guesses for 1, 2, and 3. All right, nobody wants to guess 4, and I would agree with you. We don't need to select 4, but why? That's because that is an expected abnormal finding, right? And a rash is not a normal finding, but it's an expected abnormal finding after we contact poison ivy, right? So a new single irregularly shaped coin-sized mole. Those of you who guessed 1, that's concerning, right? This is definitely an abnormal finding. We know from your ABCDEs of lesions for what could indicate malignancy that bigger than a pencil head eraser, so coin-shaped is too big, and irregularly shaped. So this could be cancerous, but we don't know if that's the priority. So everybody, it seems, likes 2. So, okay, I am going to agree with you. I'm going to pick 2, and you can see 61% of our users got this correct because, yes, this is our life-threatening issue. But if those of you who didn't know why this might be concerning, maybe it didn't register for you that this was a cancerous lesion, maybe you also had questions about a Mohs surgery. You know, you are looking for what can I learn from this in general. And so in our explanations, we're going to break down for you the correct answer, why it's concerning. So this is an indicator of Stevens-Johnson syndrome, and these are the medications that can cause it. So these are our anticonvulsants, antibiotics, and allopurinol. So our 3 kind of A's of Stevens-Johnson syndrome. So this can be a life-threatening shock problem. So that's going to be a priority. Now, you've been refreshed on what Stevens-Johnson syndrome looks like, what medications it causes. Here are our characteristics of a melanoma skin cancer, that ABCDE mnemonic, if you didn't recall it. So when you're going through your rationales, you're really looking to understand what was the big priority issue here and what can I learn from each of these options. So whether you got it right or wrong, you want to spend really the same amount of time kind of digging into this. And if you are pressed for time, really just making sure that you understand what's in the key takeaway is the big thing. So we have distilled here for you, what is the big thing? If I remember nothing else from this question, what should I remember? And in this case, it's a new rash after starting phenytoin or any of the other anticonvulsants, allopurinol, or antibiotics. That should be a priority issue for you. So as you're reviewing the rationales, make sure you understand why you answered it correctly or incorrectly, what you were supposed to learn from each individual option, because there's something there for you to learn in every single option. And if nothing else, at least know you understand the key takeaway solid. So great question. Very good. All right. So we've got a question. How do I know who is the priority when we get a question for which patient to see first if there's no option for ABCs? So that is a really good question. And management of care, you guys know, is the big section on the NCLEX. That's where the bulk of your questions are that you're going to find most challenging. And so prioritization is a very tough topic, and it's a very important one to get right. So we have actually got several resources for you. So in addition to practicing prioritization questions in the bank, we've got our prioritization cheat sheet that you guys can now access. And for focused remediation, when we're talking about remediating your weak areas, reviewing your weak areas, our cheat sheets are an excellent way to do a topical review. And so if you guys hang out until the end of today's presentation, we're actually going to send a link so that you can download all of our cheat sheets for free. But just to give you a little sneak preview, let's take a look here at what they look like. So here are cheat sheets. You can open them up for a focused topical review. And because you've asked specifically about prioritization, let's take a look at that, because this is a very good question. Who asked this? KP Nahal. Very good question. So you're right. It's not always going to be as obvious as, they're not going to say which patient do you prioritize, somebody with an airway issue, somebody with a circulation issue, right? You have to be able to kind of read between the lines and know what each of these things look like. And so based on our extensive research, we've assembled this NCLEX Bootcamp prioritization pyramid where your first priorities are always going to be airway or safety. And the good news is the NCLEX is never going to ask you to choose between somebody with a safety issue and an airway issue. So if you see one of those, that's going to be the correct answer. And then if you don't have anybody with an airway or safety issue, really, then that's when you break down into breathing, circulation, and we go beyond the ABCs. Disability, so anything neurological, low blood sugar, stroke symptoms, pupil changes, confusion. And then, of course, our lowest priority are going to be stable chronic issues, things that are routine, expected, or psychosocial needs, like the teaching and the Mohs surgery in the previous question, right? So the key then is being able to recognize when an issue is an airway issue, a breathing issue, and so on. And so we've also compiled some of these common warning signs on the NCLEX. Because when you are getting passing level questions, when you are doing really well on your NCLEX, as we know you will, and you're answering these really challenging questions, it's going to be less and less obvious when something looks like a breathing issue or a circulation issue. And so the NCLEX likes to give you these very subtle warning signs. So for example, drooling. Like drooling doesn't sound like an airway issue, but it is, right? Because this could indicate epiglottitis. Or in the case of an inhalation injury, if the NCLEX gives you an option and says the patient's they cough up some soot-tinged sputum, that should be something that you recognize as an airway issue if you know your content. Things like restlessness. They love to give you restlessness as a finding of a breathing issue. So unless it's somebody who would who that would be an expected finding, like maybe a client who is in the manic phase of bipolar and they're agitated and restless, that would be expected. But if somebody has heart failure and they're coughing and restless, that should make you think this is a breathing issue, right? So there's the two things. It's being trained to recognize what problems are problems of safety, airway, breathing, and so on, and being able to decide, is this an airway and safety issue, or go down from there. So it doesn't just stop at the ABCs, you're right. And NCLEX or nursing professors like to kind of try and make it that simple, but I could have a expected abnormal. Like I could have a 90% pulse oximetry with COPD, and that's not really a breathing problem because it's a stable chronic issue. So it's not as simple as the ABCs, and we try and break this down for you here. So again, really, really good question, you guys. All right. Yes, good, Sen. Very good. All right. Epiglottitis. Good. Okay. Does that make sense to everybody? Anybody have any more questions before we move on? Swollen, yep, very good. Swollen throat will cause drooling, which is ABC. Awesome. All right, Cheryl wants some EKG questions. All right, next question from Vicky Smiles. I like your name, Vicky. So she says, please help us with tips on identifying the right answers on NCLEX questions. For example, when you see a certain phrase, how will it help you know if it's the right or wrong answer? Okay, so I think you're asking about test taking strategies. And this is kind of the difference between the old NCLEX and the new Next Gen NCLEX, is a lot of these tricks, like phrases that should give something away as being right or wrong, they aren't as useful anymore because the exam is really asking you to call on your knowledge of the content and your ability to critically think. So I'm going to give you a couple answers to your question, but I would first say that rather than focus on trying to memorize phrases that give away the right or wrong answer, I would spend more time kind of focusing on making sure that you understand the content. And I would say if you're answering questions in the bank and you're reviewing your performance and you're realizing that you keep missing questions, let's say in the example of a prioritization question, maybe you keep choosing distractors that say somebody has dyspnea on exertion. You missed kind of the qualifier there. It's not dyspnea at rest, which would be concerning, but dyspnea on exertion. And actually, this next page of this prioritization cheat sheet will give you some examples of that. So here you can kind of see, same idea, pink frothy sputum. We've got a client with CHF, a client with CHF. CHF on its own, in isolation, is just a circulation issue. But if we've got pink frothy sputum, that's an unexpected finding, versus peripheral edema, which is an expected finding. So just making sure, I would say, that you're not looking for one word or one phrase, but instead considering the whole answer, the whole patient, the entire patient situation, kind of stepping back instead of focusing on individual phrases or words and just trying to think, what do they look like? And so we've also given you some examples here on the final page to give you some practice with that. So, I've got a full scenario here, sudden anxiety, and I've got a pulse oximetry reading of 80%. So we want to think about these things together, right? So you want to kind of consider the whole patient picture at once instead of just looking for specific phrases. So excellent question. Okay, yes. Somebody says test taking strategies is key. Eliminate the wrong answers first. Definitely. You don't want to focus on trying to prioritize any patient that has stable or chronic issues. If it's a stable breathing issue, you don't need to think about it. If it's a stable circulation issue, you don't need to think about it. So eliminate those stable chronic issues first and focus on the unstable or acute problems that remain. Excellent. Okay, so we've got a question that several students have asked about knowing when to study content versus answer practice questions. What would you recommend? And is answering questions and reading rationales practicing content? So, yes, it's going to depend on your foundation of content, I'll say, and it's going to be a little bit of both. You want to kind of practice going back and forth between the two. And if you look at our study guide, you can see that after you take a readiness test and review which areas are weak, then you're going to do practice questions here, reading rationales as you go. And then this is really where your learning takes place, is when you review those rationales and then take some time to go back and repeat your missed items. Because the important thing is that you know how to answer these questions. You know this content in the context of an NCLEX question, right? So if I just memorize everything about one disease process, that doesn't necessarily help me answer questions. So I would recommend, have kind of a focused content review built in before you go try to apply that knowledge on in a question bank. And then after you've answered the question, so let me give you an example. All right, so nephrolithiasis. So let's say I've just reviewed my renal and urinary section, and at this point I've got a good understanding of the different renal and GU findings. Now I've come to the bank, I'm answering questions on renal and urinary questions, I'm applying my knowledge, and then that is going to help me identify my gaps in my knowledge. If I sit down and I have a good foundation of this and I try and answer these questions, flank pain radiating to the groin, pain in the lower right abdomen, maybe I know a couple of these because I've just studied this and it's fresh, but let's say, I think, I don't know this word, I think it's the term for a UTI, and then I pick this one because I know that's what a UTI looks like, but then I would miss it because this is actually a finding of the UTI. So this is going to help me brush up on not only my findings of nephrolithiasis, but clarify any terms or confusions. So that's what I would recommend. I would recommend kind of building in this alternating content review, reviewing what you'd learned in nursing school, using our cheat sheets for that, and then doing a focused session answering questions on that content area in the bank, because that's going to immediately call out for you what you failed to learn when you tried to refresh your memory with a content review. And then at the end of the week, when we have those built-in days for reviewing your missed items, you can actually create a test here from your learning items, which is ones you answered incorrectly, or reviewing items, which is something you got partial credit on. So I can say I want to go in here and I only want to review the maternal. Let me do maternal since that's my weak area. So if I want to focus my study, let's say I just reviewed something on placenta previa and abruption, because I literally just recently reviewed that content. So when I'm coming in here to answer these questions, it's going to be immediately obvious to me if I missed something from my review. So, all right. Other questions? Okay, I see that it looks like most of our questions here have been answered. So let's move on to the second part of our presentation here, which is how do I know when I'm ready to take the NCLEX? And this is a tough one because I think we all want to feel really, really confident before we go into our test that I've got this, I'm ready for it. But those of you who have taken the NCLEX before, or your classmates have, or the cohort before you has, probably everyone came out saying that they feel like they failed, right? It's really uncommon. If you did go into the test and you know that you just nailed it and answered almost everything correctly, good for you. But the way that the NCLEX works, it's an adaptive test. So the better you're doing, the more questions you're answering correctly, the harder and harder the questions are that you're going to get. So whether you sat down to take the test or whether I sat down to take the test, each question it gives us is going to be one that the CAT algorithm thinks we have a 50% chance of answering correctly. So my questions will be harder than yours most likely, but we're both going to walk out feeling like I didn't know anything on the test. And that's actually a good sign. So just that little note on readiness is you're probably never going to feel fully prepared. And that's why we have in our bank a lot of very challenging passing level and above questions for you, so you can get comfortable answering these complex questions. It's not going to do you any favors if you just practice answering easy softball questions. It'll make you feel good about yourself, but then when you actually sit down to take the test, you aren't prepared to answer those passing level questions. But ultimately, the answer is kind of only you are going to know if you're ready. But to help guide your remediation, we've given you a couple of ways to know that. So first, whether you've met both of the NCLEX Bootcamp targets. And so within the product here, you are going to have your performance page, and you're going to see these little green check marks, and you'll be told if you've met the targets. And so this has been studied. Actually, they've done a lot of studies where they've looked at what correlates with passing standardized tests. And almost every time it's the more questions you complete, the more likely you are to pass. And that's just because we know practice makes perfect, right? So we want to make sure that you have answered this is according to how other users are using the bank, the average number of questions answered, and the average score, because this is how the NCLEX determines passing it's kind of at a cutoff based on how everyone's performing. And so that means if you've answered at least 1,122 questions, and then your average score is 61%. So I've met both of these targets. If you meet both of these targets, 99% of students who meet these targets pass the NCLEX. So you are very likely to pass if you have answered enough questions and scored high enough overall on your average score. And so if you have not met one of these two targets, so for example, if you haven't tagged or answered enough questions, that means you just need to go on answering questions. If your score is low, your percent performance is low, then you want to go remediate some of those items by answering your learning questions or your reviewing questions and mastering that content that you've missed. And then we also recommend that make sure you want to meet those in all of these subjects. So even though I've met both of my targets overall, and I wanted to practice more, I need to go answer some more fundamentals questions in order to make sure I'm ready to answer those safety and infection control, basic care and comfort questions. I need to answer more mental health questions and management of care questions. So that kind of helps you know if you're ready or not, is have I met both of these targets? The other ways that you can know if you're ready is by your results on these readiness exams. And so these are based not only on your performance overall, but your performance in each of the subject areas. And let me see. So that if you look at our study schedule here, we make sure that you take a readiness assessment up front, and then you have a week of practice of reviewing your weak areas and missed items. And then you take another readiness assessment, and then you do the same thing for a week. And so you kind of do this is your practice routine. I take a readiness assessment, I see where I'm at, and I see where my weak areas are. I answer questions and cases, reading the rationales, watching the videos, learning and brushing up mostly in my weak areas in these subjects, and then I take another readiness assessment. And so ideally, you want to see your performance improving from week to week. So when I'm here looking at my readiness scores, let's say the first week I get a low chance of passing. I've been out of school for a while maybe, and I didn't study at all. I just jumped right in. That wouldn't be unexpected. I have a low chance of passing, but then you want to make sure that maybe the next week you have a borderline chance, then a high chance, then a very high chance. You can also reset and repeat these as well to just kind of keep assessing your progress as you go. And that's what makes practice, perfect practice, is that feedback piece, that evaluation piece being built in. So make sure that you keep taking these readiness assessments as you go. So yeah, you'll know you're ready if you've met both targets, and then you have a very high chance of passing on the readiness assessments. If you don't, then I just showed you how to get there, either by answering more questions or repeating your missed areas or focusing your review on your weak areas so that you can have that high or very high chance of passing. All right, so I'm going to take some questions related to readiness. All right, Eki Louise said, what do you recommend to do the final week of preparation? Okay, so that's a really good question. It depends on how long you've been studying, right? Because if you only have 1 month to study, if you're trying to cram all this in, then you probably want to take a little time to rest, do easy review. What I wouldn't try to do is learn the heaviest, most critical information in your final week. Here in our 1 month schedule, really at the point that you're answering management questions, so when you're answering questions on prioritization, you're going to be prioritizing between adult clients where you learned about their diseases already, maternity clients where you learned about their diseases already, and so you're really just applying information you already learned instead of learning something brand new. So I wouldn't wait until the last minute. And I would definitely at least give yourself a day or two of rest before the exam, because at this point, it's like you're ready or you aren't, right? And so give yourself a day or two, and we've built any necessary rest or easy review days into these schedules to help make sure that you aren't overwhelming yourself and stringing yourself out, and that you're really well rested and your mind is sharp and ready to answer questions on test day. So very good. Okay, I'm going to go ahead and go on to our final section here if you guys want to drop some more questions in. So what should I do if I receive a low chance of passing on my readiness assessments or have previously failed the NCLEX? And so I'll say this, a low chance of passing on your readiness assessment does not mean you are going to fail. It just means that you have a little bit more review to do. And like we said, so if I look at my low score here, it tells me that my weakest areas are, again, maternal health and pharmacology. So we tell you here, if you get a low chance, this is what you need to do. You need to go practice questions from these sections, read your explanations carefully, and then repeat those readiness assessments and watch to improve. As far as if you have failed the NCLEX already, well, if you fail the NCLEX, they're going to send you something called a Candidate Performance Report, or a CPR, which is, I think, an unfortunate name. But if you get a CPR, they're actually going to show you whether you were below, near, or above the passing standard in each of these areas. And so each of these areas is going to correspond to a different subject in our test bank. So let's say you took the exam and you got on your candidate performance report that you were near the passing level in everything, but or above the passing level in everything, but way below the passing level in pharm, or near the passing level, but not above the passing level in clinical judgment. So that would mean that when you are remediating yourself before your next NCLEX attempt, you want to focus your questions from our pharmacology section and from the NGN case studies. And this is where clinical judgment is going to be tested on the NCLEX, and that makes up more questions on the NCLEX than anything else. So if you've got 3 full-length case studies on a minimum length exam, that's about 25% of your test. That's a big chunk of the test. And so being able to look at your candidate performance report saying, I scored low in clinical judgment, and then focusing your remediation on just the NGN case study. So when I make my test, I am working specifically on these case studies, and then within these case studies, making sure, like we talked about, that you're handling the rationales in a way that allows you to learn what you missed, why you missed it, why you got it right, what each of the options was supposed to be teaching you, or what you were supposed to be seeing or thinking about. And then our videos in this is really, really helpful. Is really helpful for you to understand what thinking should have been behind that. So excellent. All right. Okay, Vicky Smiles has some good advice, says don't beat yourself up. Yeah, don't beat yourself up if you do poorly. And I agree. Remember, the NCLEX is a very challenging test, and everyone who passed is still getting about 50% of the questions right. So it is normal to feel challenging. Don't let it feel, don't feel defeated when you answer questions incorrectly. You can miss 50% of the questions on the NCLEX and still pass. So keep that in mind. I think that's great advice. All right. Okay, so I think that's all of our questions. I think we got everybody's questions answered. We just talked about the candidate performance report. Okay, so one student asked about the candidate performance report. What does evaluating outcomes mean? So great question. So this clinical judgment section is broken down on your candidate performance report into each of the clinical judgment areas. And you can actually learn more information about that in our Next Gen course. And so let's see. Within each of the NCLEX case studies, you've got these 6 steps, and that corresponds one step to one question. So recognizing cues, analyzing cues, and so on. This is basically the nursing process. And so if your candidate performance report said that you were below the passing standard in evaluating outcomes, that means that you need to, I would say, go review specifically in our strategy course how to approach a case on evaluating outcomes and get a lot of practice from the case study section of our question bank. So, all right. Very good. All right, everyone, thanks so much for tuning in. This was a lot of fun. I was happy to be able to answer some of your questions, and hopefully you have a better idea and feel more confident going forward. So just big takeaways. Remember, make sure that you're focusing your study, follow the study schedule, follow the study guide, take it one day at a time, review your missed and weak areas, and make sure that you're not letting yourself feel defeated by answering poorly, and you're just kind of leaning into these performance tab results in order to know whether you're ready or not, and then just take a deep breath and know that you've practiced and you've learned all this content and you are good to go. So remember to check out we're leaving a link for a discount code, a 10% discount for you guys showing up today, as well as a link to download all of our cheat sheets for free, even if you are not a current NCLEX Bootcamp subscriber, although we hope that you will be, because we're confident that we can help you pass and apply these principles we talked about today. So thank you so much, everyone, and have a great rest of your day.